काय? काही आणि तरी म्हणजे काय? हां, जोरात बोल, मला ऐकू नाही येते.
Hello, hello. Mic test. Hello. Hello, hello, hello.
check one. Hello, check. Hello.
Hello, check. Hello. Hello, check.
Hello. Hello, check one. Hello, check. Hello. 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 Hello.
Welcome to Fellowship Session 1. The chairpersons for this session are A.V. Ganesh Kumar, P.L. N. Kapardhi, Debabrata Dash, and K. Damodaran. May
Hello, check. Hello.
Welcome to Fellowship Session 1. May we now request Dr. C. Raghu to come.
Hello, check. Hello.
Hello. Check one. Hello. 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 Check one. Hello.
Hello. Hello, check. Hello, check.
Well, welcome all for the 10th live IJCTO Hyderabad. I mean, this is going to be our 10th year technically, though we initiated 12 years back. We lost 2 years in the COVID time. So today's will be the fellows course, and we are starting quite early to accommodate a lot of topics. So without wasting time, I think it's already 2 o'clock. We'll start with the first speaker, Dr. Raghu. Doctor? Dr. John Christopher. Yeah, okay.
A very good afternoon. As we know, CTO PCI is not a simple thing. You need to take up challenges. Presently, we have heavy downpour going on. Some flights have got delayed. There will be a jumbling up of the talks. So kindly bear with us. And with the first session starting today's, Dr. Ganesh Kumar sir is already on the dais. Dr. Kaparthi ji is on the dais. I request Dr. Debrata Dash also to join, and Dr. Damodaran sir to join the dais as chairpersons. Request the first speaker, Dr. Johan Christopher, to start off with pre-procedure CTCAG for CTO PCI success. Subsequently, the chairpersons to take up, with the next speaker being Dr. Rajesh Vijayvargiya. Thank you.
Good afternoon, ladies and gentlemen, and thank you, IJCTO, for this invitation. Thank you, Dr. Kaparthi, for helping us with this. I'll just use a laser pointer if it's possible. Okay. Yep. So, we do know that the disclosure is that I don't do CTOs, I image patients for CTO. Having some issues with the slide. Okay, sure. So we're all aware of what a CTO is, and this is an August audience for CTO. So this is what it is. Once you have that right, we also know that there is a lot of work by 2 of the solvers, Dr. Neil and Dr. Deepak Bhatt, that preparation is the key to success in a CTO. Now, if you look at the 3 colors, the first one is a patient you would just go ahead and do the CTO, and the red one is something that you would not attempt to do and send it to a CTO center where there are very experienced people to do it. But it is in the yellow that you would actually want to use imaging, intermediate kind of difficulty areas, and this is going to help you with planning and the successful execution of the CTO. We are all aware of the challenges of CTO: complication rate, adverse events, failure in tracking, exposure to radiation, contrast, especially in the early part of the curve when you're doing CTOs. So our basic evaluation starts with the echo, and once we have a normal LV function, we look for ischemia. We want to have at least about 12.5% as per the Hasimovitz's data, which clearly shows that PCI is going to help. And if the patient has an LV dysfunction or there is significant wall motion, then you would do a viability plus ischemia testing. And this is, in our center, we do a lot of nuclear scans, stress maybe, to assess both the viability and ischemia. And if there's sufficient viability and sufficient ischemia, you would go ahead with the procedure. The traditional approach has always been to take patients directly to the cath lab, make the diagnosis, see the CTO. If it's easy to do, go ahead and do it. And if the wire doesn't cross, well, no intervention. And we all know that the coronary angiograms have certain limitation. We have an idea right now, it's a luminogram. You need multiple injections, and you need to have an add-on tool like an IVIS or OCT to look for the plaque. We offer something a little different. When you have a patient with a probable CTO, you go ahead with a CT, make the diagnosis, and assess this patient, plan it, and only then go ahead with the intervention. We have a 6-step method by which we use, which I will come to shortly. You should also believe that CTO has a lot more than just a coronary evaluation, and these are some of the things that we do in our lab to assess patients. And it is a very versatile tool. You can look at perfusion, you can look at FFR, and you can look at the transluminant attenuation gradient, very important in patients with CTO. Why CTA? If you look at the JCTO score, which is the angiographic score, and the CT rectus score, they are very, very similar, both in the imaging part, the clinical part, and the prognostic, and we'll come to that later. CT is a great technique if it's used well. You get plaque characterization, calcium versus lipid versus fibrous, and you've got a single data set, 5-second scan, low radiation in the current machines, and you get a whole host of data. The protocol, very similar to what you would do for a coronary. In our center, we have a little more delay because these patients, sometimes because of the low perfusion in the artery of interest, we have a little 2 or 3 second delay, so we're able to image the distal vessel. Important is the preparation of the patient with beta blockers, ivabradine, and sublingual sorbitol. Now, this is what a snapshot of a CTO looks like. So you're able to image the aortic cusp, the ostium, proximal portion, the positive remodeled CTO, small segment of vessel, the negatively remodeled, and most important, the distal vessel and the calcific plaque in that vessel. So you get the whole data set very easily. And we look at various characteristics of this, including the length, curvature, axis, side branches, origin angle, distal vessel caliber, and obviously the plaque character, which is one of the very important things. Now, there's a lot of data coming from 2005, and as the slice of the CT scan has increased with technology, you will find that the correlation and the success rate is very, very good when you use CTA as a preliminary tool in the evaluation of these patients. Now, this is a large Korean multi-center CTO data which used CT, and you can see that they have a point system for various parameters, including the entry site, the branch, the occlusion length. 15 is what they've taken, 45 degrees the bend, severe calcification, including central calcification, we know is a very big problem, can be seen very easily, and the clinical data is also taken, reattempt, occlusion, duration, and then you get a score, and as you're all aware, the higher the score, the more difficult it is. And on the preliminary look on CT, if you have a score of something like 3 and 4, this is certainly for an expert center doing CTOs. On the other hand, if you're a 0 to 1 on the CT, a fairly younger operator can also take up this case. And why I say this is that in the initial curve, it's good to have this, the chance of success becomes more, the chance of complications becomes less. Now, the CT rectus score came in after, and it is a derivative of what the Koreans did. And again, you have a score system, occlusions, blunt stump, severe calcification more than 360, bending more than 45, clinical attempt, clinical duration, and again, you got the 3 difficulty stages. And as you go with the difficulty stages, so is the chance of success low. Now, they have looked at this parameters, and they've looked at the odds ratio, and they found something fairly interesting. So whether it is calcification, whether it's occlusion, they've gone into a lot of detail and got the odds ratio. To sum it up, it basically tells us that if you have a KCCT score of anything about 2, your chance of successfully crossing the lesion in less than 30 minutes gradually diminishes as the score increases. And the chance of you successfully even doing it, forget about the 30 minutes, really rises once you cross the point score of 3. And then when you're looking at the combination of 30-minute crossing versus total crossing, you will see if you're well within the 2 point, your chance of crossing the lesion less than 30 minutes and also successfully crossing is extremely high. And if you cross about 4 or 5, you will see that not only you can't cross it in less than 30 minutes, but you're possibly not going to cross it at all. So it's a great tool both for the diagnosis and prognosis, and helps you choose who is going to do this particular patient. And then if you look at the procedural success versus the ability to cross the guide wire in 30 minutes, again the points correlate. Up to 2, you find that both are very, very good. Your chance of success and your speed is going to be good. But when you cross that 3, you're going to have difficulty both in keeping to time as well as even the ability to cross. Now, 2 patients with a CTO. You can see these are the angiographic findings for both the patients. Most of the patients sent to me have already had the angiogram done. You can see the occlusion here and the occlusion here. Seems a little similar, but just imagine what happened when we did the CT. Patient A has a lot of non-calcific plaque, which is fairly short. 15 mm is what the guidelines tell us, but this is somewhere in that region. And look at patient B, has a long occlusion, and there is a lot of calcific material, and at one point, it's almost 360-degree calcium. So you can imagine 2 very similar looking patients on the angio turn up very different on the CT, and also the difficulty level then goes up. Again, angiographic evidence of RCA, total occlusion of the proximal RCA, no flow at all. We did the CT, we could beautifully reconstruct the entire distal vessel, including the diameter, the length of the stenosis, and also more important, the consistency of plaque, which is more fibrous lipid, easy to cross with guide wire. So this is our 6-step method, and we'll just go through it very quickly. The first one, obviously, is to just identify the CTO. This is the angiogram, that's the circ occlusion, and this is what you see on the CT, multiple calcified plaques, long little lesion, distal vessel small, not a great patient. And this again is an RCO CTO, total occlusion at the right, but you can see that there is a track right there with a good distal vessel reformation. And this is an LAD vessel, completely very small distal vessel, long track, but no calcification. And then the second thing we look at is we predict clinical benefit. So this is a patient whom we did a dual source CT, and we saw that there's significant scar in the distal LAD with dilatation. So whatever you do for this CTO, that's not going to improve. So looking at the clinical benefit is important. For most of our cases, we look at the stress maybe. This is a patient with an ostial LAD occlusion, and you can clearly see that there's a decreased perfusion in stress, but a very good reformation at rest with good amount of residual viability, which means that the pains you take in opening this is going to be rewarding. And this is a patient with both left main as well as an RCO CTO, and you can see that there is ischemia both in the left main and there is also ischemia in the RCA, and both do very well at rest, which means that there is significant viable and ischemic myocardium. And again, this is a patient with an RCA CTO. You can clearly see in a hybrid imaging when we combine the CT and AB pictures, RCA occlusion, and there is a lot of ischemia in the RCA, which means that this patient is going to do well. The third thing is a procedural outcome, and for this, we look at a few parameters: the calcification, the bending less than 45 degrees, multiple occlusion sites, and a blunt stub to start with, and the occlusion length and the remodeling. So these are the 5 parameters we look at. And if you look, this is the patient with an RCA lesion. You can see the long lesion, multiple calcifications. Luckily, the bending angle is less than 45. And then what we do is we pick up these images and load it into the system, in the angiogram, and we trace them and put the lines, do center lining. So this is a patient with a short occlusion, and then we do the tracing, we put the lines, center lines, we correlate it with the CT image, and we are also able to look at the plaque. It's just a partially calcified plaque, discrete lesion, not a big problem, short length, and you get the stent size, the stent positioning, and the success is quite high. Compare this to this patient who has a long LAD lesion. We correlated the CT images, we load those images, we see the track, we see the composition, lot of calcium, and then we see that this patient is going to be difficult to do. And this is just an illustrative example of an ostial RC which was difficult to open, and when we did this CT, we found a big chunk of calcium which required an ablation before you could have success. Most important, when we follow up this patient, CT is a very good tool to look at the stent, especially if they're more than 3 millimeters, and ensure that what you've done is good. I think I'll stop at this if we are running out of time, and I'll be happy to take some questions.
I mean, it's a very important. Hello. as far as, the fellows course is concerned, because learning curve of CTO PCI can be shortened by actually mastering CT angiogram evaluation. Having said that, we faced our initial challenges, both as interventional radiologists, cardiologists, and both of us were not good at reading the CT. Okay, so it took time, a few years for us to sit together and try to gather information. So, there needs a little bit of an effort from us to actually go in and look into the details. What was the last part of it you were saying, overlapping the...
Yeah, there is some software. Siemens has it, and I think GE is planning to come out where you can actually load it into the second screen. You can load the CT data, and then you can superimpose the whichever artery which you have an interest. And they have a software which you can put the lines, drawing the lines, and that is superimposed on the angiographic. But that's not seen in most of the systems.
So you do the CT angio in the CT scan
CT
machine.
scan room. We just load the data. Systole and diastole we pick
and
up.
Bring the data to the cath
Yeah,
lab.
that's loaded into the thing, yeah.
Only
and
the Siemens machine?
Siemens as of now has it.
Anybody is doing that?
Third-party vendors like Circle, vendors like Circle also can enable to do it. You can just have a separate screen also for it if you want.
We can have some question from the Dr. Rajesh.
Yeah, we have this software. It's called Singo CTO from Siemens. We started doing it recently only. It gives a very good tracking of not only the central line, but also the calcification also.
Yes.
So combining calcification and the central line, you can trace the exact path of the CTO and then use your wire strategies also. In retrograde CTO, if you are not sure whether you are reaching the true lumen, this is a very good tool. It gives very good idea. We just started using it only, so it'll take about some time.
Because it's a 3D volume data set, it's very, very good, and
Correct.
you can get the entire track. So your fluoro time comes down, contrast comes down, safety goes up again.
Yeah, there was a pilot study from Mass General Hospital, and they looked at 24 patients with CTO, with this CT fusion guiding, and 24 patients without guidance, and they found this people who use CT fusion, success rate was better than people who did not use CT fusion.
Is it like dynamic coronary map, like
Yeah, something
Rajesh
like that.
here, on the stage?
Yeah, okay. Sorry.
Is it like a dynamic coronary map? Yeah, similar to
it
that.
gives you an exact pathway of your CTU. If in the conventional angio, it's complete occlusion, you don't see anything distally, but this gives you a path to track your wire across.
It is a good modality. When it can reduce the procedural time, contrast, and all these things. In fact, in 2005, when I was in Toyohashi, Japan, every patient was subjected to CT scan, irrespective of the anatomy, whether it is CTO, even STEMI patients were subjected to CT scan.
Yeah, I think one of the important things, if you look at the IJCTO score and the CT rector score, there are two things that stand out. One is the length and the calcification. Both are excellent on CT. All the other parameters sort of fade out if you look at a multivariate analysis. But length and CTO length and the calcification is what really helps, and CT gives that data.
How good is CT angio in predicting instant restenosis, especially calcific instant restenosis and other?
Predicting, I don't have any data.
Imaging CT instant restenosis.
You mean after the stent is put in, then yes. So if the vessel is 3 mm or more, your chance of predicting is very good. Reaches almost 95% in an experienced operator. But at anything less than 3 with the conventional scanners, 2.5, 2.4, or even less, then it goes down to 70-80%. It's anybody's guess. But what is important is that you get to know what is there. So if it is a dark area, low Hounsfield unit, it's more of neointimal proliferation, thrombus, for example. Whereas if it is a bright area, it means there is some calcification that is coming. But the confidence really moves after 3. But I must tell you, I was just in a symposium recently where we were talking about photon counting scans. It's come in Japan and the US now. And there, even in 2.5 millimeter vessels, because of the technology of photon counting, where every individual photon is displayed, you're getting some very, very good pictures in the stent.
What is the inter-observer variation in the interpretation of the CT angiogram between the reporters?
It's high. It's high. If the operator is not trained to work with the interventionist, it's quite high. The second thing is when you're looking at stents, there's a certain kernel we have to take. This kernel has to be decided previously before you go in. So it's a B46 very sharp kernel. So that sharp kernel can actually look through the stent. So you should know what you're imaging, you should use the kernel beforehand, and when you're post-processing, again use it. So the confidence level goes up. But anything less than 3 becomes a little difficult.
Thank you. Thank you.
Thank you. Thank you very much.
May you invite the next speaker, please?
You can invite. I request Dr. Rajesh Vijayvargiya sir to come over the dais and deliver his lecture, Radial versus Femoral Axis. I request that we all stick to some timeline guidelines. No doubt all topics are very interesting and needs a lot long debates.
Good afternoon, everyone. Thanks, IJCTO organizer, for the invitation. And my topic of the talk is transradial versus transfemoral access for CTO PCI. As you all know about, transradial access is preferred access for the contemporary PCI. In today's practice, most of you people are being trained for the transradial access during the PCI. However, for the CTO PCI, traditionally it's a transfemoral approach which is preferred, and the transradial approach is increasingly being used for various CTO operators. The reason are lot many. Few of these important reason to have transradial access compared to transfemoral are reduce the risk of vascular access complication. Adequate support, of course, is there for both radial and femoral access. Operator experience and the preference outweigh the access site selection. For the transradial access, there is a concern about the radial artery occlusion, which can be decreased to the negligible level with the patent hemostasis practice. And for the transfemoral access, you do have local vascular complication, which can be very well improved following the fluoroscopy or ultrasound guided puncture with the use of micropuncture needles, femoral angiography, and of course the use of vascular closure devices. Selection of transradial and transfemoral access also depend on the peripheral arterial disease which can be there in an individual patient. So here are the few cases. The first one is the chronic renal failure patient with the radial artery calcification. Here are following the puncture, not able to push the seat, and this is the patient who of course do require the transfemoral access. Another case, a radial loop which couldn't be straightened up despite putting a wire and also the guide catheter, and one has to go ahead for the transfemoral access. Third one is the arterial luxuria, where though it can be cannulated with the right radial approach, but then a backup support is not so good. And here one can go ahead and use the left radial or transfemoral access. This particular angiogram of arterial dysuria is the angiogram of the aortogram, and also the barium swallow to demonstrate the compression of the esophagus with the aberrant right subclavian artery. The success of CTO PCI is directly related with the characteristic of the CTO lesion, ability to use different CTO tools and technique. And then there are various devices which has to be used simultaneously, and then there are various techniques like antegrade and retrograde, subintimal tracking or dissection and re-entry, parallel wire technique with the intravascular ultrasound help, or using of 2 balloon and 2 catheter are the one where there is need to have a 7 or 8F guide. And in this situation, it's preferable to have a transfemoral instead of transradial access, though the transradial access can also use 7F guide with the seat which is able to accommodate the 7F guide across the transradial. But then there is a concern about radial artery occlusion with increasing size of the femoral, increasing size of the French size for the transradial approach. Access site bleeding, of course, is higher with the transfemoral access, and when it's very common with the CTO operator to use the long sheath along with the guide catheter, and of course the ACT is on the higher side in this patient of 300 plus, and then there is a risk of the increasing bleeding complication. For any CTO operator, a balance between the radial and the femoral access is what is required. This is about the advantage and disadvantage of the large guiding versus the smaller guide catheter, which can be extrapolated for both transradial and transfemoral access, as there is the advantage of 7 or 8F guide to be used with a transfemoral access. There is a risk to have a higher bleeding, but the backup support and use of various devices simultaneously is more feasible and accessible with the transfemoral compared to transradial access. This is the case about the mid-RCA calcified CTO, where it's an active support of the AL1 guide with the transradial access, and then one can use the guide liner to have an extra support, which was used in the index case to put a 2 overlapping stent in the mid to distal RCA. The another case, anomalous right coronary artery with transradial access, it's a AL1 guide. The lesion couldn't be crossed with the balloon. Tornus device was also not successful. Ultimately, it's the Rota 1.25 bar which was used to open up the mid-RCA calcified CTO, which was assessed with the OCT and had no stenting done from proximal to distal RCA. So this is one of the cases out of the 35 cases of PCI series which we have published in Asia Intervention. So what are the limitations of the transradial access? For the fellows, yes, a learning curve is there for the transradial access. 7 and 8 guide is the one which cannot be used. Of course, the 7 can be used with a glide sheath across the radial artery. The patent hemostasis practice has to be used in case one is going to use the 7F guide with the transradial access. Mother and child technique can also be helpful in this patient with the transradial access. For the active guide catheter support for the RCA CTO, one can use the left radial, and for the left coronary CTO, one can use the right radial to have extra backup and extra support during the CTO PCI. Whenever there is a passive support which is highly recommended or highly required in those with the ostial or the proximal CTO, it is preferable to have a transfemoral access compared to transradial access. Regarding the transfemoral access, there are the limitations mainly because of the local access site complication, and then there is an inconvenience to the patient because of delayed mobilization, inconvenience, prolonged hospital stay, and also the hospital cost. And what the literature do suggest about transradial versus transfemoral access, this is the randomized trial being published in 2022, about 600 patients. It's a 6 or 7F radial access or 6 to 8F transfemoral access, and then for the transradial access, it's an immediate sheath removal versus transfemoral access, it's a manual removal after 6 hours of the PCI. If you compare between the two arms, the major JCTO, progress CTO, and progress CTO complication score were similar. There was a similar use of retrograde approach in both the arms. And then transradial access was found to be non-inferior to transfemoral access as per the procedural success is concerned, and had no fewer access site complication. While there is no difference in procedural duration, contrast volume, and radiation dose. Another randomized trial about complex PCI, where around 58% of the lesion were CTO with the JCTO score of 2.1, and the local hemostasis was either controlled by the TR band for the transradial or vascular closure device with the transfemoral access. And if you see the access site complication, it was significantly less with the transradial compared to transfemoral access. And then there is no difference in the procedural duration, contrast volume, or radiation dose. And now there is some systemic review which is also available about the 9 observational study and 10,000 patients. Again, there is similar technical success, whether it's a transradial or transfemoral access, lower risk of access site complication, and similar MACE rate in the two arms. Another meta-analysis of 11,000 patients with a higher JCTO score in the transfemoral compared to transradial, and therefore there was a better procedural success rate with the transradial compared to transfemoral in this particular meta-analysis, where the vascular complication was less with the transfemoral assess, and rest of the parameters were more or less same in both the arms. Another meta-analysis of 19,000 patients, similar finding was observed, lower access site complication, procedure success is more or less similar with a similar maze and contrast-induced nephropathy. This is about the 28,000 patient CTO PCI, which has been meta-analyzed with a JCTO score of 2.3, and the transradial assess was associated with a significant reduction in the assess site complication and major bleeding with a similar risk of in-hospital maze and 30-day mortality and less fluoroscopy time and contrast volume with the transradial compared to transfemoral assess. Then there are a few cases. This particular case, a long LED CTO been treated with the anti-grade wire escalation, and it's a distal 7F guide was used, and this is helpful to have a final kissing across the LED D1 and a good flow across the left coronary system. It's very important when one is going to use the 6F seat in a bifurcation lesion that what hardware has to be used. So this particular case is the LAD and D1 disease with the LAD CTO been successfully treated with the 6F transradial assess and bifurcation stenting. This particular case, it's again a transradial assess with the 6F guide and a parallel wire technique, the mid to distal RCA CTO been opened up nicely. And the last case, this is something unusual, the right aortic arch patient. You can very well appreciate in the first cine how the wire is going, which is something rare. So right aortic arch, and this patient had a transradial angiography from the outside hospital where there was a difficulty in cannulating the left coronary, and therefore it's a transfemoral assess, and we had a successful PCI of the LAD. So take home message, the assess site complication is significant and important consideration during CTO PCI, which is frequently ignored and also underreported. Transradial assess is emerging as an alternative to contemporary transfemoral PCI with similar success rate and 30 days maze. Though the complex CTO PCI transfemoral assess is still preferable, but it can be very well can be done with the transradial assess as well. And as a fellow, I would say that one should be acquainted with both approach and preferably choose transradial assess whenever feasible and possible. Thanks for the kind attention. So most of the time it's a transradial assessment, which I do prefer, but then whenever it's a complex and I can very well shift to transfer most of my PCI, I would say around 85% of all the PCI I would prefer to go with a transradial, and 15% is the one where it's a
even for high JCTO score.
Yes.
Okay. Because
there are a few cases which I had
because once nowadays these local vascular devices are available, I think because large bore is needed, especially for supports and high JCTO scores, I think femoral approach is mainly preferred by majority of the operators.
I would say whenever one's, as an experienced operator, whenever one feel like that there is a technical difficulty with the transradial, which of course is going to a maximum of 7F, it's preferable to go ahead with the 8F transfemoral approach.
Thank you.
It's very interesting that you show that large meta-analysis of those 28,000 patients. The radiation as well as the contrast and the procedure time is less with transradial compared to transfemoral. I mean, I just want to know from the people in the audience and my Japanese colleagues if they are there, is it, I mean, in your own, do you really feel that complex subsets of CTO PCI, the actual radiation time and contrast and the procedure time will be less in transradial? I mean, how do you justify that?
No, it's one of the meta-analysis which has shown that there is a difference between the, but most of the rest of the meta-analysis has shown it's more or less similar. And I would say regarding the fluoroscopy time and also the contrast, it depends on the operator experience, how comfortable he is to go ahead for, and therefore it's a variable. But then, yes, Japanese colleague can very well comment about what's their routine practice vis-a-vis European, which Japanese do prefer to go ahead with the more transradial vis-a-vis European, which do prefer for transfemoral approach.
Apart from the radiation exposure, being a fellowship course, can you please enumerate some of the good backup guiding catheters for a calcified CTO in these patients?
So,
your choice.
No, it's as I mentioned about EBO is the one which is a good guide catheter for the left cone system, and it's the AL1 which has to be used for the RCS CTO. Yes, as a fellow, one can use the AL guide for the left as well, but one has to be careful about the left main and left dissection with the AL, which of course is not so frequent a complication with the EBU guide. For having a passive support, whenever there is a proximal lesion, proximal or ostial CTO, it's preferable to have a transfemoral access, because there is no need to have an active support, which of course can be given by the transradial access. So whenever there is a proximal CTO, when there is only need for the passive guide catheter support, it's preferable to go ahead with the transfemoral approach.
Only one question.
Yeah, Rajesh, very well delivered lecture. I just feel that fellows should not go with the idea that we should do transradial. Idea should be we should do transfemoral primarily. And in few cases you can try transradial, but people who are just starting the course, it's not possible to do transradial with a good backup support. You can do transradial only for the dual injection, but primary vessel to be opened should be transfemoral. This is what I feel personally. Your comment now.
Yes, you are right. Being a experienced interventionist and routine practice of transfemoral access, but then as you have seen the data, the improvement in procedural success is similar, and then the vascular complication, which most of the time has been ignored. With transfemoral access, you have a long seed, ACT more than 300, procedure time is too much, patient is inconvenient with both the femoral artery being cannulated at certain stage with the convenience for the convenience of the patient to improve the vascular complication. One can very well go ahead with the transradial access as well.
Thank you. Thank you for your nice talk. So next speaker, please.
While Dr. Raghu is setting it up, I mean, I see my DNB students, they are very good in radial punctures, which we were very bad 25, 30 years back. And when they actually struggle in femoral punctures.
It is across. I have been training so many people. It's difficult for them to get a venous access, difficult for them to get a femoral arterial access. It's a common thing. Yes. It depends upon, I think, it depends upon how expertise the operator is. Yeah, that's all, I think. Okay. Good afternoon, audience this afternoon, and my chairpersons. Today, I am going to talk upon my toolbox in CTO practice. I will show you certain clinical scenarios and what would be my choice in certain scenarios. I start with the simpler cases and go on with this is a patient who has got an anomalous right coronary artery from the left sinus, and you can see that there is a total occlusion. I took a normal coronary guide wire, and if you can see, the normal Fielder FC, which is my workhorse wire, is unable to traverse that CTO. So what did I do differently? So then we went on. You can see this is the microcatheter. My microcatheter of choice is a Caravelle, and you can see that we changed the coronary guide wire from a Fielder FC to a Fielder XTR. So in patients there is an antegrade collateral channel, it is always essential for us to use a microcatheter and use a low tip load wire and a tapered tip wire, that is a Fielder XTR. So that is what is my choice for these patients. Now obviously with this thing, obviously the result would be good. Now, what are the differences? An XTR has got a tip load of 0.6, which is not the least but one of the lowest tip loads, and it is a polymer jacketed wire, and the tip is a tapered tip. So, this should be used when there is a subtotal occlusion like what you have seen in these patients where there are microchannels. So, when there are microchannels, you use a support with a microcatheter and use an XTR wire. But the only thing when you should be cautious is when you push the XTR wire, even though the tip load is low, because it is a polymer jacketed wire, you can cause a perforation. So, one needs to be careful. So, compared to XTR, XTA and Fielder FC, you can see the different characteristics of the various wires. Now, we go with a chronic total occlusion with a blunt stump. You can see here in this patient who has got an LAD total occlusion, no retrograde collaterals and no antegrade collaterals for this patient. So, so it could be a recent occlusion which could be an acute on a chronic total occlusion, which was what I thought. And then, so what I will do for such patients would be to use a microcatheter as I showed you, and then we used a, for us to go up to the lesion, we use a normal workhorse wire, and once you reach the lesion, you exchange the the wire in the microcatheter with a higher penetration wire. If you can see, this wire was not crossing, and you can see the wire was buckling. So, at this point of time, we changed it into a little higher penetration wire with a Gaia second. So, for example, if you are not able to penetrate the tip of the wire with a normal workhorse wire or a Felder XTR, then if there is a blunt stump, you can use the penetrating wire to enter the CTO lesion. The lesson from this case is, once you entered into the CTO lesion, use the advantage of the microcatheter and change the wire tip load to a lower tip load wire. Here I used a Felder FC because that is my workhorse wire. Otherwise, you can use a any other workhorse wire what you use in your cath lab. So, once you enter the CTO, and after that you might have to change the lesion. So, this is, we changed from a Gaia second to a Felder FC. So, de-escalate the coronary guide wire after entering the CTO body if your first wire is unable to cross. And another advantage is, once you have the microcatheter, you can change the shape of the direction of the tip of the wire. That is very important. Whenever using a Gaia second, the directionality change is very advantageous. So, this is the final result. Now, Gaia's first, Gaia second, Gaia third or tapered tip wires, these are the tip loads, and they have a 1:1 torque controllability, a conical tapered tip, and this conical tip is uncoated. So, you don't need to, you don't go subintimal. So, you should, you can use this Gaia as the second choice of wire if your first wire doesn't cross. Now comes the new generation of wires, that is the Gaia next wire. You have got Gaia next 1, next 2, next 3, next 4. These are also tapered tip wires with varying tip loads. The Gaia next 1 is used for controlled navigation within the CTO. It is deflectable wire. As you go further forward, Gaia next 3 and 4 are high penetration wires. But the advantage from difference from the Conquest or similar is, you can change the tip direction with a Gaia, whereas you cannot change the tip direction with a Conquest. The advantage, one more advantage of a Gaia next over a Gaia family is, the traditional Gaia family is, they are more durable wires. And you can extend this, they have got an extend coil, so you can torque it and go within the wire, and you can do counterclock to torque the direction, and if you go clockwise, then you will be able to redirect the wire to the other direction. So, these manipulations we need to understand to use the Gaia second. Now, sometimes like in this patient, I had a CTO, he had a circumflex lesion, and you can see the diagonal is filling, the LAD is not filling. So, what we did, you can see this is the importance of a retrograde angio. You can say a contralateral angio, contralateral angio to see the retrograde filling of the coronary. You can see the LAD is filling, but if you can also realize that the stump is very short. you can see the antegrade filling, and then there is a short length of the CTO. So we were going into the diagonal. So we went in from the diagonal to the LAD. Once again, in this case also, we penetrated the CTO with a Gaia. You can see the Gaia is going into a different plane. Deflect back the Gaia into the true lumen. This is once again with a wire like a Fielder XTR. So you should not shunt to change the wire once you enter the lesion. So obviously the result and all that, this is the good result for this one. Now I will show you one more case with the instant restenosis. We used a normal wire, and with this normal wire, it did not go. Then we chose a Gaia second, it did not advance. So then what did we do? We used a Conquest Pro with a microcatheter support, which is a Caravel. So Caravel, we upgraded from this one to a Conquest Pro, and we could cross the lesion nicely. And then this instant restenosis, we had to dilate with because the track is very small. We used to use a specialty balloon, Alveo HP, because we can go to very high pressures up to 26 atmospheres. Then followed it with an IVL, and we used a drug-coated balloon for the angioplasty. So then I will show you the final result for this patient. So this is the final result for this patient. Long-standing ISR need a drilling strategy. Drilling better is with Confianza. The new generation wires are the Gladius wires. Alveo HP for short balloons with high pressure, because RBP is 24 atmosphere. Use of a guide extension catheter was also used. Guide plus 2 we used in this case. CTO instant restenosis, we have a vessel course is known, so we need to change it differently. So what are the various wires? You have got Ultimate Bros 3, Confianza Pro 12, Gaia, and Gladius. Gladius and what we call the course of the vessel is not known, and Ultimate Bros. These two we use for the ambiguous CTO route. But with Confianza and Gaia, we need to know the course of the vessel. So you have got different, some are tapered, some are non-tapered. So this is a way how you have to choose the wire based upon that. Similarly, we have got 4 or 5 different types of low profile balloons. I will mark that HP is a high pressure balloon. Now, for a retrograde PCI like this, there was a lot of discussion, like a single catheter with a transradial. Here we were crossing a ostial CTO from antegrade, it did not go, and with a Sion. And then what happened was, once we crossed this lesion from the retrograde axis, the microcatheter did not go. So the use of a microcatheter, if you want to use through a very tortuous microcatheter, sometimes a fine cross is better, whereas for the rest of the things, my workhorse is a Caravel or a Corsair Pro or Corsair Pro XS. The fine cross has got the very large internal lumen, whereas Corsair Pro XS has got the smallest external diameter. So this is how you have to choose your various catheters. I think I will show this, the last case where we can show the retrograde axis, and we can take some questions. We used a Suho 3 for the retrograde axis, and retrograde we use a Corsair Pro XS. We can use the J channel score for using which one, and once we go in, we cross with a Suho 3 wire. I will just end up with showing what is a Suho 3 wire, and in this patient we went retrograde, and from there we crossed antegrade to get into the true lumen. So what I wanted to show you is, this is the final angiogram for this patient. In the Japanese registry of about 900, retrograde axis, Suho 3 was the best choice for all groups, and retrograde non-septal 67%, retrograde septal collaterals it is 40%. Suho 3 is the lowest tip load. We can use it not only for retrograde axis, but also for patients like SCAD. I think with this, I would just try to show you about 2, 5, 6 cases, what would be the hardware choices for different types of scenarios. Thank you.
Raghu, this is a very important topic, so let's have some questions from the audience, because that in fellows course is a complaint that their questions are not heard. I mean,
Yes.
So this topic is so important. This will carry forward for tomorrow. So I invite people to ask questions because wires and all these are very important things. If you have any doubts, please ask.
And with these so many wires, we
Please come forward and
many
ask
times
questions.
it will be confusing, Dr. Ganesh, which
Otherwise-
wire for which lesion.
Yeah. Otherwise, don't complain tomorrow that hey, the fellows course was rushed up.
So please explain about some pilot family wires. Can
But-
we use for looping,
I couldn't get
making
so.
a
Who's
knuckle?
speaking?
So I'm Dr. Nilesh.
Yeah, Dr. Nilesh.
I wanted to know something about the pilot family wires. And
Actually, yeah, so the pilot wires are there for very long time, Dr. Nilesh. 50, 100, 200, 3 generations of the wires were there, 3 different iterations of the wire are there. Right now, I do not use pilot for many, many years. I think 2 decades I stopped using pilot. Only thing is when you want to go subintimal, people take the pilot to 200, subintimal and then antegrade dissection and re-entry, people use as a knuckling wire the pilot 200. Otherwise, I think we should move on to the new generation wires rather than, because the new generation wires have come with so many wonderful characteristics. Oh, it is a totally different wire because I think actually I used Fielder FC for almost 17, 18 years. So yesterday when I was reviewing, Fielder FC is a older generation wire, outdated wire. So I am thinking, am I outdated? So Whisper and Pilot are before that, 7, 8 years before that. So I think we should move on from the Whisper and the Pilot eras, because these are polymer jacketed wires. The resistance is very low. You can nicely go through any vessel by using these Asahi generation of the wires that they like either Fielder FC, XTR, nowadays Cyan, Blue, Cyan. So those are the wires I think which we should use in the current era.
To be frank, the pilot nowadays they are used for especially the knuckles. Actually, it is used for the high IJCTO scored CTOs. For knuckles, actually, it is using a pilot or a de-escalation. Once it is or stick and swap technique after ADR also, you can use this pilot after sticking into the true lumen from the extra plug. So these are the restrictions of pilot nowadays in the CTO interventions.
Nowadays we have to see whether you have got a channel, use a tapered wire, no channel, non-tapered wire. Polymer jacketed versus non-polymer jacketed. Hydrophilic, tip non-hydrophilic. Like that we need to understand every wire, and every day we learn lot of these wires and color coding of these wires, because once we use many wires you should know which color casserole is the wire, which wire. It's very important for us. Similarly, we should use the microcatheters also. Different types of microcatheters are there. Caravelle, what we call Corsair Pro for antigrade one, Corsair Pro XS for the retrograde axis. XS is small and Corsair is for the Corsair Pro is for the antigrade one. So these things we need to know. Similarly, smaller balloons, CTO balloons, you have got the semi-compliant ones, but when you use a semi-compliant balloon, the balloon can burst. You do the granuloplasty. But you have to use a HP balloons or a higher pressure balloon so that you get a better outcome. One more thing which I did not cover is you should have a low threshold to use a guide extension catheters for any of these CTO angioplasties to get a better success rate. And that, yeah, thank you.
This Caravelle catheter, sometimes it catches the stent.
Yes.
So I think you can use other catheter instead of whenever you have instant resistance. That is one. Second, about pilot 200 also now is not used for knuckling. We have now Gladius move.
Yes.
And for non-CTO lesions, pilot is still very useful wire. I mean, after choice PT, I can tell for non-CTO, pilot 50 is our second choice in cath lab. Apart from run through BMW and all workers. That is my comment.
Yeah.
Regarding
yeah, complication management tools, because it becomes a full day session.
Yeah, one question regarding crossing channels through the retrograde PCI. What is your first, second, third choices for the wire? And
we have a retrograde section, but one answer
first, second, third
one
choices
answer
for
is,
your
as you
microcatheter.
can see, SUHO, XTR and Xeon. These are the three common wires which are used in the Japanese registry.
And microcatheters, 1, 2, 3.
Microcatheters, it depends upon whether you are going through a retrograde, it is a Pro XS, antigrade, it is a Corsair Pro, and if you want to go sometimes through a septal or epicardial collector, you can use a Caravelle. Sometimes if it is very, you want to have a larger lumen diameter, then you use a fine cross, larger lumen diameter.
We can go for the next speaker, Dr. Ajit Pillai. This is a very important topic what he spoke. Next, I think next IJCTO we should keep half an hour for this topic.
Good evening all. Sorry for the delay, the flight delay. So my topic is slightly has to come a little earlier. This is basically how to analyze angiogram for antegrade and retrograde PCI. So angioanatomy is very important. CT is fastly catching up. All of us old-timers still do a heavily rely on angioanatomy for success as well as for retrospective analysis of failed CTOs. And always do a bilateral gear. It is extremely important. Single angio sometimes give us a clue of success, but always do a bilateral axis. Long sheaths, bilateral, one femoral or two, one radial and one femoral. I take usually bilfemoral. Never compromise for support and take 7 front guiders and always use microcatheters. So basic tips. Angio views will come to in detail. Take the scout images with clear idea. Always perform angiogram with an intention of doing CTO PCI. Don't just finish off. The moment you see CTO, just keep taking detailed views in orthogonal views and fix a gantry in the same angles for wire advancements. Okay. So spend time in the console before you plan a CTO PCI. And before you scrub, always assess the following points: length of the CTO, proximal cap, distal cap, angulation, tortuosity, and of course, most importantly, calcification. Always think of retrograde gear whenever the length of the CTO is more than 20, heavy calcification, ostial flush occlusions, that is ambiguous proximal cap, previous attempt and failed antegrade, extensive subintimal tracking during previous attempt, and of course, when there is a major bifurcation to prevent side branch closure due to side branch injury. So the key performance indicators are dual injection, select optimal projections, set up images, mag drop magnifications, no panning, please no panning, very important. Sequential injections, there's an ideal view, you just inject, there is an proximal RC occlusion. It's a very clear-cut case for retrograde. Longer acquisitions, very important. And of course, one has to be very clear about the judicious use of radiation and contrast. So this is a very typical example, So this is a very typical example of an RCS CTO. Seems very kind of tempting, but it is not. The moment you do retrograde, you understand that it is a very complex CTO and the retrograde gear hardly filling into the crux, and this is actually the vein. Okay? And this ended up in having a very complex CTO of the right coronary artery. This is a CT image. So never be very tempted with a very thing, ended up in a retrograde PCI. So optimal projections, this is for the fellows. So I'll go a little slow and then when I catch up the time, I'll stop it. So RCS CTO, the optimal angles are LAO 30. This will tell us the proximal cap, the RCA course. This is a regular LAO 30 only, regular LAO, shallow LAO for the RCS CTO, proximal RCS CTO. You know proximal cap, RCA course, distal cap and lesion length. Please understand, proximal cap, distal cap as well as lesion length, and if there is any tortuosity. These are the things you should know. Now let's come to the cranial. Again, distal RCA, you look for a cranial view. So LAO cranial, this is for the distal RCA. You see the distal bifurcation. See whether the distal cap is at the bifurcation involving one of those branches, PDA or PLB. Then obviously you have to think about retrograde for salvaging one of those branches. And of course, circumflex PLB collaterals, very dangerous retrograde axis. These AV Guru channels, we can actually visualize in this view. Now, for septal collaterals, let's say we are looking at septal collaterals for an RCS CTO, RAO cranial is a better view. Now, RAO 30 degree will tell us about the proximal cap. This is again, so we are taking LAO30, we are taking an RAO30, basically if you look at the orthogonal views for proximal cap, tortuosity, and of course septal collaterals. So this is for the RCA CTO. Now let's come to the LAD CTO. In LAD CTO, again, classical LAO caudal, which is basically a spider view or an RAO caudal, which tells us the proximal cap. You will know whether there is a nostril flush occlusion, and of course the lesion length, very important. Please understand, proximal cap, lesion length, distal cap, 2 additional points, tortuosity, calcification. That's 3 plus 2, 5. Those are 5 points we should look for, all the fellows. LAO cranial, we know that LAO cranial, what you do for a dominant circumflex, for a distal cap of LAD. If let's say is a proximal to mid LAD CTO, LAO cranial will tell us as the distal cap. And of course the bifurcation, whether there a major diagonal is involved and the CTO length. Now in RAO cranial, needless to say, we know mid to distal LAD, distal cap, septal collaterals, distal length. In RAO30, you see the septal collaterals. Okay, so septal collaterals always RAO will help us better, whether it is an LAD or RCA. Okay, now let's see circumflex CTO, most difficult one. Now AP caudal, shallow LAO or shallow RAO caudal will tell us the proximal cap. It's very simple view. In LAO cranial, especially in the dominant circumflex, we tell us the distal cap. We also see at the PLV circumflex collaterals, AV groove channels, and of course diagonal to OM collaterals. These are epicardial channels, diagonal to OM collaterals. Okay. Now let's come to RAO caudal view. What do you see? Again, it's similar to PA caudal. You see proximal cap, distal cap, PLV circumflex collaterals. It's a basic our first year DM angio revision. Okay. Then RAO30, you see septal collaterals to LPDA. Please again, you see always septal collaterals. You see, you come to RAO30. Okay. That's it. Now, so please revise proximal cap, lesion length, distal cap, and then of course look at the collaterals. So here I think what you see, ambiguous proximal cap. This could be a bridging collateral, we don't know. And you will also look for whether it's a blunt or tapered. Or then going back to the JCTO score, whether it's a blunt or tapered. It will determine, like Ganesh was telling, this will determine on the choice of wire also. And whether you also see as whether it's a side branch at the proximal cap. Okay, your wire may go deviate. There may be a possibility of using IVUS in the proximal side branch. Of course, you can always use an anchor balloon also. And of course, we look for the calcium, which to a certain degree, angio will help us, but sometimes CT may be required, as in the case I was shown. Again, proximal cap, we will discuss this. Distal cap again, blunt or tapered, is it at a bifurcation? Size of the distal vessel, is there a distal disease beyond the distal cap? All those information, we can look at the distal entity. Yeah. And the occlusion length, very long occlusions like the one I showed, obviously it has to go. So at some point of time you may go subintimal. You have to prepare. Maybe your Gaia next or Gaia may go through, but then you need to prepare mentally that you need to be ready for a retrograde gear. So collateral assessment, let's spend 2 minutes for this. Collateral pathways are plenty, and you should know from where to where, which are the collaterals which are malignant or treacherous, and which are the collaterals are virtually safe, especially for an operator who wants to start the retrograde work. Now, I will just simplify. There are septal collaterals, there are AV groove collaterals, of course bridging collaterals, very dangerous one, never try to track those bridging collaterals. So you should know which are bridging collaterals so that we can avoid them. Then there are apical collaterals, which can be sometimes very kind of, tempting to go. Very dangerous, tortuous, we have to be extremely careful. Apical LAD to PDA, then PDA to RV branch, again very dangerous course. Then RA branch to distal RCA, so called the Krugel's artery from the left to right or from homocollaterals. So these are some of the collaterals which are looking for this. Then collaterals pathway likely to be seen in LAD CTO, again same, septal collaterals, then OM to diagonal collaterals, RV branch to LAD collaterals, diagonal branch to distal LAD, homocollateral, then RA branch to LAD as well as proximal LAD to distal LAD. Homocollaterals, we are not very experts, I've seen Japanese operators, but still we can try, especially homo AP is a little difficult one. Okay. And now circumflex, this is the most difficult CTOs to among the three. Again, epicardial, mostly circumflex collaterals are epicardial collaterals. We have to be careful. Most common we try is actually diagonal to OM. Sometimes AV groove channels, dangerous ones. Bridging, no. Then OM to OM collateral can happen. RPDA to OM collaterals can happen. And also RA branch to distal circumflex collaterals can happen. So these are the collaterals we should be looking at. And angiogram evaluation should also look at the angle of exit and angle of entry. Very important. if it is more than 90 degree or is less than 90 degree. Acute or obtuse. Obtuse is always better. Acute angle is always difficult to take your wire and microcatheter into that. So collateral score, many others have published. We don't go into detail. Basically, you look at type, size, exit angle, tortuosity, etc., etc. But please understand there is something called entry angle, exit angle. So it can be septal. We describe collaterals as septal canals, epicardial channels, SVG to donor vessel, lima to donor vessel. Okay, I'll rush through this. Score is given from 1, 2, 3. 2 more minutes. I'll just cross through. CC2 is a direct chair connection. CC1 is actually a thread-like connection. But CC0 is something which we don't recommend somebody to start with, because we may very obviously go out of the vessel course. So this is the exit from the donor vessel. Again, very simple to understand. The score is actually in the reverse direction. The more difficult, the higher the score. Okay, obtuse angle, no bifurcation. This is, please understand, this is the exit actually. Obtuse angle is always favorable, acute angle is difficult. And of course, if there is a bifurcation, let's say LAD to RC, if there is a PDA, if your collateral is joining within 3 millimeter of the PDA PLB bifurcation, it's very difficult. Okay, let's go to the next. Collateral tortuosity is another something which we should look for. If there is a very big collateral tortuosity, now we have 003, Caravel, everything we can just get in. But again, please understand that the more the tortuosity, more will be the difficult part. I'll just stop in after finishing 2 more slides. So obtuse angle, again, entry is again obtuse angle, acute angle, and of course tortuosity. All these things you should look for. And collateral direction also, we should be looking for which way actually the channels go on. So depending on that, we can actually score it. But for an experienced operator, we don't spend time in scoring this, but we know actually all this will figure into our mind when we actually start this retro work. But obviously, for somebody who want to start it, it's better to know all these things so that they know what actually they are working on. Epi again is same, but please understand Epi is actually dominated by the tortuosity, the size, exit and entry angle. Always the principle is the same. Classification principle is same. The epicollaterals are classified in the same category, but these are the ways it will be classified. Tortuosity is very important element. Then we'll come to SVG and lima. We don't discuss much. I'll spend a word here. SVG collaterals are assessed based on whether it's patent. Most of these SVGs are occluded, but sometimes there can be degenerative disease, but still it may be patent, or sometimes it can be an occluder. Please understand, through an occluded SVG graft also, we can actually sneak in a Caravel or a Corsair and get our job done. So that's why this has been marked into this classification. And of course, anastomosis angle. Please understand, obtuse is favorable and acute is unfavorable. And again, anastomosis within 10 millimeter of the distal cap is actually more unfavorable. This is actually a typical example of an SVG collateral we have marked, which where the score is actually put is like this. So these are an easy way to understand how the collaterals are looking at. So let's go to the lima. It's very interesting thing. Lima always better to know that never try to do a lima unless you have a tremendous amount of experience. So lima is a very dangerous. That's why the score has been put in Jeopardy score. You never try to dissect the lima. Nothing should happen to lima. It's very important. So try to avoid it, but again, the score is like that, exit, entry, angle, and also depending on the septal location, these have been classified. Okay? Ganesh, with that I will stop, so that we have time.
I'm very good, a lot of information in this. We will try and share the slides with all of you. Somehow we'll try to reach and give all these fellows topic slides so that this will be with you. I'm critical of 2 situations that we face day in and day out. One is when angiograms are done and you're looking at a CTO, you just take a very short single shoot, and then we talk about doing a CTO angioplasty. When these CDs come to you, you end up doing an angiogram all over again. I mean, the patient says, I tell the patient that I have to do the angiogram again because you cannot make out anything, right? The second critical thing, or I want to be critical, is many of the operators, when they want to start a CTO program, we don't want to do bilateral injection. I mean, that's laziness. You want to do a CTO angioplasty without seeing the distal vessel. I mean, if you get success, it's just a chance that you're getting a success. So you have to do a bilateral injections. Unless you see the distal vessel, you should not attempt a CTO angioplasty, however simple it looks, correct?
Yeah.
Yeah, these are the two most important things I want to give a
Yes.
message.
I think all of us have learned it the hard way. And the simple way I will put it, actually, all the cases which we do and which we fail, when we go back, we understand that we have something in the anatomy which we missed. So that tells us that probably we should spend more time in planning rather than in execution. So this is telling from all the experienced operators saying that when you fail, then only you know. Starting from patient counseling, everything as Dr. Ganesh was telling, it is very important. If you do a dual injection, understand the anatomy, then you can know your predict your success rate. And accordingly, you can counsel the patient, family, and get motivated yourself rather than failing. And the failing always demotivates you. After 2 hours, 3 hours of work, if you fail, it demotivates you and the team. So don't do that. Get a clear understanding of the whole picture, then you know, okay, this is the chance I can succeed, this is the chance I may fail. So if you fail also, you won't repent on that. Thank you.
Thank you.
Thank you.
So much.
The slides are there with Dr. Kantilal, so if you want, you can get
Yeah,
it.
I think we'll, Dr. Kantilal, at the end of the meeting, you have to share all these slides of the fellows course with you.
Yeah, sure, it will be shared on the email. Thank you very much, chairpersons, Dr. Ganesh Kumar, Dr. Kaparthi, Dr. Dash, and Dr. Damodaran. I see the heat has started of the fellowship program. We go ahead with the session 2. May I request the chairperson, Dr. Raghu, Dr. Ajit Pillai, Dr. Syed Imamuddin, Dr. V. Rajshekhar, and Dr. Lachuman Das to please occupy the chairs and take forward the session. Dr. Sudhir Rathore has already come, so he will start off with his first lecture. Request the chairpersons to please occupy the dais.
He is there. He's too fast. He doesn't need any invitation.
No invitation required in a home meeting, yeah. Thank you, chairpersons, thank you, organizers. Sorry I was a bit late, but I've been given a task to talk about popular CTO crossing algorithms. So if we look at aims of any angioplasty, the aims of the angioplasty is to successfully recanalize the vessel safely, whether you integrate, retrograde, ADR, whatever it is, and try to avoid complication. And in the event of failed intimal tracking, you try to minimize the subintimal space. And then after doing the procedure, you put stent, you put balloons, you put whatever, balloon POBA. The procedure should be durable, and with image-guided optimization is good. So what does the algorithm do? CTO algorithms allow CTO procedures to be done efficiently and safely and are based on experience of the experienced operator and the historical data. There is no randomized trial or anything like that, but obviously the younger operator can use the experience of the people. So obviously for anything like success CTO PCI, you need to know your CTO first before you can recanalize the vessel. And there are several ways to do a procedure. It's not like I do integrate. The aim should be to recanalize the vessel successfully. So coming on to the algorithm, how do you work out the algorithm? So you have to always take a bilateral angiogram, and you have to define the cap. Where is the proximal cap, whether it's ambiguous, blunt, or tapered? Then is there a branch at the proximal cap? Then what is the quality of the distal vessel? That comes in the algorithm, whether it's a disease, diffuse disease, or healthy, or is there any bifurcation? Then the presence of interventional collateral, ipsilateral, contralateral, septal, epicardial. Now interventional collateral which you can use, or you can do it based on your expertise. And then the less important things are what is the true length of occlusion, calcification, tortuosity, angle, inside, outside. Those things are a little bit less relevant nowadays. So this was the first algorithm which came early in 2010, or later on 2011, 2012, based on dual injection. And then you decide how your cap is, how the distal target is, how the collaterals are. If they are all favorable, then you go antegrade, that's say, because the chance of success is better with antegrade. That's what they meant. And when you go antegrade, you do antegrade wiring, and if the length is more than 20, this algorithm suggested that antegrade wire escalation may not work, and you have to go antegrade dissection re-entry. So some people will deliberately, as a first attempt, go in these cases based on other people's experience. And if there is an ambiguous proximal cap, target distal is not good, and there are good interventional collaterals, then you can sometimes primary go retrograde as well, and then retrograde you can cross to true lumen, or you can do a dissection re-entry. So this was the initial algorithm, which is based, also called hybrid algorithm. So you quickly move from one strategy to other strategy based on this algorithm. There's no point carrying on with anti-grade wire escalation for two hours. The proximal cap is ambiguous, length is very long, distal vessel you can't see. It's not going to work. And then came, obviously, a lot of algorithms came between that algorithm and this algorithm. There was the Asia-Pacific algorithm, there was the European CTO club algorithm, but this is the mother of all algorithms, or we may that it is combined by all the experienced operator called Global Chronic Total Occlusion Algorithm. A couple of years back it was published. Same thing here as well. If you see, you take dual injection here, then you look at proximal cap ambiguity. The things have been progressed since the first algorithm came. If the proximal cap is ambiguous and there is a side branch, you use intravascular ultrasound to identify the proximal cap. And if there is no side branch, then you can move the cap, which means either you go subintimally, which is a balloon-assisted subintimal entry base. You enter subintimally into the proximal cap and do some re-entry techniques. If there's a poor distal quality, then again, if there are good interventional collateral, you go retrograde. But if proximal cap is good, distal vessel quality is good, antigrade wiring should be done and attempted, antigrade wire escalation. And if this fails, then it is again, obviously with experience, accumulating experience, operators think that parallel wiring and intravascular ultrasound guided should be applied in some cases when the distal vessel quality is good. And if this doesn't work, ADR could be done. And if they all fail, then obviously you can just dilate it like a STAR procedure and do not put stent, and this could be an investment procedure. And obviously you can keep changing the strategy as well. And if all these adverse features are there, then good interventional collateral, you go retrograde approach. And if this is successful, you carry on. If it fails, then sometimes you go back to antigrade. So you have to change. So the role of algorithm is you should change strategy quickly before you get into any complication and try to successfully end the procedure. So this algorithm also gives advice on when to stop the procedure if it has been more than 3 hours and you're not making any progress, or if you 3 times, if the contrast volume is high, or if you've used more than 5 gray and there's no progress. Sometimes you can carry on. If you suppose your wire has crossed and it is 5 gray, then you carry on and you dilate and you finish the procedure. Okay, so I'll just share with you quickly few cases, just like a snapshot type of thing, not the full cases. So this is some bilateral angiogram set up short, and you can see here there is a proximal cap where there's a branch. You know the cap is a little bit ambiguous, but not too bad. Distal cap, distal quality is very good, and they are good interventional collateral. So quickly I will think in my mind, I will go with antigrade wire escalation. If it doesn't work, parallel wire, and then retrograde. ADR is out of option here. So that is what I did. I quickly tried antigrade wire escalation. As you see here, the wire did cross into the side branch, but I was not able to, even with double lumen catheter and escalating it with the Gaia 2 wire, I was not able to cross into a distal vessel. So quickly then I don't just carry on with this. I quickly moved to interventional collateral. My wire was half already in the interventional collateral, and I crossed the interventional collateral quickly, and you see here I was able to successfully finish the procedure. Wire went into the branch first, but then I was not able to get the branch, and I was very lucky the antigrade wire went into the retrograde microcatheter in a rendezvous fashion here. So then it was, so it will be called as a kissing wire technique basically, but retrograde supported, and we were able to successfully finish the procedure after few stents. Successfully, stent, distal flow is good, all the branches are maintained. Another case here, failed procedure, first attempt. Let me go back to this. So you see here, this was failed before. So we did an IVAS guided proximal cap entry because the proximal cap was not clear because it was going into septal also, it was not clear. So this was IVAS guided entry into the proximal cap. As you can see, IVAS shows you where the wire is, and that is what IVAS will do. And then we carried on with the procedure, and there was few more intermediate steps, and this was the final result after that, and the branch was all saved. So this is another case here. Due to some reason, it's not playing. So this was quite a ambiguous proximal cap in this. So let me just show you actually. I think I've selected the laser, so it's not letting me. So this is the case. If you see, this is like a very ambiguous proximal cap. There's a side branch. You're not sure what it's going to do. Distal vessel quality is not too bad, very tortuous. So antegrade wire escalation unlikely to work because so much tortuosity. Distal collaterals are there and distal vessel is good. So I think I must have tried. So we did IVAS guided proximal cap entry. We were not able to enter into a true lumen. And we entered like in subintimal with a CP12, progressed with the microcatheter. And I deliberately wanted to knuckle the wire here because of severe tortuosity, long lesion, and I knew that I'm not going to successfully do the antegrade wire escalation. Failing that, I will try retrograde. The collaterals were not brilliant, so that's what I did, and I knuckled the wire down. After stiff wire, I took the soft wire, and then wire went very close to subintimal space. You can see here, I'm not showing you the intermediate step. Then we exchanged it to a stingray. Wire crossed into just before the bifurcation. I was lucky to cross it, and we were able to save all the branches. So from the algorithm, I know that how I have to move forward to successfully do this procedure. Again, this case here, you see this is a right coronary artery CTO. CTO is quite distal here, previous bypass surgery. Further down here, before the crux. So distal vessel is diffusely diseased. ADR is not an option. Antegrade wire escalation. If it doesn't work, I will try to go retrograde. And I've looked at the collaterals. I will try to use these epicardial collaterals. So this I have decided beforehand, like 1, 2, 3 strategy. So this is antegrade wire escalation with Sion Blue XTA, Gaia 2, CP12, multiple wires for you. And this is the final. On the right hand side, you will see it is in the subintimal space. It's below the distal cap. So I was not able to enter. Now I have to quickly move to retrograde here, which was quite tortuous. So I did selective with Sion Blue, got my caravel in, and then Sion Black for part of the collateral Suo wire, and it was able to cross it. So the purpose of this talk is not to show how to cross the collateral channel. So I successfully crossed the collateral channel and did the procedure, and this was the final result. So I was able to secure all the branches distally. So when you come retrograde at the bifurcation, I think that is the best strategy. Otherwise, there might be a chance to go subintimal and lose the branch. Now, there are some more examples here. You can see here, I can show you quickly. Obviously, these are some examples. Ambiguous cap, what will you do? IVAS guided antegrade wire escalation, parallel wire, distal vessel is good. If it fails, ADR can be done as well. Similar here, tapered tip, short length, distal wire good. AWE will be the first strategy. Parallel wire, failing that, ADR could be done. Here again, the similar things can be done. So you should have a mental map of the patient's CTO after taking bilateral angiogram. Similarly here, very long lesion, good epicardial collateral, interventional collateral. This was the case done, the length is from here to here. So, and collateral is good, so you should go retrograde early in your case. Retrograde wire escalation, RDR, what you want to do. But this will, the algorithm will help you in how to proceed the procedure. This again, case here, you can see the ambiguous cap, ipsilateral collateral channel, good collateral channel. So all the options, you can do ADR if you are an ADR person, subintimal entry, base or subintimal entry, and then you can re-enter, good collateral. I did it retrogradely. So how does this all fit in with the data, the real world data? This is the data registry. This is the accumulation of 9,000 patients of 5 registries. 3 of them are hybrid registry, recharge, expert recharged, progress and open CTO. Expert JCTO is more like a Japanese registry. These are number of patients done by expert operators, you have to remember. And then you can see here, so technical success was more or less similar in all the registries, whichever way you do. Procedure time is slightly higher with expert JCTO, but the contrast volume is low. And this was the final successful strategy. Antegrade wire escalation in 2/3 of cases in European and expert CTO, and 1/3 retrograde. On the contrary, in the hybrid registry, about 20%, about 25% were ADR, antegrade dissection re-entry. So you have to remember this, and their antegrade wire escalation was only 50%. So they move quickly. If they think it is not AWE, they don't go to parallel wire, quickly move to ADR. And I don't want to go into this. So in conclusion, ladies and gentlemen, so careful angiogram evaluation is very important after bilateral angiogram. High success rate with low complication rate if you manage, if you follow different algorithm. Then also you can efficiently use your resource skills and move towards success. Avoid too long in failure mode. Switch operator if it is not working, or switch strategy. And if you are not competent enough to use that collateral, then you stop early rather than stop late. Do it next time with the proctor, and proctor training improves the skill set. Stepwise escalation, obviously do less complex cases and then move on to the more complex cases. So I will stop here. Thank you.
Sudhir, between the retrograde, because you saw the registry, it is 25-27. In our practice, if antegrade and retrograde, our percentage of re-entry is extremely, I mean, the subintimal re-entry techniques is very, with or without Stinkray cross-pose is very, very less, maybe hardly 5%. What's your practice in UK and Europe? Is it really the true world experience at 24-27, the figure you showed? Or
yes,
because none of us, maybe the way we are trained, we heavily relied on anti-AWE or retrograde wiring. Very, very rarely we use the subintimal re-entry. So is it something which you
Yeah,
also
so I think this is a real world actually. If you look at those recharge open CTO progress register, American, so if you go to American data, they've got pretty high success rate successfully, and quite safely they are done. So they based it on hybrid algorithm. Their 1/3 cases up to 20. It is getting a little bit less now. These registries are about 5 years old.
Okay.
So it's getting about 15 to 20%. But if you go to Japanese and European, the ADR might be below 5%, and AWE and retrograde will be majority of the cases which are done. Now my procedure, I am kind of a hybrid algorithm kind, because I do more like, because I've done some training in Japan, so I follow Japanese approach, but I am quite quick to change strategy as well. So my ADR is about less than 5%,
yeah, true.
but about retrograde 20%. But the success rate still in experienced hand, you have to understand, is not more than 90%. Obviously some super operator can have 95%. This is all contemporary and consecutive patient, not selected patient. In all registries up to 90% if you use these techniques carefully. And you quickly change the strategies. Obviously it can be a little bit low, little bit high. So people who use, so the global registry has included everything in there. But if you look at hybrid operators, do less parallel wire, and the other obviously operators, they use more parallel wire and those kinds of things, and they do more base and subintimal entry and those techniques. So I think either technique is good as long as you know how to do it and successfully do the procedure. There is no gold medal in what technique you have used. The gold medal is only for people who have successfully done the procedure. Nobody is going to ask, and patient goes home healthy and remains alive for longer time, and stents don't get blocked again.
Thank you, Sudha. Any questions from the floor, please? A little advanced topic, but should know. Be more than happy to. Please, fellows, any questions, please?
Okay, we can carry on with the discussion. The meeting is still heating
Go
up. These are the introductory talks. So
any of these algorithms taken care of the patient's characteristics, like frailty score or ejection fraction? That also, is that anybody looked into this algorithm, or only the procedure?
Yeah, the procedure is very like angiograph. So the algorithms are not based on patients' baseline demographic characteristics, where they take into account the age, gender, frailty, and those kinds of risk factors kind of thing. They look at the angiogram, so those things are pretty important as well. I think we can try to come, obviously another algorithm will come in few years' time. Things are changing where they should take into account the frailty as well, and frailty is very important. Rockwood frailty score, the people who don't do routinely frailty, we have to do frailty routinely in our patient, TAVI, CTO, whatever it is, to decide Rockwood frailty score, and patient's frailty should be, I think it should not be more than 4. They should be able to walk unsupported. Maybe they can use a stick, maybe due to some mobility issues, but clearly patient should be able to transfer himself from bed and look after himself, dress, and those kinds of things. So obviously all the operators, they take into account those things as well, but not in the algorithm. Okay, thank you.
Thank you, Dr. Sudhir. Can we now go on to Dr. Kaparthi, please? Dr. Kaparthi.
Good evening, everybody. So this is one of the important topic, that is microcatheters, especially key to the success in the CTO angioplasty. So microcatheters for successful CTOPs, especially support is everything, especially CTO. And the purpose of this microcatheter, as Dr. Raghu previously described, it will prevent the wobbling movement of the wire and gives the support of the wire so that it can cross the CTO segment with the support, and for exchange of the wires also this is useful. Of course, multifunctional microcatheter is also available. I will describe in the next following slide. So these microcatheters form an important part of the toolbox, which consists of sheaths, especially long sheaths, previously TRA, TFA that were described, and guiding catheter, that is supportive guiding catheters, and guide words previously described, and next Dr. Goyal is going to describe, and microcatheters, and complication management, especially snares and external wires. IVAS, especially imaging, is very, very important. So these are the different microcatheters. Usually Asahi is a dedicated one which usually use. Of course, other catheters nowadays available. For completion's sake, I will describe. And here most important is non-torquable and torquable microcatheters, especially and third one is penetrating microcatheters. So these are different microcatheters are available. And first you should know the important characters of microcatheters, so that in which subset you can utilize, you can take. And fine cross, basically it has a hydrophilic coating and available 135 centimeters and 135 centimeters. And most important is the entry profile is 1.8 French. That is most important. It is a tapered 1.8 French tapered tip, tapered profile, entry profile for a microcatheter. And it has a excellent stainless steel bead with hydrophilic coating, so that it is trackable even CTO segments, especially in soft tissue CTO segments. It is very useful. Once wire passed for exchange of the wires also, it is useful. So these are the different characters of these fine cross catheter. And so this is one of the important, you can observe this RCA CTO with a soft tissue islands of the CTO segment. And once after crossing with the help of the fine cross, you can observe with the anchor balloon, you can cross across CTO segment that this catheter, and then ultimately we exchange with the software that is routine workhorse wire, that fine cross, and then subsequently we completed the angioplasty antegrately. And the second importance is the Corsair. So this is one of the important torquable catheter, especially it has a Shinka shaft technology, proprietary braid. It is there. And most important here, initially the Corsair is available in 135-150 centimeters for antegrade and retrograde. And the important braided one is, it is made up of almost 10 stainless steel wires with a tungsten tip. That's why the tip is also more flexible. And the advances in this one is Corsair Pro. And once the radiopaque marker was removed, it has 3 important properties of improvement, especially increased flexibility and trackability by removing the radiopaque marker, new kink resistant proximal hub protector, or smooth transition tip to the shaft, and that anti-tip profile is 1.3 French. That is important. And further important improvement in the Corsair Pro, it is increased flexibility has happened along with the torquability, and Corsair Pro XS happened. In Corsair Pro XS, the most important, instead of 10, it is 14 stainless steels, so that its flexibility is much more enhanced in Corsair Pro XS, especially useful in retrograde septal channels crossing, especially tortuous septal channels and epicardial channels. It can cross without any injury. So this is the one. The hub is kink resistant and entry profile is 1.3. It's a hydrophilic coating, and most important is a torquable one. You can see how it is crossing the tortuous channels. So these are the features I described, and this is one of the important where the septal channels, how it crossed with the Corsair Pro. And this epicardial channel, corkscrew epicardial channel, with the help of CO and Corsair Pro, how it passes the corkscrew channels effectively to enter into a pylori branch through epicardial channel from circumflex. And then after knowing that the Corsair Pro and Corsair Pro XS, then the importance of Caravel catheter, which is a sleeky catheter. The entry profile is 1.4 French, unlike entry tip profile of the fine cross is 1.8 French, this is 1.4 French, almost from hub 2.6 French. So, and it is also taper tip, and it has excellent properties of the trackability in especially epicardial collaterals. So, this is available both 135 as well 150 centimeters length with a hydrophilic coating, and it has an Actone precision braided shaft. So, that's why it can track like anything with just a simple pushability and with a excellent support to the guide wires. And this is the important computer. You can see how it is flexible because of the low tip profile 1.4 French. It can cross the torch washes also. And of course, this is the one Caravel with important flexible properties with a low entry tip profile and hydrophilic coating. And this is RCA CTO with a balloon anchor. At the same time, the this Caravel gave very good support to the Gaia second wire, and ultimately while doing the anti-gate preparation to cross into the penetrate the distal cap and enter the distal RCA segment of this ISR CTO. And this is a retrograde Caravel where we have used through the septal channel and trackable over the wire after crossing the C2 segment for externalization. We use this Caravel. So this is very useful, this tortuous crossing of the septal as well as epicardial channel. Very important, especially it is a traumatic and is a favorable catheter for epicardial collateral along with the CO wire. And after knowing multifunctional catheter, this is a dual lumen catheter which you should know, especially the tip as well as the side port will be there. The tip is the rapid exchange one, and the side lumen is the over the wire lumen. And first one, that's the Kaneka, that is this Crusade catheter. And Crusade catheter, the tip profile is slightly higher, that is 2.2 French and little bulkier. And this is useful for multi-purposes. I will describe. And this is a dual lumen catheter. And 1 millimeter distal idiopathic marker is there with a 0.5 mm wire exit port marker. And it is a 140 centimeters working length with flexible distal shaft. So especially initially this was invented for the side branch reverse wire technique and difficult side branching. It was retro wires, retro side branches it is useful, and branching side branches across the stent for causing it is useful, and it is useful for some purposes I will describe now. The Crusade assisted proximal puncture as well as a parallel wire technique in this given case of ISR CTO we used. Because of the multiple port, you can use the workhorse wire for the side branching. From that, we can take the help of this side port microcatheter help, and then you can penetrate the proximal puncture. And after entering the proximal cap, you can take this as an anchor. If you enter into the block to block, you can go directly. Suppose if stuck in the extra block, then you can take this one as a wire anchor, subintimal anchor. You can penetrate the block with the second port. And then the more sleeky dual lumen catheter, that is a Saseke, the next generation double lumen catheter, and it has a 6.5 millimeters tip to over the double port with a tapered soft tip compared to the Crusade, and visible. It has a oval design with a double stainless steel core technology with lubricity. These four are the unique characters: a double stainless steel core, elliptical shaft design, tapered soft tip, as well as the L3 coat, long-lasting lubricity. This makes this one more sleeky double lumen catheter with multiple functions. So these are the different utility. You can use a subintimal anchor technique. You can use a reverse wire, side branch access through the stent struts as well as side branch occlusions also, especially the ostial LAD CTOs. You can use the circumflex, you can keep the, you can do this dual lumen assisted proximal cap puncture you can do. And these are the other different uses, especially the retro side collateral, especially septal collateral from LAD. You can use this, take this help, as well as the selective injections you can use for the side port, And the retrograde anchor also, you can, especially distal cap bifurcation, you can use the anchor to penetrate the distal cap, and side branch anchor technique also you can use. So this is a Sasuke which we used for the distal cap, actually, for difficult side branch or septal collateral entry, because proximally it is taking angulation septal collateral. With this we take the Sasuke for the entry into the proximal part of the septal channel. And then after that one, penetrating catheter, Asahi Tornus, this is the more important. It is available. The important character of this Tornus microcatheter is to enlarge a lumen for uncrossable, balloon uncrossable lesions after the wire crossing. This you can use to make the channel in the CTO segment, so that the balloon uncrossable will become crossable. So this is available in two things, especially 2.1 French and 2.6 French. 2.1 French is a greater flexibility for tortuous anatomy, and because of its hydrophobic coating, and the tip profile is 1.8 French. Whereas it's 2.6 French, the tip is 2.1 French will be there, entry profile, and it has a hydrophobic coating, and for penetration it is useful and available in 135 centimeters length. So this is the one, in spite of the guide extension, it is unable to, balloon is unable to cross in spite of the crossing of the wire because of the heavy fibrotic and some calcium burden. Then we have taken this Tornus and ultimately penetrated this CTO segment, so that the balloon we can able to cross. And of course, the crossbar CTO catheter, as everybody knows, this is also a penetrating catheter, and this is useful especially to produce the extrapolar space, and so that for ADR it is useful. And the ideal thing, you can reduce the time, especially in ISR CTOs, where you can make this crossbars in that ISR segment, because it won't go, it is a class 1 indication in ISR CTOs. And of course, nowadays the recent one, just I want to mention the recross, which is a triple lumen, and 2 ports will be there, 2 lumen and 3 ports will be there, especially with the entry tip profile is 1.5 French, and 180 degrees it is 2 ports will be there, so that it is very useful for side branch proximal cap puncture, especially the stumpless CTOs is very, very useful, this catheter. And of course, this can be useful to like multi-purpose for lumen catheters. You can use this recross catheter. So this is the BVS CTO. This recross catheter, just we put the diagonal branch, the workhorse wire, and keep this recross catheter, and of course this is the recross catheter, and then from the side port the wire we pass through the hub, and ultimately penetrate the proximal cap of the BVS, and then give the excellent support, and then we pass over. You can see the markers, distal and proximal cap BVS, and then ultimately we wired and then completed the revascularization of this LAD CTO of BVS CTO of LAD. And of course, for completion, this is the catheters, pro-navi catheters, which is useful 1.7 French, just like akin to the fine cross. And of course, tip profile as a 1.7 French, fine cross is 1.8, and pro-navi 1.9 French. It is just a tapered tip, which is a torqueable one, which you can give excellent flexibility as well as a good support. And of course, the turn spike, it is almost like Corsair equivalent. And this navigates complex intervention every turn, and these are available in four models. It is available, and it is a low profile shaft flexible tip, which you can use through tortuous anatomies. And compared to these, you can see the profiles. Turnpike of catheter of 2.6 French, as well as 2. French, and Corsair of 2.6 French. And of course, non-torqueable, the NT profiles, you know, Caravelle is 1.4 and fine curves is 1.8 French. And gold, this is a penetrating catheter, especially calcific CTOs after wire crossing. You can use this because of its threaded metallic tip. You can use as a penetrating catheter also, this one by means of rotations. And then spiral, this catheter is also more flexible tip as well as a spiral shaft, which makes more crossable of the CTO lesion, which gives support. At the same time, you can pushability is more and more for this spiral catheter. Of course, a standard version of flexible tip is there, especially because of 5-layered shaft. This has a more flexibility and torqueability, and you can pushability is more for these torqueable catheters. And then for last, and this one is supercross, which is angled microcatheters, and ostial CTOs also. This is very useful, and 90 degrees to 120 degrees retro side branch access, especially bifurcation CTOs. This is useful along with the dual lumen catheters. Thank you.
Thank you, Dr. Kapati, for the wonderful lecture. It's a very comprehensive one on microcatheter. For the fellows, can you just briefly tell how to handle these microcatheters, because all are not alike.
Yes.
Which can be rotated, which can't be rotated.
Yes, yes. Fine cross and caravel, usually majority of the operators just wire holding and they will push. And whereas these Corsair catheter, usually as well as the Tornus, they are rotating. But rotations, what you have to do is, for the Tornus, for passing antegradely, penetration, you have to do counterclockwise turns. And then for removal, you have to do clockwise for Tornus penetrating microcatheter. For Corsair, actually, you can use almost 10 to 15 turns and you have to release the torque. If you won't release the torque, then you can face the problems, especially the torque accumulation will occur. Sometimes the stuck, or especially if you use the Oxford catheters, sometimes breakages also can occur, especially in the calcific lesions, it may stuck also, it will occur. And in some operators, actually I have seen, they will rotate the caravel also. But usually caravel is not designed for the rotations. They just only pushability. Even because of its excellent braiding and all these things is a makeup, it will even go tortuous anatomies, especially the epicardial tortuous collaterals, it can cross with the CO wire.
And the choice of microcatheters in simple words.
Yes, yes. And another important is the fine cross as well as the caravel is a more of sleeky catheters. And especially if the gap is small and the vessel size, proximal vessel is small, then you don't take bulky catheter like a Corsair and all these things. Because there's a lot of, suppose bend is there, proximal vessel, then the vessel as well as the guiding, the microcatheter has some disparity in the direction, intended direction you can't do. So you take fine cross and caravel, if the proximal vessel to the CTO proximal vessel, if you want the small vessel size means, then you take the caravel as well as the fine cross, which are sleeky catheters. Suppose for the septal, that is collateral retrograde and all these things, you take a Corsair Pro XS as well as caravel. For epicardial, majority of them prefer caravel catheters along with the Corsair Pro XS, but caravel is more safer compared to the Corsair Pro XS for the epicardial collaterals.
I think we'll move on to the next lecture. Thank you very much. It was a wonderful session. Next one is Dr. Goel. Yeah, Goel will give a lecture on guide wire for C2O PCI, which and when. Master of guide wires.
Okay, so actually I have to talk on which wire when. How do you... So what I'll do is I will talk a little about the wires and then show you some examples. Basically, CTO wires are talked in terms of tip load, tapered versus non-tapered. Coatings could be hydrophilic or polymer jacket or hydrophobic tips sometimes, like we have in Asahi Blue. Penetration force versus penetration efficiency. We talk of this especially in the Gaia group of wires, the penetration efficiency being more than the penetration force because of the way it is made. Then torque transmission 1:1 or no whip effect. Now these are things which are very important, crucial, and one has to understand to move forward in the CTO domain. Now wire choice decision-making factors depend largely on the angiographic picture. So angiographic picture and also the history, that's very important. So the duration of occlusion, is it a post-MI setting or not? Microchannels are present, or there is a very faint trickle that you can see. Proximal cap is tapered versus blunt, or it's a flush occlusion with a side branch. There is a bend or tortuosity within the CTO segment. Is there a calcification? And there is a branch point at the distal cap. So with all these things, this is actually the summary of the whole talk. If the duration of occlusion is less than 3, someone was talking about pilot. If it is a less than 3 months occlusion and a MI setting, pilot is a beautiful wire to do it, especially when you don't see the distal vessel. In these situations, sometimes you don't see the distal vessel. Post-MI setting, that's what I said in the next one. And pilot is good to explore if it goes fine, otherwise you will use regular CTO techniques. Proximal cap tapered, then you can use XT, XTA, Gaia 1, something like that, grading going upwards. And if it is blunt or flush occlusion, then you need to penetrate. And for that, you need something like Gaia 2, 3, or Conquest. If there is an antegrade trickle, there are micro channels probably. And then something like XT, XTR, XTA works well. CTO segment is bendy, then Conquest is not the choice. I have a red on Conquest. You have to, hydrophilic wires are good. You can use Gladius sometimes, or otherwise you have to use some directing wires. Calcification, well, you must know we do use Gaia, but Gaia can get stuck in calcifications. So if it is a calcified CTO, you're not getting success, and retrograde is a better option. This talk largely will be on antegrade because wire choice selection is largely for antegrade procedures. Branch point at distal cap is present, then again Gaia is a better choice because, and at this point you can't do stingray. You have to go into the distal vessel, intimal or subintimal, and then only get into the stingray business. The CTO length, well, if it is long, then always retrograde is a better option. If it is short, well, several wires are okay. Well, ADR, if there's a leader, then you can use a cross pause, but if there's a flush occlusion, then you need a penetrating wire or a knuckle system, which can be done through Gladius or Pilot 200. So this is it. So you always have a feeling that softer wire will always be safe, but that is not so. What happens is, if there is a small calcific speck, you're not seeing this. Okay, sorry. How do you get the laser? Laser pointer. Okay. When you have a small calcific speck like this, a softer wire may get deflected, but a penetrative wire will go through. So it is softer will get subintimal and a stiffer will go through, provided you know where to go and you're doing it the right way. My usual choice of wires for antegrade, step 1 is a Fielder XT, XTA something, second is a Gaia 2, and third is Gaia 3 or Conquest Pro. Now, Fielder XT is a taper tip wire and 0.8 gram load, 009. It is a wire good for controlled drill. The wire will find its way. You have to know how to rotate it without pushing it. And if there is loose tissue, it will find its way. I'll show some examples here. The XTA, XTR are very much like XT, but here they have a composite core, so the directing of these wires is better. XT you cannot direct, it will find its own way and that's it. But XTA and XTR, especially XTR, if you want to stay soft, there is some patency, you don't want to get subintimal at all. And XTA, if you're looking to get a channel across, something like that. We can skip that. So, difference between CTO wires, well, you must know soft wires less than 1 gram load, intermediate wires, and the stiffer ones. Like the Gaia 3 and Conquest Pro. The Gaia wires have a composite dual core. They have a taper tip, 0.1, 0.11, 0.12 inches, and the tip loads 1.8, 3.5, 4.5, only 4.5 grams. But this 4.5 gram load wire has a penetrative force which is much more than a Conquest Pro. So that is where the penetration efficiency I was talking about. They have a hydrophilic coat, and because something they have called the Act 1, they have more penetrative force. And the other thing is, because the tip load is less, they have the flexibility, and you can direct them, you can literally direct them in different directions. So with tip flexibility, because of lower tip loads, greater penetration efficiency and direction control. So the Gaia wire literally can be, and the torque control is 1:1, and literally you can direct it wherever you want it to go, provided you know where you want it to go. That's the most important thing. You can literally guide the wire. The limitation is, because of the lower penetration force, this wire will sometimes get stuck in calcium. So it will track all the way down, and here it will get stuck. And then you rotate it more, it will coil itself, or rather the coils will get uncoiled, and you will break that wire. So tips to Gaia wire manipulation: never over-rotate, always advance 2 mm and draw a millimeter to ensure that the wire tip is not stuck, and always redirect in advance. And this is to the angles of 15-20 degrees. You're not supposed to make it 180 degrees one go. Wire equivalence, well, you have in other makes also. Conquest is like Hornet of Boston or the Infiltrack of Abbott. But you must understand the wire that you're using before you really get on. The other dedicated wires are the Miracle series. These are non-hydrophilic wires, 3, 6, 9, 12 gram. Ultimate Bro, this is a polymer jacketed wire, 3 gram load, good for retrograde passage of the, from the retrograde distal cap. Conquest and Confianza series, strong penetrative power, 0.9 inch. But to direct the Conquest is a little difficult. Gaias can be directed better. These will go more straight. So in tortuous anatomies, Conquest may not be good. The Pilot series, as I just said, 150, 200 grams. The load is 2.7, 4.1. And it is good when the path is not clear and you know that this is a semi-chronic occlusion. We do get patients which are 1 month old MIs or 15 days old MI, and the regular workhorse wire will not cross. And you don't see the distal vessel because it has not crossed, it is not filling. So this one will penetrate that cap and just find its way. So that's the only thing Pilot will do. And then other makes are there. Well, you must know the details. The Asahi Suo is for the retrograde, 0.3 gram load. This wire is not there, the Miracle Neo, but it is good. It has a square type of a tip. And it is good that it doesn't get subintimal so easily. And the Gladius we have 3 grams. One is for making knuckle and another is for something like Ultimate Bro. Infiltrack is alternate for Conquest in the Abbott, 11 grams and 14 grams. Collateral channel, I think I'll skip this in the interest of time. Let retrograde talk do that. I'll just show you a few examples. Now this is for XT. Now you see this. We have occlusion of the circumflex, and the collaterals are very strong. Strong epicardial collaterals, certainly CTO, but you see you have some tapering there, and I had a feeling that that's where the angiogram has to be analyzed frame by frame. Someone was talking the two things, bilateral injection a must, angiogram analysis a must. So you have to really analyze the angiogram. If you analyze the angiogram well, several CTOs sort of melt down very easily. So anyhow, so you can see what it is, so strong collaterals, and the wire that is crossing, it is just a XT. You are just rotating it, and it's finding its way, and gradually going down, you are reconfirming the distal wire location through contralateral injections, and the next one you see, you are right there. So, and then further wire progress, and once you do that, you can of course complete the case. This is now 2 channels. You see the RCA, it looks patent, but it's not patent, it is a CTO. There are 2 channels here, microchannels you see in this segment. And this is a recanalized CTO. So Sion has no power to move, it's getting stuck. XT moves forward, but again getting stuck. XTA now makes its way. XTA is 1 gram against this thing, XT of 0.8 grams. That little difference makes a difference. Exchange to workhorse once you cross and then complete. Another patient of XTA, now RCA occlusion, strong collaterals from the left side across the AV groove, crossing with XTA, you see that it's going to cross. So gradually working on it under contralateral guidance, and you can go through. Okay, that's the final. XTR. Now there are some cases where, now this is again a CTO. There is some trickle there, and it is a little bendy if you see here this RCA. So XTR, and in this patent segment, I don't want to go subintimal. So XTR, I will give the bend forward. XTR will take that bend, and it's only 0.6 gram load, tapered tip. And it will go down, and then you can further travel with XTR. Gradually, you have to do that. Take the help of the microcat. There's a caravel coming down, if I'm not wrong. And then you gradually advance it. And always keep checking in the contralateral injection. And there you complete it. Now, this is again a very, very bendy lesion, which was sort of failed outside. Truly not a CTO, but again, XTR is a good choice for this. I'll skip that. Okay, so lots of bends, and then it is sometimes getting subintimal, but I can redirect it. That's the beauty of XTR. And Gaia, now this is LAD occlusion. Some little flow forwards from bridging collaterals or somewhere there is there. Now, XTA is buckling. You don't really see the track, which way it is to go. So I have to find a track. There is a side branch also there, and a tiny one which cannot be used much for. So this is Gaia 1, which has gone into a branch. And then you do a tip injection, this a septal there, and then some little flow I can get through some channels. So now you advance it in the orthogonal plane, and here you use what I often say about 3D wiring, and then you can get in. I don't have time to explain that, and then you can exchange the workhorse and complete the case. This is a typical pilot 150 case. This is a total occlusion. I am not seeing the distal vessel filling through either native or contralateral injection. And this is maybe a 1-month-old MI, something like that. And then a pilot 150 will just get through the resistance at that cap. And then, because if you just handle it, it will not go haywire. The other CTO wires distally can go haywire. And then you can do that final. I think there are lots of examples now. This is something we know of seeing from the side branch IVUS guided, but sometimes your wire always goes in the side branch. Now this is a case, how do you, it's not running. This is a case where there's a big side branch, the wire is always going in the side branch. So what you need to do is occlude the side branch from the mouth and then use your penetrative technique. And here it was crossed with the infill track. That's a conquest type wire. You confirm it from the contralateral injection, and there it is. So it is in the distal vessel. You have to confirm that, and then you can get the final result. I think parallel wire, for parallel wire, the second wire has to be stronger, we know that. So largely I do it with either a Gaia 2-3 or a Conquest. So this is getting subintimal. XTA is stuck at the distal cap, you can see that there, and it is subintimal. Because you have different choices. You have to decide which choice to go through and exchange to workhorse. And I think with this we will move. Now this is another parallel wire. Now you see this is a very bendy vessel here, very bendy lesion. I would electively not use a Conquest here, but my initial wires went subintimal, and this is Gaia that is hanging there. and then to cross it, so you can see the Gaia is not in the right position. So then you use a parallel wire. It takes a little while to show you where it is, okay. Cross check, this Gaia is in the wrong track. So, but the conquest finds its way correct. So this is one where Gaia failed and conquest succeeded, and then you can complete it. Okay, so to conclude, what you need for which wire, when, and understanding mastering wires, you need to have a good understanding and knowledge of the CTO wire, its hardware technicalities, and the angiographic anatomy of the CTO lesion, which is fundamental to a successful wire crossing, along with good wire handling skills. You certainly need perseverance, some patience, and of course perfection. Know when to stop. Thank you. Sorry I overtook the time, but my submission is next time when we do it, we'll probably give a little more time to the speaker so that he can really teach. Otherwise, in 10 minutes and 12 minutes, it's more of my own showcase rather than trying to teach the audience. Sorry for that. Thank you. Yeah, for fellows course, that's what I'm, next time, that's what I, so that it is more of a learning rather than just showcasing what, I'm sorry about it if it hurts anyone. Yeah, please.
What about Gaia Next?
Yeah, Gaia Next, I specifically did not put it because I have not used it. I am told that my friends have just got it. I'm going to catch Asahi to give me also. Gaia Next, Gaia is a single core wire round. Gaia Next has multiple wires round in that distal core. So what happens is, the way I showed you the Gaia breaks, the Gaia Next probably doesn't. And the 1:1 torque control of Gaia Next is even better than Gaia. So whatever controlled wiring that we are doing with Gaia 2 and 3, I'm sure it will be even better with Gaia Next. So if Gaia Next is there, with all these technologies and I talk of 3D wiring, we have a talk tomorrow. I did the live case today with 3D wiring and we succeeded. Everyone thought we were suboptimal, it will go parallel wire, but I could re-enter it. So Gaia Next will do very good in that.
Little
So I think that
and then
it has the same features of Gaia, except that it probably will not get caught and broken.
Yeah. Thank you. I think we are running really short of time. We'll move to the next lecture. Dr. Damodar, please. Yeah. Request fellows to ask questions. Don't be shy. All of us have learned through mistakes. So there is nothing hard sciences, so please feel free to come.
Good evening. Thanks to Dr. Rao and the organizing team. I am going to talk on wire-based anti-grid dissection and re-entry. That is star, mini-star, lost is the area I'm going to focus on. As we are aware that with the advent of device-based re-entry, that is Stingray, and advancement in the retro skull sets, this kind of procedure is becoming less relevant in the contemporary PCI, but it is not obsolete. In certain situations, it may be of use. Let me discuss the historical and contemporary data, where and when it will be used, with few case examples of us, which was done a decade ago. Nowadays, we are not preferring that. Just for the fellow's sake, I just want to go through the history that started with the parallel wiring, then star, when we entered into the subintimal space, and at times we are not able to, understand how to get out of it. So that so many operators in the arena of CTO has devised so many techniques, subintimal star technique, classical star, mini star, and lost, and also the AFR, and with some newer dual lumen guiding catheters also. This algorithm has been already touched upon by Dr. Sudhir. But still, if you look at it, the Western operators, mainly the Euro CTO algorithm, is mainly emphasizing the wire-based ADR as one of the strategy, whereas in the others, it is not much mentioned. They mention it as a final procedure or as a road to an investment procedure. This is where I am going to discuss upon. And you know, when we look at this time-old procedure, we thought it is out of vogue. But still, as he rightly mentioned, this wire-based re-entry is more than 25% of the ADR cases in the UK hybrid registry. So it is still prevalent in some of the cases. And this is the simple understanding of how it is happening in STAR as well as the LOST and in the device-based re-entry. So there is a major difference between re-entry and redirection of the wire. The STAR is basically extending the dissection plane beyond the distal cap and re-entering with the same wire, that is the knuckle wire. Whereas the LOST, limited antegrade dissection, what I am going to discuss is more of a redirection just before the distal cap. That is more of an intrapluck tracking just before the distal cap. And when we talk of STAR is basically a subintimal tracking and re-entry. It is a blunt dissection within the vessel architecture. One has to understand the vessel architecture and other things. And it is formed by usually the classical STAR by Dr. Colombo et al. They just made an umbrella handle, this is a big handle, using a moderate strip wire, that is a pilot wire. People were talking about pilot wire, the use of it, but still it has a role in knuckling, especially if you want to make a big knuckle, especially when you want to avoid the small branches in a tortuous calcified lesion for the people who are doing antegrade dissection re-entry operators. This is a wire of choice, but it causes a large subintimal hematoma, so the re-entry failure is more here. And if one has to understand how it has been transformed from the subintimal space into the true lumen, you can clearly look for the collapse of the hand and the umbrella handle when it re-enters into the true lumen. Because of the constraint force from the vessel architecture into the true lumen, obviously it collapses. And the mini STAR is just a modification that here the main difference is we are intentionally re-entering the true lumen as proximally as possible, just little after the distal cap. So we are avoiding an extensive subintimal dissection because most of the STAR techniques have got poor outcomes because of the long, extensive subintimal stenting as well as the shredding of branches and the poor TIMI free flow. So Galaxy has designed this kind of mini STAR by making two curves in the mini STAR. The one 1 millimeter, that is 40 degree. The other one is almost like 5 millimeter from the tip of the wire, that is 20 degree. And here it is not only the knuckling, sometimes if you catch the intra or extravascular extravascular channels, the wire can go through the channels and into the distal true lumen. Suppose if the tip of the wire is facing some resistance, then it automatically forms a J-tip. So you don't need to do a pre-shaped umbrella handle here. The historical data from Colombo to all the techniques showed the acute result is almost 80 to 90% in most of the cases. But if you look at the long-term outcome, most of these cases have long-term restenosis of more than 50% or peri-procedural MI, mostly due to the poor distal TIMI3 flow after the procedure as well as the loss of branches, side branches. So that is why this is only a bailout procedures when we have exhausted all the conventional antegrade and retrograde strategies. Whereas the contemporary data, if you look at this, when we are talking about this STAR technique as an older technique, if you look at this IJCTO registry also, it is not that bad. It is almost used in more than 25% of the patients. And if you look at the success rate, though it is numerically lower success, when you adjust the complexity of the lesions, it is almost equally having the same success rate of almost 90%. So because this wire-based ADR is used in such patients in very experienced centers with high volume operators, only as a bailout after failure of both antegrade. So obviously the lesion complexity is more, naturally we have to expect a lesser success, but the long-term results are equally good. Let me come to some cases which were done long back. So this is a case of 68-year-old male with the RC long segment. You can see a long segment with an island of vessel in the mid-RCA. And initially we thought of going with an antegrade wiring because the time our retro skill sets was just beginning. So we thought of doing an antegrade wiring, and it was dissected. Then we tried a bit of a parallel wiring. It was also not successful. Then we went in for a J-tip umbrella handle star technique. And you can see here the umbrella handle goes up to the bifurcation, and then if you look at this frame, how this wire goes into the PDA. This is where it is very risky. Suppose if it goes into the small branches, it may dissect, it may perforate also. This is one of the, almost 5% of the cases in the initial 40 patients had perforation, though not recurring a tamponade aspiration, mild perforations in the registry. So then we did a VDA to RC stenting. And another important thing is loss of branches. So we need to always have the strategies to rescue the side branches. So we did the stenting. Through the stenting, we just rescued the PLV, and then this is the final result. So coming to the loss technique, that is limited antegrade subintimal tracking. That is, if you look at this picture, the subintimal space is almost just before the, or well before the distal cap. It is not an extensive one like in STAR. Then we need to take another wire, a stiffer wire. If you see these steps, we need to go subintimally with a knuckle wire, and we need to go and stop before the distal cap, and with the retrograde injection, we have to check it. And then we need to take a stiffer wire like a Confiance of Pro 12 or a Pilot 200. And the main important thing here is we have to make a 90-degree bend, and this should be of the diameter of the, approximately of the diameter of the distal vessel, so that we can re-enter through an intra-plaque tracking into the distal true lumen. This is how we have to limit the subintimal stenting and the length of this one, as well as the side branch loss. This is a case initially we have done 10 years ago, and this is a patient with anterior MI. The LAD was stented, and you can see the RCA has a long segment occlusion almost from the proximal to the distal cracks with a high IJCTO score. Initially we tried with the antegrade wiring. Then we thought of going for dissection dot technique, that is dissection and re-entry. We initially tried with a pilot wire. There was a knuckle, and then the knuckle was going up to the mid RCA. It was not working well. It was our initial experience also. Then we changed the wire again, knuckling. It was not doing. Then we thought of going for a Carlino, that is injecting 0.5 ml, very low contrast through this microcatheter. You can see there is a long tubular dissection through the vessel course. So then we took a fielder wire and went into the distal RCA, but we understood from the retro and other checks that the wire was in the subintimal space still. Then we had to take, with the microcatheter, we had to take a pilot wire, and again, here the distal tip bend is more essential to re-enter into the PDA. The PDA is centered, then stented, then again, here you can see the very slow flow in the PLV. The side branch rescue is very, very important. And we did the side branch rescue, and this is the final result. The patient went home well. 9 minutes later, he came with some kind of atypical angina, and we are also curious to do a check angiogram in this patient. If you look at this, 10 months angiogram of this patient is nicely, the vessel is nicely remodeled, and you can have some small aneurysms and some ectatic areas, and also a moderate stenosis of the PLV branch. And at that time, we have the older version of OCT. We just did a OCT also in this patient to see what is happening in this vessel. Then it showed that in the dissected areas, there is a late persistent maloposition because of the resorption of hematoma there. But here the question is whether what to do further, because there is no clear-cut idea for that. A few anecdotal reports says you can go and dilate it. The others said don't do anything, just leave it like that. But we have to give you a prolonged DAPT. We don't know how long we have to give it, but we gave up to 4 years. This is a very, similar time. There was a case report which also said the long-term remodeling of these vessels after a subintimal stenting. You can see the aneurysm here. We don't know the fate of this aneurysm in long run, whether it can cause a very late stent thrombosis, we don't know. These are some novel techniques, antegrade techniques. I'm not going into the detail just to make you aware of this. Just whenever we thought of a wire-based re-entry, it is uncontrolled, unpredictable re-entry. So there are some novel techniques like the AFR antegrade fenestration technique by Carlino. It's a very aggressive technique with a lot of vessel disruption. Basically, they will put 2 wires in once we are in the subintimal space. Through one wire, they will take a balloon sized 1:1 beyond the distal occlusion, and the other one will be a polymeric soft wire, either a cyan block or a filter wire. Once you dilate the vessel beyond the distal cap, that is between the true lumen and the false lumen, to disrupt the septum between these two, then obviously you can immediately push the wire inside. These are the techniques not as a primary modality as fellows. These are all like by experienced operators as a bailout when all the strategies are exhausted. So this is another one. This is the one, the same thing he has modified with a single balloon, that is a balloon with a proximal wire, so that the manipulation of the wire will be better in this. This is called the AFR technique. Coming to my conclusion slide, the learning points are, although wire-based re-entry like star, mini-star, lost appear safe, they still carry risk of perforation. Main thing is loss of side branches and peri-procedural MI and poor long-term outcomes, which is not only due to the stents, but also due to the poor TIMI flow and the loss of side branches. So in contemporary PCI, this should be used only as a bailout strategy when we have exhausted with all the strategies. Suppose in case of re-entry failure, some of the European operators suggested that we can still use this as an investment procedure for a future stenting, because the poor outcome is only due to the long stent, so we can reduce the stent length as well as preserve the side branches. I hope in novel integrated techniques like wire-based ADR with the newer catheters, we have some experience with recross also, may give good improvement in procedural success as well as long-term outcomes. Thank you so much.
Good lecture, Damodar. I think as you told, it's largely contributes to less than 5% of our procedures, and then it continues to be a bailout procedure. And the challenge is, because it continues to be a bailout procedure, none of us are actually gaining more experience in this. It's because of the last bailout procedure. And our retrograde skills are improving, retrograde experience is improving. Most of us watch and learn from the Japanese operators, and they also kind of now started off using ADR in their armamentarium. Again, in case of non-interventional collaterals, when retrograde approach is not possible. Thank you so much.
Yeah, only in RCs, may not be in LE deletions. Yes. Yeah, thank you.
Okay, we have concluded this session, and then we had an excellent talk. Thank you very much. Hope we are catching up with the time.
Yeah, thank you, chairpersons, Dr. Pillai, Dr. Syed, Imamuddin sir, and Dr. Lakshman Das. I think now most of us have understood the algorithms and what all to start off with a CTO, and the toolkit is getting ready. Let's take it forward. The techniques. We'll go to the session 3. May I request the chairpersons, Professor Goyal sir, Rajesh Vijayvargya sir, Dr. Hayashi, and Dr. Manoj Kumar Agarwal sir to come over the dais and take up the session further. Dr. Hayashi, yeah.
I think have people come?
He's coming. We have in this sessions starting from antigrade to parallel wire, IVUS, yeah, and ADR and base operations. We start with Dr. Sharath Reddy.
Yeah, Sharath, you can please go ahead.
Yeah, thank you. So in next 10 minutes, I'll take you through escalation and de-escalation in CTO interventions. I think when I first entered into CTO interventions, I was like a boy entered into a toy store. You have so many toys, and you have to buy a toy. So that's how it will be, when you have so many wires. So what is most important is you got to know your wires and keep using it, and then you can really have a good hand over it. And this is a very recent, classification probably, which is quite useful for younger generation to understand. So you can divide wires into low penetration, intermediate penetration force, and high penetration force with blunt tip and taper tip. So And when you're doing an antegrade wiring, see the tenets of antegrade wiring is you enter the proximal cap, go across the CTO through the intimal cords and then reach the distal vessel without perforating and without creating a subintimal hematoma. I think that is the tenet in antegrade wiring. So, I mean, for that, what you need is a clear proximal cap and a good distal vessel. So, if you have these two, you can start case, antegradally. Also, you need a clear course of the vessel, which Dr. Goel has mentioned repeatedly in his presentation. So, clear cap, clear distal vessel, clear course of the vessel. So, you can use antegrade wiring and you can escalate, antegradally. So, if you have a cap like this, it's very unclear cap, and you can see ambiguous cap. So, you can't really escalate, without making your cap clear by using imaging. And when you have an unclear distal vessel, like in this case, you see, you hardly see the vessel proximal to the crux, and operator started wiring it, and you really don't know where you are, so in relation to the distal true lumen. So it's hard to reach distal true lumen in such scenarios. And when you have a clear, you need a clear course of vessel, like in this RCA where it is clear course, and see this right congratulatory CTO where course is really, really ambiguous, which I'll show in subsequent slides. And when you have a clear cap and clear channel, so I think the way to go is take a microchannel wire, which Dr. Goel has showed already, filter XTR, XTA, or fighter wire. So take microchannel wire, and what we have to do is, it's simple. Just keep rotating. Anybody can do it. There is no need to direct these wires. So just keep rotating. You can see my hand in this. So keep rotating. The wire will choose the channel. There is no need to direct these wires. So automatically the wire goes through the channel, and you see it reach distal true lumen, and you can finish. Sometimes you may not able to show the channel in angio, but still you can try a microchannel wire like filter XTR or A. So you can see here it reached distal true lumen. So whether there is a channel or not, you can try, microchannel wire. So what are the don'ts with these wires? You see this case, so a clear channel, but the wire went like this, and you can see how the wire is bending. So this is what we shouldn't do with these microchannel wires. It is the wire to rotate, it is not the wire to push. And you can see it is buckling, so that means it is in the subintima. So, and what happened? Subsequently, I have to go retrograde and finish off the case, but you can see here, so this is the vessel in IVS. It's completely, the dissected. So we shouldn't think these wires are benign. You can see there is an intramural hematoma. You can see it's a circumferential dissection of the vessel. That can happen with these microchannel wires. So, and why and when and where to escalate? So generally, escalation happens either at the proximal cap or within the CTO segment or at the distal cap. And the most common is actually proximal cap, because often that is the hardest portion. So you can see this case where it looks blunt, but there is a small cap if you see it closely. And the operator tried escalating to Gaia 3, and you can see how the guide is supporting. When he's trying to push the wire, guide is popping out. So these wires won't work the way you decide when the guide is not supporting. So you need to have a stable guide. So the wire went subintimally, and after 3 hours of effort, so they just came out. And what we did, you can see, there is an anchor wire, there is an anchor balloon, and guide is immobile now. So now you take a wire, right? Gaia 2, I have not taken Gaia 3. Take a Gaia 2 and position it into cap. And what you just check in fluoro. You can see here we are giving contrast. We checked Gaia is on the nipple of the proximal cap. Then push with the 2 fingers. So it's a direct with your hand and push with your left hand. That's how you have to use. These are the directable wires, and you have to directly push. So we entered, and then you can see here, we entered here and then progressed through the CTO and now reach distal true lumen, all with a good guide support. Then only it happens. So, and when the proximal cap is calcified, so like this, you can see it's a bit ambiguous cap, but there is calcium on either side of the proximal cap. So calcium will guide you. Obviously, you don't need an IVUS, and you can't even place IVUS also here. So, yeah, the course is clear, but the cap is calcified, and you can see the tram track calcium. So this is a Gaia. You can see the Gaia just slips into your side branch. So it won't really, you can't really penetrate such a calcified cap with these wires. So, and you have to escalate. So usual escalation, this is operator dependent. I usually escalate from Gaia 2 directly to Harnett 14. Very rarely I escalate to Gaia 3. So I escalated to Harnett 14. So this is Harnett 14. As already Dr. Goel mentioned, these are not the wires to really direct it or steer it. So it is just to perforate, and again you de-escalate back to your first wire. So we perforated proximal cap, you can see, and we made sure it is within the tram track calcium in orthogonal views, and then again you de-escalate, because you can't really track these kind of vessel with a Conquest Pro or a Harnett. You have to immediately de-escalate to Gaia 2 and advance with that 1 mm tip. So when you have such a proximal cap, you have to anticipate, balloon won't cross subsequently. So this is what happened, we have to do rota and then do subsequent procedure. Whether clear or ambiguous, when hard cap is there, you have to escalate and de-escalate. So you can see here, so this is an ambiguous cap. You can see this, we identified cap in IVUS, and there is a hyperechoic spot in the nipple of the cap. You can see here, this is a spot. And you see how the Gaia behaves. This is Gaia just buckled on the proximal cap. So Gaia just buckles on such caps. So because of the stiffness of the body of the wire, and you can see how the Harnett goes straight. And you go with the Harnett, perforate, and then go back with your Gaia and cross subsequently. So that's what we did, escalate and immediately de-escalate. And this is escalation to Harnett, then de-escalated, and Gaia, and reach distal true lumen and complete. And it's not recommended to continue the escalated wire, that is Harnett, to cross entire CTO body. So Harnett is just to remove the resistance and come back to your Gaia wires and go ahead. So this is my usual escalation and de-escalation in most of the cases. And when there is an ambiguous cap, here the rules will change. You can see this is an ambiguous hostile LED. Here, what is most important is the stiffness of the wire body. You see here, I'm trying to perforate with a Gaia, and I'm trying to perforate with Harnett here. So Gaia, after perforating, when you push it, it buckles and gets into your side branch. But Harnett, since the body is stiff, it just goes into the proximal cap. So you take an Harnett, enter the proximal cap, then immediately, once the puncture is done, this is how we shape the wire, and this is the angle, usually 40 to 60 degrees, and that depends on the angle of attack of the vessel. And once you entered into the vessel, so what you have to do is immediately, you have to send your microcatheter inside CTO and consolidate your position, then de-escalate to 1 mm tip wire, that is Gaia 2, and cross. You can see here, so once I de-escalate it, how dramatically the wire goes. So you can see here, I pushed, so just see, I pushed Gaia, just went into the distal true lumen. But the same thing, it doesn't happen if you continue with Harnett. So crossing CTO body, we target intimal crossing, but often 30% of the times it may not be intimal, but ultimately reaching distal true lumen is important. If there is calcium inside, probably you go subintimal. And if you are stuck inside the CTO body, again do escalate and de-escalate wherever you are stuck. And the next point of resistance in CTO is usually distal cap. So a distal cap is hard when there is a side branch at the distal cap like this, and also if there is a post-CABG patient where the graft is onto the vessel, the cap will be very hard. You can see this a patient where I'm crossing, LAD CTO. Gaia went to the distal cap and stuck there, and from there it veered off from the track, and this is a distal cap, but it's going off track. And then we have to escalate to Conquest Pro, you can see, and literally direct it into the distal true lumen. Yes, you can see the resistance is given off. So, and then you can de-escalate back and complete your position. See, when there is an ambiguous codes, escalation matrix completely changes because you don't know the codes. It can be this, or it can be this, or it can be this. Then it is very difficult to use a directable wire. And RCA gives often surprises to the operators. And you can see this is an RCA where we had an ambiguous course. And when primary operator tried, you can see this is how the wire went. A couple of minutes can I take? Yeah, so the best way is, I'll just go. The best way in this case is go with the wire. So pilot wire already Dr. Goel has presented in an ambiguous cap, escalation to pilot wire, pilot 200, and then embed your microcatheter into the proximal cap, then stabilize your guide and microcatheter, then take a knuckle, so you knuckle it, and send the knuckle till you cross all the loops. You can see how the loop is in the vessel. So these are the loops which you cannot cross with a directable wire because you often perforate and go out of the vessel. And then once your microcatheter crossed your distal loop, then you can bring back your Gaia 3 or Gaia 2 and track into the distal true lumen. That's what we did. So you can escalate, you embed microcatheter, you knuckle, and then redirect your directable wire, and you can reach. You can see how loopy is the RCA in this case. See, these are the final results. You can see the vessel, how loopy it is and how to cross. So when antegrade wire is in subintima, I think these are the things which you can do: parallel wiring, re-entry with Stingray, or tip detection ADR, or retrograde. And first three are mutually exclusive. And parallel wire, already enough was spoken by Dr. Goel, so I'll skip this. Always your second wire should be a higher tip load wire to cross, because we assume the first wire went subintimal because of the stiffness of the block. And sometimes we do de-escalate even in parallel wire, so it happens based on your field towards the block. To conclude, antegrade can be an initial strategy except in ioto-osteal CTOs. Unambiguous cap and clear distal vessel are prerequisites for predictable antegrade wire navigation. A clear cap and clear channel start with a channel tracking wire, and wire escalation pattern is operator dependent, and this is my typical escalation and de-escalation matrix. Ensure stable guide before wire escalation. De-escalation is preferred to avoid subintimal entry, especially when you puncture ambiguous cap. Anticipate and prepare for a hard distal cap in these scenarios, so where you need to escalate. Antegrade wire escalation ended in subintimal position. These are the solutions. And make an ambiguous cap unambiguous with IVIS. Penetrate and consolidate and de-escalate in an ambiguous cap. Have a clear plan for escalation in ambiguous codes. It's very important. Knuckle wire can overcome this. And escalate, embed, knuckle, and direct can be used in those scenarios. Thank you.
Thank you, Sharath, for that really good presentation explaining things. If anyone has any question? Yeah, sure.
Thank you for excellent lecture. I agree with your lecture, and so you focus on not only the wire escalation, but also the de-escalation. So it's very important. So because the city operator have to avoid the wire perforation during the procedure, your lecture to focus on the de-escalation. It is so nice lecture. Thank you.
Actually, if I can say two messages here. CTO, always understand the CTO as a proximal cap, body, and distal cap. Proximal cap is tough, distal cap is tough, body is always softer. So whatever strategies he's talking will be. And second thing is, the guide catheter support is the most crucial, I think. If you don't have a good guide catheter support, however stiff wire you may use, it will never go where you want it to go, and it will go the wrong direction, and you will end up as you should. I think, thank you, nice presentation. We'll move forward in the interest of time. So the next presenter is, I think it is parallel wire technique. Who's doing that? Show the program here. Huh? Oh, okay, sorry. I don't have that display here.
No problem. Okay. So, yeah. Before I begin with my speech, I would like to thank the IJCTO organizing committee for letting me a part of this wonderful event. And this topic really confused me, and I find it very really challenging, because I didn't get the understanding what is traditional parallel wiring and what is device-based parallel wiring. Then I guessed, as both are under the context of integrated wiring, it might be the Stingray-based approach or the recross-based approach, although it's an ADR approach according to the well-known nomenclature. And with your help, I will do my best to find out. Okay. I'm entering my data in the EuroC2 registry and Progress C2 registry. These are my credentials in the EuroC2 registry. I'm doing more than 300 cases per year, and my success rate has been increased since 2019. Considering the success rate around 80% with integrate techniques in the best expert hands, I think my improvement lays on switching very fast to retrograde after a failed parallel wiring technique. Parallel wiring is the last wiring technique, the last exit for me before I go to a retrograde attempt. And the EuroC2 registry defines parallel wiring as parallel wiring. I don't know any device-based parallel wiring definition. The request for entering the devices, where in this EuroC2 registry, as you can see, is Tornus, orbital atherectomy, IVL, crosspost, and Stingray are used for, the two of them are used for the device-based ADR. So here, these are my personal data in the Progress C2 registry. I use double more parallel wiring than it happens in the Progress C2 registry. Don't get deceived with my success rate. My MACE rate is a little bit higher as well. So the overall technical, in this paper, the overall technical and procedural success rate is around 80% with these two techniques. In the ADR arm, the Stingray was used in this paper, 70%. These are the data from the Progress C2 registry. And considering the over 90% contemporary success rate in modern C2 PCI, retrograde skills are needed to reach that goal. So my preference and recommendation is always switching to retrograde after failing traditional parallel wiring rather than device-based, so to say, Stingray-based or Recos-based ADR. Let me explain you my reasons. Although device-based crossing is an alternative to parallel wiring and has been well established in various algorithms, unfortunately it has no place in my crossing algorithm for various reasons. I'm coming from a relatively poor country. These devices are expensive and difficult to find, at least for me. And the device needs special training with a special certification program. And what is this for? This is for 80% procedural success rate, which is not much different from the parallel wiring. And I am not mentioning even not all CTOs are suitable for a device-based approach. So here, this is my approach. I have a very simple approach. I do a parallel wiring, and if it fails, I switch to retrograde approach. So, and in the Progress CTO registry, we have some definition about the parallel wiring. We have 2 wires, the classical parallel wiring. We have 2 wires, dual lumen microcatheter, and we have 2 wires seesaw. That's what I understood when I'm talking about parallel wiring. And this is an example with, my favorite is always using a dual lumen microcatheter. It could be a Sasuke, it could be a Fine Duo, whatever. So, and this is an example, CXCTO with a dual lumen microcatheter. And this is a filter XTA. You can see that the filter XTA is outside. It's in the extra plaque. According to the new nomenclature, we are refraining to label it as subintimal nowadays. It's going to take time to get used to it, but I'm trying it at least for myself. This is extra plaque, and then we have the Sasuke over the filter XTA. In parallel wiring, you know, you have to begin your stick, your second stick, with a stiffer wire, and you should begin from the proximal cap. If you do it in the dissection part, that's done not a parallel wiring, we can refer it to different ADR techniques then. You should always begin from the proximal cap parallel to the other first puncture. So as you can see here, the first one was filter XTA, and then I had a Corsair Confianza Pro 12 in action, and you see how it slides easily on the right panel into the true lumen. And we have to always check, because this is Confianza, we all know, you all know, that it can go easily outside and give the impression that you are really in, but you are not. And then here you have to check in 2 different positions, 2 orthogonal positions, to check that we are really in. So then the rest, you know, changing the Confianza with the Sion Blue over the Caravelle, and then after standing, this is the end result here. So then we have another scenario in parallel wiring. This is the classical one, defined very back 15, 20 years ago, so 15 years ago, so to say. So parallel wiring, we just leave the wire, the first wire in the extra plug space, and the second wire is going to be a stiffer wire, at least the same tip load wire, but it's better to have a stiffer wire. And then parallel to it, you go with the microcatheter, and then you try to find the true lumen in the distal vessel. So then we have the scenario 3. This is costly with 2 microcatheters. You have 2 single microcatheters for parallel wiring. The first microcatheter and the wire you leave in place, and then you try to puncture with the second microcatheter from the proximal cap again, and then find the true lumen. Here, it's an example. I'm not doing this. It was just to give an understanding what's going on with this kind of technique here. So then we have a seesaw technique. This is the scenario 4, and in this RCS CTO you can see that we had a ultimate bros. The ultimate bros, I can show you here. This is the laser pointer. The ultimate bros was here, extra plaque, and then this is the gladius that reached the distal part, but it is also extra plaque, and we have Sasuke dual lumen in place, which I said it's my favorite. I am doing always parallel wiring with dual lumen microcatheters. And then what I did, I brought the first wire, the monorail wire, a little bit back, and then try to re-enter with the ultimate process again. We can call this and try this in parallel wiring as well, but we don't have to invest much time for the sake of the success of the procedure. So this is we are checking. I am in the true lumen, and then come on. Okay, so okay, for the sake of the time, this is the end result. So, and this is another scenario again, scenario 1, Sasuke. After treating the donor artery, you see the LAD is filling. And then we have Gaia second is extra plaque, Sasuke and Gaia 3, Gaia third, and trying to find the true lumen with Gaia third. And this Gaia third was able to, you will see the jump, it was able to go into the diagonal, and the rest you know. And we had a complication here, and here I am in the diagonal, we checked it, and then we advanced Corsair Pro. But we had a problem here, we had a left main dissection, we had to stand the left main and the left CX for another procedure 1 or 2 days after, because we had lost a lot of contrast and a lot of time. So this is another example, Sasuke again. The rule is, it is always said that we have to take a stiffer wire than the first wire and parallel wiring, but you can also take the same wire. This was the Fielder XDR. It was in the side branch. And here, when you gain something, you should not lose it, okay? If you hit a true lumen, if you are in some kind of true lumen, you should always preserve that true lumen. That's at least my behavior. So I went into the side branch with Fielder XDR and then go over it with a microcatheter, and I change it with an extra support wire, and now at least I have the extra support wire and the true lumen. And then Sasuke over the first wire, and here, for the sake of the time, I am going very fast. With the same Fielder XDR, I had the true lumen. So what if scenario 1 fails? Here you have Fielder XDR extra plaque. Here you have Sasuke, Gaia Next parallel wiring. Gaia Next is out of the vessel. And I go a little bit fast. We are confirming we are out. And here I switch to retro very fast. And I will not bother you with this long recordings. Then we had the Mongo and the aorta. And we pushed it into the guiding catheter, and trapping micro-changing Mongo with RG3 after ballooning and standing. So I will finish on time, and here is my summary. If you don't use a device-by strategy, I mean ADR, it doesn't make you a less operator. Honestly, I don't know how to use a Stingray. I have tried it several times, but you have to master that. We have masters in ADR, Stingray ADR, and with these masters, we can reach 85% success rate. I know that from the Progress CTO registry result, but it's not a thing for me. On the contrary, it gives you the leverage to embark on invest on retrograde techniques, which will give you the opportunity to reach the success rate of the contemporary CTO communities. So my strategy is, if the dual lumen microcatheter parallel wiring fails, I switch fast to retrograde approach. Thank you for your attention.
Thank you for that nice presentation. I only might like to add that in the device base, today we have one more device, that is the recross catheter, which I think largely is working for a parallel wire type of a technique. Just that if in the regular two lumen catheter, if the second wire goes subintimal, you have to again redo the whole thing. Here you have the option of using 2 wires, in the sense one, and then if that doesn't go, you have a second option 180 degrees apart. So you can do 2 parallel wires.
I have used recross a lot. And RICOS is actually was introduced in the ADR community maybe as an alternative to string rate. Maybe that's the reason why I am not using this as a, I am considering this as a device for parallel wiring. They have also a dual lumen microcatheter recross, and yeah, recross can also be used. I've used it a lot in the past, but as I said, I don't waste too much time. Thank you very much.
Thank you. So I think primarily Stingray type of a device is for the distal vessel, and parallel wire is intra-CTO that you get back in. So I think with that we will move to the next talk, and the
So it's going to be the IVAS guided anti-grade approach. Oh, come on. Let all come up.
Okay, so thank you for invitation. I talk about the IVAS guided wiring. So there are two situations we require the IVAS guided wiring in anti-grade CTO PCI. Non-coaxial IVAS observation from the branch at the entrance, or the subintimal from the extra plug area to see the second guide wire to navigate the intra-plug route. This is a coaxial IVAS observation. So there are two techniques of the IVAS guided anti-grade wiring in CTO PCI. The one is the worldwide image-derived IVAS guided wiring. Check the location of the guide wire after several attempts at guide wire advancement while combining the IVAS and full image. But I think that this is the last result. So if you perform to do the real IVAS guided wiring, you have to do the tip direction method using the short tip pullback IVAS. So how to consider 3D image to do the tip direction method or diffusion, conventional one. So the wide wire was already inserted into a subintimal space like that, and you are just observing the IVAS from the subintimal space. Then you will advance the second guide wire. So this is an intra plug, and this is an extra plug, second guide wire here. So which direction you should rotate the second guide wire, torque? So the answer is undecided, because if the guide wire tip is directed right side, you should rotate clockwise, a little bit pull back and pull back clockwise to trace the intra-plug route. But if the guide wire tip is directed left side, you should a little bit pull back and rotate counterclockwise. This is the 3D wiring IVAS guided method. So observe the guide wire tip, not the shaft, to perform the 3D wiring in CTO region. Tip is very important observation. So there are two methods, image-derived IVAS guided wiring. So these are the performed maybe more than 20 years. This is the last result. No accuracy. So if you perform the real-time work IVAS guided wiring, you should do the tip detection method, and also you should need the short tip pullback IVAS. So just now these IVAS are available in Japan, but inside the in Japan, we definitely use only anti-wall IVAS, short tip pullback IVAS. I made it for tip detection method in this IVAS guided wiring. But the outside of Japan, I think that the optical, long tip, and the image quality is relatively low. Today I did the intervention using this IVAS, but I failed. So some limitations are here. But anyway, I'll talk about the old ones, not accuracy one. So you have to use the angiographic image and IVAS image and to make the fusion in your brain and decide which direction you should direct. So this is very complex. Maybe that is the last result. So if we perform to do the real-time IVAS guide wiring, you should use the tip detection method. Today, to see the guide wire by IVAS means to see only the guide wire shot. But no, you should see the guide wire tip until after guide wire disappears. So this is a tip detection method. If you observe the guide wire tip like this, sharp tip using the pullback system, short tip fibers, you can see the guide wire location inside the plug. So counterclockwise, you can get the target. Sharp and tip, sharp tip, and the target here counterclockwise, and the lower side clockwise.
Can you get the laser pointer up?
Sorry.
Because we can't see what you're pointing.
Okay.
Sorry about that.
Okay.
Yeah.
Okay.
You get the laser. Someone can help you get the laser.
So this is the interplug. Is that okay?
Yeah. Yes,
is
it's
that
come.
okay?
Now it has come.
Okay.
Yes.
Sorry. So this is the interplug tracking. So the target is here, and the guide wire is the right side. So I will pull back the guide wire 1 centimeter. It doesn't work. Okay. So I direct the guide wire tip counterclockwise to get a target, like this. Then get a target. This is a very precise guide wire manipulation, but it definitely needs, you should see the guide wire tip real-timely like this, using the back and forth movement of the transducer. So, and also if there is this is an uncoaxial IBUS guided image. So if we perform this one, the target of the branch is located here, and guide wire tip is located here. You should see the guide wire tip. So direct the guide wire tip to the target. So this is a coaxial guide wire observation. Maybe this can be worked in this here because of obstacles. So this is the data of the intraplug tracking using the coaxial IBUS observation tip detection method. So in Japan, in my hospital, the success rate of the tip detection intraplug tracking is at 93%. But by the conventional guide wiring fusion method, only 60%. So the tip detection method is definitely needed. And also, in case of the 30 cases, 2 cases I succeeded in the tip detection ADR. This is accident. But this is the extra plug area, and this is a tool lumen. So I direct the guide wire tip to the target, like that. So that is also very important, to direct the guide wire tip vertically to the barrier, then penetrate the barrier. That image is very important. So this is a tip detection ADR. So we have to find that the several vertical penetration by guide wire tip penetrates the wall between the extra plug and the intraplug root, like that. But the vertical penetration is very important. You have to see the guide wire tip correctly, and you have to understand which direction you should rotate the guide wire. That's very important. If you can do it, you can penetrate. So, so this is the advantage of the tip detection ADR. So you can see the distal image by using the IBUS. So that's why, because of the IBUS observation, the tip detection method allows for the vertical puncture to the intended point and more proximal point, resulting in the reliable and ideal entry. And if we use the Conquest ST wire, that is the ADR wire from Asahi company, so you can penetrate regardless of the wall thickness, and also even you can penetrate the CTO body like this. So this is the data of the tip detection ADR data in our hospital, including the 3 other hospitals in Japan. So, so I also did Stingray ADR 27 cases and compared the tip detection ADR cases by Conquest ST wires 27 cases. The success rate of the Stingray for me 67%. But the tip detection ADR by the Conquest ST wire was 100%. So, yeah, this is a collapsed the tool lumen, but the accurate guide wire, the direction to the target and penetrate, you can penetrate And also, this is a CTO body, and this is a cultural region. Maybe if you wanted to do the ADR, you direct the guide wire tip correctly to the target using the tip detection method. So this is a Conquest ST wire. And also I did a Conquest 20 wire, I did it. Anyway, if you can learn 3D wiring method in English, I already wrote 3D wiring method in CTO PCI, and also I made YouTube videos. In conclusion, IBUS standards improve the wiring, and the tip detection method enabled accurate and reliable wiring in CTO PCI. But today I failed using the Boston IBUS. Maybe I thought that short tip pullback IBUS and the tip detection method is needed to do this method. Just now some regulation is here, but I want to introduce this method to India. So thank you for your attention.
Yeah, thank you, Dr. Okamura. I have only one question to you. How do you differentiate between the body of the wire and the tip? Because as I can understand in IBUS, when I see the wire, firstly is to locate that this is where the wire is. Then the wire gives you a reverberation all the way back, that shadowing is there. Now, and that wire that you see is like a circle because you see a cut section of the wire. How do you know that this wire firstly is the tip or the shaft, and then it is the tip, and where is it directed? It's something like, I hope you know, I talk a little about 3D wiring on angiography. And because in angiogram, you can see the shaft separate and the tip separate. So using same principles, that's how we have worked out. Now, how do you differentiate, if you could help us?
Okay, so the important thing is to make the image of the tip, only the tip, and until it disappears. You have to advance the transducer to distal part, and the tip is disappear. So that is the tip, apex of the tip. Then if you pull back a little bit the transducer, tip, maybe came to the shaft. So, and the important point is, only see the guide wire tip and to direct, like this. Maybe no need of the shaft, just the tip.
So then you only need an anti-towel IBUS, because unless that's the one which can go till the tip.
Yes.
Otherwise, other IBUSs cannot show that. That's why probably you couldn't succeed today, as you said, with Boston.
So you mean that a pullback system is needed?
No, all the IBUSs, the imaging is about 20 millimeter or 15 millimeter behind the tip.
Yes.
But anti-towel, as I know, is visualizing almost at the tip of that transducer.
Yes.
That is the difference.
Yes.
Okay. I think if there's any question from the floor, we can address that.
Yes, great presentation, Dr. Okamura. So how do you decide, like, what is the location of the entry of the tip into the true lumen? So when you run IBUS up and down, there will be a long segment of subintimal space. Then you will see your wire somewhere not into the true lumen by the side. And how do you decide which location, like in relation to the IBUS and the true lumen?
Yes.
Where you want to do a transverse puncture, like anything like closer to IBUS or?
Yes. So the beyond the exit side of the CTO site, I try to penetrate the guide wire to the true lumen, because beyond the CTO side, you can see the true lumen, just beyond the exit. So I try to penetrate the guide wire, very close to the exit side, because to preserve the branch flow. Difficult, distal.
So it will be like a re-entry.
Yes.
It's not a parallel wire. It's a re-entry.
Re-entry. I try to do the intra-plug tracking, but sometimes difficult. I just only do the re-entry just beyond the CTO exit. You can see the true lumen. So closer is better. So try cross point. Difficult, distal.
Just at the distal cap, almost at the distal cap.
Thank you.
Okay. I think he'll be here for 2 days. We can discuss more about it. Next talk
Dr. Arun Kalyan Sundaram is going to talk about ADR wire-based versus device-based approach.
Good evening, everyone. So I thought this was a fellows course, and I'm so glad Professor Okamura Sensei did the talk on device-based ADR with IVIS. So, I'm going to take a little. This is not a talk against antigrade wire escalation. This is not a talk against retrograde. So I do believe that you should be comfortable in all aspects of CTO PCI. And given the time, I'm just going to go over, the basics of a lot of these things. And the short answer is, if you're going to talk about wire-based ADR versus device-based, I do believe there are roles for both. So, going back to the basics, you have the last technique, which is, the first three are pretty much wire-based techniques. You have star, mini-star. Mini-star was basically an evolution from star. These are basically wire-based strategies to re-enter the true lumen after you get into the subintimal space. Now, the problem with wire-based strategies, and it got a lot of bad press because you don't control where exactly you re-enter. So it's not a controlled or a targeted re-entry. About almost 15 years ago was when I think crossbar stingray got introduced in the world, and it was kind of a game changer at that point because for the first time it actually allowed precise re-entry. So that's 4.5, and now you have recross, and I think Traverse is another device that's going to come out pretty soon. So the key is, this is actually from the Art of War, there is a role for each, and I think understanding what specifically is needed where is very important for you to do CTO successfully. Why was this talk about dissection reentry? I think basically the prevailing wisdom is that when you have a long plus CTO segment, what do we mean by that? You have a really long CTO segment, you have an extremely calcific vessel, you have an ambiguous course or an extremely tortuous course, or let's say someone who is an expert has already tried to wire and failed, then the idea and the rationale, and I think Dr. Reddy also showed this in his talk, you use a knuckle to traverse the CTO segment in a safe manner, and once you get to the re-entry zone, you'll re-enter. Now, it's about safety. There is a role now, APCTO club algorithm, pretty much the global CTO algorithm, we've all kind of said, all right, there is a place where you do dissection reentry and you do this with pretty much a device-based system because it's more targeted. And if it doesn't work, you do what we call subintimal plaque modification or an investment procedure, live to fight another day. There's a lot of bad press against ADR because, this hematoma was always an issue. It was not always controlled because you don't have control over the distal segment, right? You don't have control. Unlike retrograde, you don't have control of the segment beyond the CTO body itself. Again, extremely calcific vessels is very challenging. I think Tuchkani Sensei published a paper where he basically showed that it's really hard when you're re-entering through an extremely calcific area. And you needed bigger guides. Typically, I think initially we all did 8 French guides, and I think most of the Asian population and most of the Asian doctors use 7 French. And you really wanted, we were kind of going into good targets. So I'm going to kind of just tell you that the field has moved forward. Again, before I get into device-based, I'm going to just briefly show you one wire-based ADR case. So this was a case I did a couple of years ago, actually in Hyderabad. So there was a post-bypass LAD CTO, and this was supposed to be for a workshop, so it was supposed to be an ADR case because the patient's already, no great retrograde options really except through a graft and a really tortuous epicardial collateral. So the idea was, okay, I'm going to just go knuckle. It was really long, so I didn't even try to wire this. So this case was microcatheter, knuckle, big knuckle, nothing elegant, going down, confirming that I'm in the vessel architecture, and I got the microcatheter down. And at this point, I'm like, okay, I'm going to get the stingray, I'm going to re-enter, but then I found out that we actually didn't have a stingray at that point for whatever reason in this hospital. So basically, the old way was we used to do it over Miracle 12, got the And then you can see that I'm in the vessel architecture, but I'm far into the LAD. So at this point, I don't know if I actually ended up doing parallel wire or if it was ADR, but basically I took a dual lumen catheter and took a Confiance Pro 12 and essentially wired into the LAD. Confirmed that I was in the position. As you can see, that is the place where I re-entered, exchanged it for a workhorse wire, and then ended up stenting it. Of course, you lost branches. So the point is, you should know how to wire, and this is not a talk against that at all. The other thing is, why do we talk about STAR? STAR has really made a resurgence. There are lots of studies that are ongoing about if STAR still has a role, and can we do deferred stenting? The problem with STAR was people stented right off the bat, and then you ended up losing side branches, and we don't want to lose side branches. So here was a LAD, so there you can see the knuckle just going in, and this is how it looked 4 weeks later, and after PCI, you got a much better result, right? So don't be in a rush to stent if you do STAR. What is the current role for STAR? And just for the fellows in the room, essentially what you're doing is taking a wire and just really shoving it in so that it just re-enters at some point into the true lumen. And the purpose is to cross the CTO segment and gain entry into the true lumen. The flip side is, it's not controlled, right? So when you have really complex anatomy, you're failing in ADR, you're failing in retrograde, it can be used as a salvage procedure. The key is don't stent at that point. Oh, okay. So now we go on to device-based. This is like the granddaddy is crossbar Stingray. Barely use crossbars these days. I mean, I think with newer wires and knuckles and having the Mongo or the MG14 wire, I don't think I've touched a crossbars in the last several years. You could still do it if money is no object in ISR, etc. But that's how it looks. And you spin it really fast, but the long and short of it is you penetrate the proximal cap, deliver your microcatheter, and then here, I'm just gonna, in the interest of time, I'm just gonna go there. Upfront use of knuckles and trap liners, and that really helps. Trap liner is available in India, by the way. It's basically nothing but a guide extension catheter and a balloon that's in there. So if you don't have it, you can use a guide extension catheter and a balloon. The idea is to block your inflow so that you don't expose the subintimal space to systemic pressure, because that has a higher chance of resulting in a hematoma. So just moving on. So you're basically using knuckles or crossbars or whatever else you want to use to get to the reentry zone. So you want to be in positions 4 or 5, right? And then once you're there, if you're in 5, you're already in the true lumen, great. If you're in 4, you just need to re-enter. And Stingray, basically between the proximal and the mid port is just about 1 millimeter. So within a 1 millimeter precision, you can re-enter exactly where you want to into the true lumen. And so once you're here, these days we use the MG14, you're in the landing zone. Essentially take your Stingray and stick and drive. I'm going to show you what I mean by that. You have to be in the right orientation. The balloon orientates as it wants. You don't want the one on the right, you want the one on the left where you see a single line and 2 dots. Because there you know that you have to either go above or below. Because this way you know where the vessel is. How do you know where the vessel is? Typically, just to keep it simple, you take a retrograde injection, not an antegrade injection. You know where the vessel is in relationship to the balloon, and then you use the balloon to re-enter. So this is just, again, from many years ago, actually 2017, geez, I'm getting old. Okay. So essentially what you do here is, you know that the balloon is here, you know from a retrograde shot that the vessel was higher up, and so you take the port that goes up. So that's just to show you how you penetrate, and this is, I'm just going to let this play for a second. Okay, yeah. So you stick really hard, and that's how it looks when you take it out. It either goes through this hole or the mid hole, okay? So we used to always stick and swap. There's still times when we stick and swap, but for the most part, with newer wires, you can stick and drive. I don't use the Stingray wire anymore, and I think most of the operators have moved on. There are lots of other wires, and I'm going to tell you what has changed. This, again, is from a couple of years ago. The idea in this case, let me just play this here. This is a Circ CTO, where there were really no good retrograde options. It was a longish lesion. So initial, because of the ambiguity of the cap, IVUS was used to penetrate the proximal cap. As you can see, around 11 o'clock is where you made a true good entry, but then it was really hard to wire it. So at this point, what we did was basically tried wiring for a while and we're nowhere in the vessel architecture. As you can see, that's the target, and that's not a great target. So at this point, used a knuckle to traverse the CTO segment, and you know it's in the vessel architecture. Typically, you don't inject through the same, you don't do antegrade injections, but in this case, this was a live case, so we kind of had to for a lot of reasons. But once you're in there, basically that's the 2 dots that you see, the stingray balloon, and you take it down all the way. You can see it come down here. And then you can see that that's the wrong orientation. I think I've labeled it already. And you don't know if I should go above or below, but this is a double stick and drive. So initially I tried to do a blinded double stick and swap it out for a pilot, but I couldn't. So then I just used a Conquest Pro 12 to stick and drive, and there it is. So that was the proximal hole, and we were able to secure both the branches. You exchange, once you've crossed the CTO segment, you always exchange for a workhorse wire, confirm that you're in, secure both branches. That's at 12 o'clock is the true lumen. Here is the true lumen. Somewhere in the middle, that's subintimal, as you can clearly see. Between 3 and 6 is where the true lumen is compressed, and more proximally, again, true lumen. Again, the other thing in the remaining few seconds I have is to show you guys that it used to be believed you needed a good landing zone. These days, you really don't need to. And so in this particular case, this is an RCA CTO. Again, you're not going to get the whole shebang here, but at least you will know that this is a proof of concept. You know that you can re-enter in a lot of segments, so I want the fellows in the next gen to be more interested in CTOs. So here, basically, knuckle is a super long CTO segment, so you're just wiring knuckle all the way, and you don't want to lose either branch, right? So at this point, I just want to play this here. You actually re-enter before you see where the vessel itself is, and once you're there, you basically, again, stick and drive it and exchange for a workhorse wire. The rest is just PCI, so that's the end. A few other points. I do want to tell you guys that there are times where there is no way in hell I could have done this case any way other than with ADR. It's a post-bypass, proximal cap ambiguity, with a diseased SVG, which essentially means I can't go retrograde through that graft because the patient will just decompensate. And so that, I just want you to pay attention to the top right. That's the part where we could re-enter. So just to tell you that once you do this enough number of times, you will get better, just like anything else. The first time we wired a straightforward lesion, we sucked. But eventually you get better. So it's a question of how much you practice, right? So this is another case, low EF, surgical turn down, viable LAD. And I just want to, again, just showing you that that's the only way you can do this, because unless you put in an impeller and try for retrograde, which would have been an option, but the patient couldn't afford an impeller. So what has changed? You can do it with smaller guides. We don't use crossbars anymore. And I think, with the Stingray LP has pretty much taken over. We don't stick and swap that much anymore. You manage hematoma really, really well. There are lots of algorithms for problem solving, for your proximal cap ambiguity, for et cetera, et cetera. Again, I can't get into all of that right now. You do it for long plus. There are operators all over the world. And again, I'm going to kind of skip this in the interest of time. But what I want to tell you is that there are newer techniques. You could do facilitated cart, et cetera, et cetera. Okay. Recross catheter is another, just one more minute and I'll just be done. That's another device that is used for ADR, or you can use it for parallel wire. Essentially, when you're subintimal, let me just show you how this is. Essentially, you have a distal port, and it's kind of like a poor man's Stingray. It works because in India, you could reuse it for a couple of times, but the ports, this port and this port are, again, 180 degrees offset. The wire can go here or to the distal, and this is another lumen. So it's essentially a double lumen, triple port exit. So essentially, you could still do ADR, you could do reentry, you could do parallel wire, etc., using this device. So again, just want to show you that this can be done. So I just want to I want you to pay attention to this particular movie file where essentially we are subintimal, just used a recross to basically get back in, okay? So anyways, this is all good. Going to my conclusion. You really need to know all techniques for you to treat the right patients, the right tools, get all the skill sets, including, you know, getting really proficient with IVUS. As you can see, for you to be able to do IVUS based reentry or IVUS-based getting into the true lumen, you want to be comfortable with IVUS in the first place, right? So if in your institution you're not getting trained in that at all, then you're obviously not going to be able to do anything else. So anyways, thank you very much. That'll be done. Thanks. Use the other one.
Okay, so good presentation. Your use of ADR is increasing, reducing, same? I'm just wondering the future of this ADR.
So, I mean, the problem is I don't get a lot of wire escalation cases. So, I mean, I would say ADR has kind of been consistent. I would say with Recross and with Stingray, its usage has probably been about 30% or so. At least in the last one when we put it in progress, that's kind of how my numbers were.
Actually, Recross and all, they are more of a salvage procedure. You are trying to work intraluminal, but you get subintimal, then you get a Recross in. But elective knuckling and ADR, what I feel is that you electively have given up the option of intraluminal wiring. That's the only, and that's the reason you don't do it. Well, I may not do it, I will just continue, but have these as an option once I get subintimal.
So it really depends, Dr. Goel. Like, I mean, I completely agree, and just so that for people that are learning, I think everyone in the room will agree that our goal is to try and stay intraluminal, or intraplaque at least, not to go into the subintimal space unless you have to. But I think the accepted wisdom these days, and globally, I would argue that when you have a CTO segment that is ridiculous, that's like a 100 millimeter CTO segment in your RCA, I mean, the probability of you wiring it in 2 hours is close to zero. I don't care how much of an expert you are. So in those cases, I think you make an upfront strategy that I'm going to use a knuckle to traverse this long segment.
Yeah, if it's a real long segment CTO. Okay.
And also, recross, I completely agree, is more when you are in bailout, when you're salvage stuff.
Yes.
For a dedicated true ADR where you have knuckled and etc., I would still go with Stingray.
Yeah, but that I would do maybe if it's a really long CTO.
Yep.
And retrograde option is not there.
Sounds good.
Okay. Any other question from the floor? Okay, thank you. So I think we had a good conclusion on antegrade techniques, and I think we'll move forward to retrograde in the next session. So, Dr. One more presentation, but one more was not here.
One more, and I'm talking about antegrade techniques.
It's a base operation CTO PCI by Golar.
So I'm going to talk about base. And by base, I mean balloon-assisted subintimal entry. So this is another antegrade technique. And having just heard a statement which is we try and stay within the true lumen of the CTO, I'm going to tell you how to get round the true lumen. Because I think my thoughts about CTO PCI is that the end game is about getting an open artery, but getting an open artery as quickly, efficiently, and safely as you can. And I believe that sometimes you have to do that in the subintimal space. So I think talking purely about the base procedure for 12 minutes is more than I can possibly do. So I'm actually going to talk about how you manage the proximal cap, and the base procedure will be part of that. So let's just start with the very basics, talking about the proximal cap. So the proximal cap is where we start. It is the area of maximum resistance in a CTO because it's exposed to aortic pressures. And we all know that it's fibrous and it's calcified and it's often very, very difficult to get through. So as a CTO operator, we've got 3 challenges. We need to understand, so we need to be able to identify the proximal cap.
then we need to be able to penetrate it with a wire, and then we need to be able to cross it with equipment. But I just want to ask you all a question. If we know that the proximal cap is the hardest and toughest part of a CTO to get through, why are we spending all of our time trying to get through it? Is there another and more efficient way? I'm just going to leave that kind of sitting on you all to think about as I talk for the next 10 minutes. So, the first part of managing the proximal cap is to identify the proximal cap. So I thought I'd show you an angiogram. This is a patient of mine with what I would call an ambiguous proximal cap. So the first thing to do is to try and identify this with IVUS. So we've opened things out, and that's not helped me greatly. So where's the proximal cap here? Is it here? Is it here? Is it here? To be honest, I don't really know. So to start angiographically and to complete this procedure antegrade, I think is quite difficult. So what options do we have? And we've heard a number of talks about IVUS, so I'm not going to spend too much time. In the interest of time, I'll just skip on. But you can use IVUS to identify the proximal cap. Your next option is to come retrograde. So you can bring retrograde equipment through, and you can knuckle up, and you can define your proximal cap with retrograde equipment, and then bring in your antegrade system and puncture onto your retrograde equipment. And here you can see we've made a puncture, brought the microcatheter through, and then taken a soft wire, knuckled down. We've got two systems in a subinterval space, and we're set up very nicely for reverse cart. So we've elegantly got around the inability to identify the proximal cap by using a retrograde system. But I think most people who are doing a lot of CTO will be in a situation, not uncommonly, where they can't identify the proximal cap, either with angiography or with IVUS, and often not able to get retrograde. So what do we do then? What is the solution? So all of you who want to stay within the lumen, you can't start within the lumen, you can't puncture the cap, so how do you get around it? So you have to be able to think in a different way. Again, I'll answer the question here a little bit later. So I've talked about the ambiguous cap and how we identify it. The next problem we're going to find is the resistant cap, and I'm calling it the resistant cap because it's an impenetrable cap or it's an uncrossable cap. So another case from my practice. So we'll just focus on the panel on the left-hand side, and you can see a severely calcified right coronary artery, heavily calcified cap. We've got ipsilateral collaterals off the proximal right coronary artery to the distal vessel. And if you then look at the panel on the right, you can see that there is a wire in the side branch, which I was using as part of my escalation to try and cross the cap. And I've reached a point where I've got a coaxial balloon anchor and a microcatheter and an IJCTO20 to penetrate the proximal cap, but then I was completely unable to bring my microcatheter across. So what now? And again, I'm going to leave that hanging as well. So if we think about the resistant cap, what are the challenges to dealing with it? Well, the first is to have adequate support. Then we need to be able to penetrate the cap with a sufficiently stiff wire. And then we need to have some way of crossing the CTO segment with a microcatheter or a balloon. So what can we do to augment penetration force at the proximal cap? Now, we've seen some of these diagrams earlier talking about using a dual lumen microcatheter. So if we've got a handily placed side branch, which we often do in CTO, we can drop a workhorse wire into our side branch, bring through our dual lumen microcatheter, and then we can use a penetrative wire to puncture into the CTO. And just giving you an example of this in a silicon model. So at the top, you can see an attempt to cross a proximal cap using a standard microcatheter and a Confianza Pro 12. And you can see that the microcatheter is being pushed back. But by using, sorry, I'll just go back one. By using the dual lumen microcatheter, sorry, over quick with my fingers. By using the dual lumen microcatheter, and you actually put an anchor wire in a side branch, you fix the microcatheter and you allow the wire to penetrate the proximal cap of the occlusion model. So hopefully I can make that play there. So you see how the microcatheter, or the dual lumen microcatheter, isn't being kicked back, and you have enough support now on the wire tip to allow it to make contact with the proximal cap in this silica model and now the wire will cross the proximal cap. So if you have a side branch, a dual lumen microcatheter is a way to increase support to allow you to penetrate a resistant proximal cap. And just to show you that in graphical terms, the red line being a standard microcatheter and the support, and the blue line being a dual lumen microcatheter. And you can see there's much more support to a stiff penetrative wire through a dual lumen microcatheter. But sometimes we don't have a handily paced side branch, so what can we do then? What's our algorithm for increasing penetration force at the proximal cap? Well, we're going to start with a microcatheter and a stiff wire, and if that fails, well then we can put in a side branch anchor. If that fails, we can take a guide extension catheter down as close to the proximal cap if it's anatomically possible. And if that fails, we've got the option of a coaxial anchor, and by coaxial anchor I mean a balloon in the target vessel pinning the microcatheter against the wall, and I think that gives the most support to allow you to puncture a proximal cap. So, when I talk about optimizing crossing, we need to think about support, we need to think about the devices we're using, and is there anything we can do to modify the proximal cap? So in terms of support, well, we can think about guide extensions, anchor balloons. When we think about devices, well, we can think about our microcatheters. We've got lots of different types of microcatheters, as we heard earlier. We can try lower profile microcatheters. We can try things like the Turnpike Spiral, which has a braid, which will grip the lesion. We can escalate that to a Turnpike Gold, which has this screw that goes from the tip, which may screw in and modify the proximal cap. Or we can try a small balloon to modify the lesion to allow us to get equipment through. And if all of these things have failed, then we can think about proximal cap modification techniques. So we've got balloon-assisted modification, and by that we mean basically bursting a balloon that is driven into the proximal cap, hoping to get micro-dissections in the proximal cap and change the penetration properties of a microcatheter that comes in afterwards. And our last option is a Carlino, and by a Carlino we mean a forceful injection of contrast out of the tip of a microcatheter into the proximal cap, trying to change the characteristics of the proximal cap. So I've talked about the resistant proximal cap, and I've talked about trying to get through, so increasing your support, and then in trying to increase your penetration power, or try different techniques to modify the proximal cap. But what if you just can't get through? So when we talk about the base procedure, what we're really talking about are strategies to go round the proximal cap, the so-called move the cap techniques. So the move the cap techniques, I think there's really 3 of them in conventional practice. There's scratch and go, which I don't want to talk about in any great detail here, but what we're really doing in the scratch and go is taking a penetrative microcatheter and driving it into the wall of the artery proximal to the proximal cap, and then driving the microcatheter into the wall, and then we follow the microcatheter by pushing on a soft polymeric wire to try and create a dissection plane. And I've never felt overly comfortable with scratch and go. So I've really reverted to the balloon-assisted subinterval entry methods of base and side base. So for those of you who are unfamiliar, let me just explain the techniques. So what we're trying to do is we're going to take down a 1-to-1 NC balloon, and we're trying to create micro dissections in the vessel proximal to the proximal cap. And then we'll come back with a microcatheter and a soft polymeric wire, and we will try and access those dissections and dissect around the proximal cap into a subintimal course. So showing you that in real time, taking you back to that case of mine, heavily calcified vessel, unable to really penetrate with an IJCTO20, and unable to move a microcatheter behind it. So pretty stuck here, no way of completing this case. So how did we get it done? Well, so moving on and taking you into where we are in the case now, we've now brought in a second guide. We have a retrograde system through those ipsilateral collaterals and a wire into the distal vessel, knuckled at the distal cap. And then I've used an intravascular lithoplasty balloon to disrupt the proximal vessel. And then I've taken a 1-to-1 NC balloon down to pin my microcatheter. And I've taken a gladius wire, and I'm pushing hard on the gladius wire to try and enter some dissection plane that I've created in the proximal vessel. And then you see this wire start to knuckle and loop behind the balloon and go around all of that calcium that's been previously impenetrable. And then we get to a position where we have 2 overlapping knuckles, and we can perform reverse cart. And this was the end result. And I think without dissecting around the cap in this case, there was no way of finishing this case. So, I've shown base there as a way of completing a case when I'm in a failure mode, but why not from the start? And I think we do have this fixed mindset that dissection and re-entry techniques are our last resort, but sometimes I think they just make the case far quicker, far more efficient, and actually safer. And I just want to say it's not about ADR. Sometimes I use this technique to facilitate retrograde procedures and get two systems in the same space much quicker and much more efficiently. So I've talked about base. A modification of base is side base. So this is using a side branch and protecting the side branch with a balloon. So in side base, what we do is we use a 1-to-1 NC balloon proximal to the side branch. We create dissection planes. We then protect the side branch using a balloon, and we try and get a knuckled wire to pass behind the balloon and behind the side branch. So just an example of this in real time. So we've got an ambiguous proximal cap. We've done some ballooning. We block the side branch. Sorry, let me just go back one. And we push on a knuckle, and you see the knuckle come behind the balloon into the architecture of the right coronary artery. And from here, contralateral injection to show that I'm within the architecture of the artery. From here, I can perform ADR. This was Stingray ADR, and a good result, very efficiently, very quickly. So I'm going to stop at that point, and I'm going to say the three key aspects of managing a proximal cap. Well, you have to be able to define it, you have to be able to penetrate it, and you have to be able to cross it. But sometimes you can't do any of these. So you need to change the way that you think about things. You need to think about your skill sets, and you need to be prepared to have a growth mindset and to think about using the subintimal space earlier and to bring this into your algorithm if you want to get quick, safe, efficient procedures. Thanks, I'll stop there.
Thank you for the excellent lecture. And I have one question about what is your favorite wire favorite wire? Sorry, favorite. Favorite
my
wire.
favorite wire?
Yeah, to make a subintima.
Yeah, normally it's going to be a Gladius MG. So I quite like a Gladius MG, which will normally pick up what are these dissection planes. So yeah, the Gladius Mongo behind a balloon to pick up one of the micro dissections and get going.
Okay, thank you. So my favorite is XTA because I don't want to make a perforation, but the wire have to have some hardness of to make a subintima. So my favorite is XTA. Yeah. Thank you.
I think you have to have enough body to the wire to be able to get into the subintimal space. Okay. And XTA, I think, is fine. It works.
Thank you.
Thank you.
Okay, I think we will close this session. We'll move to the next session in the interest of time. Thank you.
Yeah, thank you very much, Dr. Goel, sir, Dr. Rajesh Vijayvargiya, sir, Dr. Hayashi. We'll go for the next session. Antigrade is understood. Let's see what's happened in retrograde and what not to do, what to do. May I invite the chairpersons, Dr. V. Suryaprakash Rao, Dr. Okumura, Dr. Rath, Dr. Ajay Swami, and Dr. Hazra. We'll be having 4 speakers, Dr. N. Pratap Kumar, Dr. Sanjog Kalra, Dr. Dash, and Dr. Nagamatsu. We'll be starting with Dr. N. Pratap Kumar. Request the chairpersons to please kindly take over the scientific agenda forward.
Not sticking on to the time.
And please stick to the time, Dr. N. Pratap Kumar, sir. Request.
So can I go ahead?
So retrograde step, CTO, PCI, step by step. The overall success rate of an antegrade CTO actually is 63 to 66%. Earlier CTO trials have a low success rate. Recent CTO studies have a high success rate because when they combine the antegrade and retrograde together, the success rate has gone up. So when you do antegrade alone, the success is 76%, but you can become 96% by retrograde. Retrograde approach increases the success rate in CTO PCI. It increases risk of complications and should be performed by experienced operator and centers. When you look at the stages of stage 1, 2, 3, and 4, stage 3 comes the retrograde CTO PCI. Before that, antegrade and antegrade dissection re-entry. When should I consider a retrograde attempt? The Asia Pacific CTO PCI shows there is a retrograde approach coming here. Primary approach, it can be a proximal cap ambiguity. You have a bifurcation of the distal cap, a diffusely diseased distal vessel, a difficult to engage a CTO vessel, and a flush aortic ostial occlusion. And also, secondarily, when you have a failed antegrade attempt. The change of crossing strategy, the flexibility is an important point for the CTO's success. Avoid getting stuck in a single strategy. Starting a retrograde CTO attempt, you can have a short retrograde guide catheter, 90 centimeters, which is not required because we have reaching the collateral circulation with the larger or longer microcatheters are available now. So workhorse wire through a long microcatheter, 150 centimeters, will make your life better. Before starting retrograde, assess the risk of ischemia. You should look at the lesion of the Lorna vessel proximal to the collateral origin and a dominant collateral, that is a single collateral, risk of ischemia to be covered. Donor vessel, keep a guide wire placed as a safety measure. When you actually do a retrograde CTO coming up to the LAD CTO, you have to keep a wire in the circumflex vessel. How to choose a collateral channel? That is a crucial step in retrograde CTO PCI. You should have an appropriate interventional collateral. What is the definition of an appropriate interventional collateral? Presence of at least one collateral channel, which from an angiographic appearance alone is considered suitable to deliver an interventional equipment from the donor vessel to the target vessel beyond the occluded segment by an operator experienced in retrograde CTO technique. You can actually, this is a CTO segment from you have a RCA CTO on the left side where the collateral coming from the LAD to that one. And if you actually the same thing, an LAD CTO, the collateral coming from the LPDA, RPDA to the LAD. So the optimal collateral is actually, you have a clear connection, no side branches, no tortuosity, and you have an angle more than 90 in both recipient exit as well, vessel and donor exit. Basically, the channel size should be large enough initially to start the collateral, and tortuosity should be less tortuous, and angle of attack should be less than 45, and length to emerging point, when you just reach the retrograde channel in the recipient vessel, and that should be longer than 5 millimeters. In a septal channel, the areocranial and areocaudal projections are the better projections, and you can have even a plain areo projection. For example, in epicardial, you have to go to areocranial and epicranial. Be clear about the collateral anatomy. You should have a selective injection of the contrast to the collateral, or you can balloon occlude the collaterals to see if more favorable collaterals can be recruited if the first collateral is not seen well. So this is actually a classical picture of a B-shaped thumb of the turn of the wire which is coming from the LAD CTO to RCA CTO. How do you select a collateral? It's a large non-tortuous collateral is the best thing. You can occlude the collateral with a small balloon in the main donor vessel for 2 to 4 minutes. You can actually, when unfavorable non-intervention collaterals can also provide dominant blood flow to the CTO segment. You should have actually assessed every collateral these things. 1, size, tortuosity, angle of entry to and exit, and a bifurcation and distance from the collateral exit to the distal cap. Preferred order of selecting a retrograde collateral channel. Preferred is bypass, but the ideal what we get usually is septal collateral and epicardial collateral. Preferred collateral in SVG collateral, I told you, septal. Septal collateral, shorter route to the recipient vessel. It is less tortuous, less chance of tamponade, and can be dilated with a smaller balloon if the microcatheter did not cross. Hemografts when no other option exists. Challenges in the epicardial collateral, unpredictability of success and occurrence of complications. What are the technical difficulties in epicardial collateral? A longer collateral, more tortuous, higher procedural ischemia, and high risk of tamponade and even complication and death. Septal perforation can have a septal hematoma and dry tamponade. Rarely, but epicardial collateral perforation have more tamponade and more complication and even death. How to cross the collateral channel with a wire? You can have a contrast-guided approach, especially for the septal epicardial end bypass. Surfing is actually for the septal channel. Avoid aggressive wire manipulation, and it can may lead to perforation. What are the tips of crossing the epicardial collateral? You can use the wires, basically 4 wires. The epicardial collateral Zion and SUHO3. In the septal collateral, cyan black, SUHO3, and filter X3R. You should actually, in epicardial collateral, the wire should be ahead of the microcatheter all the time. You should have a cautious injection of the contrast through its tip, ensuring a back bleeding is possible prior to the injection of the contrast. You should withdraw the epicardial collateral wire after ascertaining no perforation at the end of the procedure. And you should avoid surfing, and dilatation of epicardial collateral is always discouraged. What are the independent predictors of the failure to cross the collaterals? One is tortuosity, side branch of the collateral tortuosity, inadequate collateral size, and inadequate collateral exit location. How to predict a successful collateral crossing? Actually, there is a Nagamatsu is sitting here, actually J-channel scar, the Japanese CTO PCI expert registry shows these are the, and is already shown. You should understand the reverse bend, continuous bend, corkscrew are definitely minus for any crossing. What are the guide wires for the collateral crossing? You can have X3R, Zion black, and SUHO3. Crossing the collateral channel with a microcatheter, pushing or by rotation. Septal collaterals can be dilated with low pressure using a smaller balloon. Epicardial collateral should never be dilated. In the microcatheter cannot cross, what are the choices? Try another channel. You can actually deliver the microcatheter by rotation, increase the support, different microcatheter. You can use a short microcatheter and a new microcatheter and dilate the collateral. Other options, retrograde true lumen crossing, just marker for the antegrade crossing. Actually, you can actually retrograde crossing, and you can have it using as a marker wiring technique and use another collateral. How to cross the CTO? You can have a retrograde wire escalation, a retrograde dissection or re-entry, wire reverse cut or confluent balloon. You can use it as a marker for antegrade wiring. Ideally, you should have an intraplaque crossing, short occlusions, and when distal cap is pervert. Successful crossing strategy only in 5 to 10% of the CTO PCI. You may require a reverse cut. Reverse cut is actually balloon inflated over the antegrade wire. The cut is actually balloon inflated over the retrograde wire. This is actually a revert cut example. When you have a balloon inflated, we have the retrograde wire is coming back, and actually I'm taking the balloon up. Then we dilate the balloon. Once the balloon is deflated, you can see the second frame, when the balloon is deflated, the wire is going up. And again, when your balloon is again taken up, and the wire is going up, easily going up. This is actually the reverse cut principle goes. Once it is there, the wire crosses easily up. Now the wire is going up. One actually inflated, created a space, and that will be a subintimal space, or it can be sometimes an intimal space, and this wire going. This is actually just an X3R wire, just crossing up. What are the 4 possible mechanical anatomical situation? You can have both antegrade and retrograde wire in the intima, both in the subintima, antegrade wire in the intima and retrograde in the subintima, and antegrade wire in the subintima, retrograde in the intima. This is a situation where a different space, antegrade in subintima, retrograde in the intima. You can have an LED CTO where we crossed the wire, when actually difficult, the wire entered, antegrade wire was in the subintimal space. So the retrograde wire was crossed with the help of a guide liner. We have taken a guide liner in the antegrade technique and taken the wire inside and crossed CTO. How to externalize? Retrograde wire, guide wire and microcatheter advance to the antegrade guide catheter. Externalization can be used with RG3 wire or R350 wire. And if the retrograde microcatheter cannot reach the antegrade wire, you have tip-in wire or Rendezvous technique can be used. How do you cross retrograde wire into the distal cap? Take the microcatheter up, then wire crosses, take the microcatheter up now, and then balloon trap it, then take the microcatheter up and take retrograde wire is removed. You take an RG3 wire and finish the case. That is what externalization does. Then remove the externalized wire. Stenting of the CT is performed through the externalized wire. Externalized guide wire is withdrawn inside the microcatheter, and both the antegrade and retrograde guides are disengaged. Microcatheter is then withdrawn, leaving the guide wire in place. Angiography is performed to exclude any complication. In the absence of complication, the guide wire is removed over the microcatheter after advancing it again to protect the collateral channel. So sometimes the retrograde wire is coming back. It may not be able to cross. We use the guide liner in the antegrade catheter, then we crossed it. IVUS can be used in antegrade wiring and retrograde wiring. Retrograde wiring, the wire crossing at the ostial in bifurcation and identify the wire position in reverse cut. Always common complication to be noted into: perforation, procedural MI, donor vessel complication, vascular vessel complication. The final pictures is important. You have to remove the microcatheter, assess the potential collateral damage, assess the donor artery patency, and final assessment from the antegrade injections. Thank you very much.
Excellent talk, Dr. Pratap. I know I do ipsilateral collaterals also. Very few people do. The thing is, honestly, IJCTO score is more. I think we go for the retrograde procedures.
Correct.
Even Japan registries also showed that. But we thought in the beginning that the robust antegrade techniques, actually retrograde 2012, 2013, we started doing many retrograde. But the advent of Gaia wires, now the Gaia next, the number has come down. But a good operator, a complete CTO operator means you should be able to do antegrade, ADR plus retrograde. That's very important. Some of the cases we have to do retrograde in JCTO score is very high.
That is why we should not stick on the single technique. We should have multiple techniques to be done.
The only issue is the complication of
How
perforation.
often you keep a protection wire in the antegrade guide to prevent the sucking of the guiding catheter causing the donor vessel damage? And second, how often you do retrograde knuckling?
No, I don't do retrograde knuckling. Actually, the antegrade knuckling and retrograde knuckling, I don't do. That is why actually we follow Okamura and Nagamatsu. We actually prefer not to do knuckling. Knuckling is the last choice to do. Sometimes wherever I tried knuckle, I all failed. So once you fail, actually, Arun was telling, you try to fail and then only you can be successful. Like, let me try and fail. But the first question, you have to keep the catheter just a little backward in both the situation. I think it will not. And you should be careful, or minimum your assistant should be careful that it should not be sucked in. And you should always tell your assistant to help you in that.
Is it a crime to keep the wire in the aorta?
Which one?
Is it a crime to keep a protection wire in the aorta?
All protection wire in aorta will not help you. Actually, that is not the ideal choice. The wire may suck in, and usually we don't. Initially, we were not looking at these things. It would have. Now, I don't think Surya. We don't get any chance to suck in. We know that when we take the wire, we just withdraw this automatic comes that.
Pratap, how many percentage of patient of your CTO use retrograde? Second question is, how many patients you straight away go for retrograde without attempting antegrade?
So actually, some of the cases, an excellent interventional collateral prompt aorta ostial occlusion, you will be tempted to do retrograde. My rate is nearly 15 to 20%.
Dr. Okamura, because you are doing the tip detection
3D
method
wiring.
now.
Yes.
So after you started doing this is your retrograde process have come down?
Yeah, so maybe it's a 5%, maybe the tip detection I was is a 30%. Yeah, so a percentage, retrograde 5%. Only
5%.
Just 1%, 2%, 3% around. Yeah, I usually do the antegrade guide wire manipulation, but the outside Japan, I will do the retrograde approach. And I have one question. So I usually do the retrograde approach using 7 French guide cassette outside Japan, but usually with side pole. But outside Japan, there is no side pole. So sometimes the doctor made the side pole, but it doesn't usually work. So is there any comments? Or it's okay?
I don't usually use side hole catheter, but we use 7 French in both the sides and rarely use 8 French. But whenever a Japanese colleague come to the hospital, they try to use an 8 French. I think 8 French will give you more support to the recipient vessel. I think that is the only choice. You use 7 French or 8 French?
7.
We also use 7 French.
7. It's
7.
okay.
7.
Okay.
Thank you.
Yeah, the next speaker is Carabao, talking about the art of the crossing collateral and the wedge collateral. So please make a presentation.
Thank you, Sensei. Thank you very much to the IJCTO organizers for the gracious invitation to be here this morning. It was a pleasure to be here. It was a tremendous live case that we got to do with my friend Sridhar Kasturi, who was a great operator. Pratap did most of my talk, so I'll just go and sit down. Right? But maybe for the next couple of minutes, I'll tell you a little bit about collateral crossing using a slightly different approach. These are my disclosures. So here are our learning objectives. If we think about what we need to know to cross a collateral, we've got to answer 4 simple questions. 1, what type of collateral are you dealing with? 2, where are you most likely to find it? You know, we have angiograms that we take and we try to follow these collaterals. The problem is that overlap of vessels and, worst of all, panning make it very difficult. So if you understand where fundamental collateral locations are, you know where to look and you know which views to take. And as CTO operators, we recognize that the same 6 standard views are not really what we need. What we need is to be able to move the heart in our minds so that we can see what we're there to see. How do we functionally risk assess a collateral? So not just is it easy to cross or is it easy to enter, but what is the likelihood of us successfully crossing the collateral, and what are the risks associated with that crossing? You may have a choice of collaterals. How do you pick the one that you really want to pick? What's the equipment necessary? We heard a lot about that a few moments ago, to wire collateral channels safely and effectively. And then, of course, what are the technical approaches? So let's talk about collateral orientation. You heard about what types of collaterals we have. There are septals, epicardials, saphenous vein graft collaterals, or limas, or rimas sometimes, okay? So when we think about assessing the collateral by its fundamental characteristics, we consider where are we likely to find them? So for an RCA CTO, where are you most likely to find the collaterals that you're looking for? The most common collaterals for the RCA are from the LAD, typically the LAD septals. Next most common is an AV groove circumflex collateral to the PLV. And then rarely you start to get left-to-left system collaterals that you can see bridging from the apical LAD to the RPDA. And then eventually you start getting homo collaterals where you get septal to septal loops. What about with the LAD? Well, LADs, the most common collateralization pattern that you're typically going to see is going to be your PDA septals to your LAD. Now, just because a septal exists, it doesn't make it easy to wire, because there's a lot of characteristics that go into septals. And that includes the direction that your flow is going, because it is difficult to go from the right to the left, more so than it is to go from the left to the right. We consider that RV branch to LAD and RA branch to LAD collaterals those epicardial collaterals are often present. Those are seductive, but often quite challenging because they will enter in the middle of the CTO segment or very close to the distal cap. And that doesn't give you a whole lot of push, particularly when you're in a fragile epicardial collateral. And then third, where do you look for a collateral to the circ? Well, we think about diagonal to OM, which is your most common circumflex collateral, 30% in right dominant, about the same in left dominant. Then there's PLV to AV groove circumflex, and then rarely you can get LAD septals to the left PDA or LAD septals to an OM. And then once in a while you'll get S1 connections to an RPLV as well. And those are interesting because they often get invisible as the heart torts. So how do we functionally risk assess these? Well, first thing we've got to understand is, what does our experience tell us? What is it that we actually use? This is from the Progress CTO, and for those of you who are keen on Twitter, or X as it's called now, you'll see that Lorenzo Azzolini published a paper pretty recently that described the differences between CTOs in Europe and Asia and those found in North America, where Progress CTO is a North American registry. These are typically older patients, more diabetics, longer lesions, and at least 50% are post-bypass. So they're all atypical collateral locations, and there's a bunch of them that are heavily calcified. Still, septals seem to be our most common collaterals. But then that's followed by vein grafts, because we've got a lot of them. And I swear God made saphenous vein grafts to be retrograde collaterals for CTO PCI, because at 10 years, they're not worth a whole lot more than that. And even the surgeons know that with total arterial revascularization. And then things like epicardials that are ipsilateral or contralateral are increasingly less common. And then, of course, as you heard, the lima is typically the last resort. So if we want to actually functionally assess, what do we look for? Looking at a septal, the first thing you look for is the connection size. Is it big? Does it look like a side branch? Is it thread-like, but you can actually see it? Or is it one of these invisible or intramyocardial collaterals that are getting squeezed every time the heart beats? This is going to affect not only your ability to wire, but the likelihood that you're going to be able to transit your microcatheter, because one of the most challenging things to deal with is the heart beating around your microcatheter, capturing your microcatheter on your wire every time you're through the collateral. What's the exit from the donor vessel like? So the ideal is an obtuse angle, so greater than 90 degrees as you enter, because that's the way the wire typically wants to go. It gets a little bit more challenging when the collateral comes straight down into your donor vessel, because then your wire has the propensity to go in either direction, and where the heart is moving, sometimes it can be challenging to redirect it truly retrogradely. And then the most challenging is when you have an acute angle, because then the wire wants to typically go down the vessel or prolapse as you try to turn. And it becomes a challenge both with wiring and microcatheter transit. How about collateral tortuosity? Same thing, no bends, no problem. One bend increases the difficulty, and then multiple high-frequency bends, more typical at the distal ends of the LAD when you're using septals going down to the RCA, the more likely you are to have more challenges. And the more distal you go down the LAD, the more likely that your septal collateral becomes epicardial for a short course. And so it's worthwhile recognizing that when you do your risk assessment. The entry into the recipient vessel, similarly, we look at the same things that we look at when we try to enter the collateral from the donor vessel. Is it easy, and is the wire likely to go retrograde, or is the wire going to prolapse antegrade down the PDA? And then, of course, direction. And as I mentioned, left to right is typically easier than right to left. And that's because the septal entry into the PDA is actually a corkscrew, but we don't appreciate it in standard views. So you actually need a very steep cranial view to be able to understand where that septal corkscrew is actually entering the PDA. Let's move on to epicardials. This is a busy slide, but it should not frighten you, because all it does is talk about exactly the same thing I just did. You look at the size, big is easier than small. You look at the exit, big angle, so large obtuse angle is easier than 90 degrees, is easier than acute angle. Bifurcations in epicardials make things harder. And tortuosity is your enemy, because not only do you get pseudo-lesions and patients get ischemic, but as you cross your microcatheter, it limits the number of choices you have for microcatheter crossing, and it limits the amount of time you have to work, because if you push too hard, you may injure that collateral. Moving forward to SVGs, this is similar. Your graft patency affects your ability to use it. So sometimes we'll use patent saphenous vein grafts, but they have severe disease in them. So ballooning these as you go down with perhaps a guide extension catheter carries some risk associated with it. That's different than the recently occluded vein graft, which typically allows you to get in with a polymer jacketed medium tip strength wire like a Raider or a Pilot 200, versus the blunt saphenous vein graft, which behaves very differently. These are recanalizable. These are still great vein grafts, but you do have to be careful because these occlusions typically are long once it starts getting blunt near the proximal cap. And you don't know what the distal looks like. Here, CTs can be very helpful. And because the occlusions are so caked in, you really have to push quite hard to get all the way down, and you can evulse an old vein graft. The anastomosis angle, we've talked about. It's the same thing as for the collaterals, as is the anastomosis location. The location to the PDA is typically the easiest, but the most important bit is the anastomosis right next to your distal cap of your occlusion, or do you have some running room? Because ultimately that's what determines how much support your microcatheter can give you when you wire the collateral to be able to actually enter the CTO segment. And in post-bypass CTOs, those distal caps are calcified. And so you really do need to push quite hard with a fairly aggressive penetrating wire. And if you have no angle and no straight room to do that, it becomes quite difficult. And then the Lima. Similarly, we have the Lima sort of jeopardy score, where we look at the angles of entry of the Lima onto the LAD, where here, less than 45 degrees is less than successful. Your microcatheter typically prolapses down the LAD. You've got the tortuosity within the Lima, because the longer down you are, the more pseudostenoses you get, and the more likely you are to get ischemic. And then your anastomosis location. Okay? And you see scores built on this. This is from Margaret McEntegert and group, but there's a more modern way of approaching this. We heard Professor Nagamatsu's score. This is a modern score that was published just this year, where it makes it quite simple. Is it big? If so, good. If not, you don't get a point. Is it tortuous? If so, bad. If not, good. You get a point. And greater than 2 points means you're likely to be able to wire this. The AUCs were quite good. Less than 2 points means it's going to be a tough one. And so don't take that on day one. And when you look at whether or not you have safety, well, this is stuff that we all know, right? Any of these collaterals can result in perforation. The question is, which of the perforations do you actually have to do something about? And these are the ones, this is why the epicardials are thought of as higher risk. But I think back to something that Gerald told me, or Gerald I heard say at a meeting some years ago, and that is, don't demonize the epicardial, even though it's a higher risk collateral. Just recognize that it requires a reasonable informed consent discussion. Make sure you've done 100 septals before you take it on, and be careful. Start with a simple one. Don't start with some horrible telephone epicardial going from the AV groove to the RPLV that nobody would want to wire in their right mind, but it happens to be the only collateral, so you don't want to refer the patient, so you try it and you perf, right? It's just an understanding of what's most likely successful in your hands and what's most likely to work. So the required equipment is straightforward. You need a wire, and you need a 150 centimeter microcatheter. And that, most of the time, is all you need. But when you're having trouble crossing, low-profile coronary balloons can help, and you can pass a low-profile balloon right through an entire septal collateral. You do not ever balloon epicardials. You can use guide extension catheters that can improve your safety and support. You can use angled microcatheters, which can help you with that angulated entry. These are very useful tools. And then you can use dual lumen catheters for technical wiring, for reverse wiring. And finally, the technical approaches. Use a workhorse wire and a 150 centimeter microcatheter to get into your collateral of choice. There are a variety of bends that you can use, but as I said, if you can't, use your angled microcatheter. And beware of septals that are covered with stents. Those ones typically need to be dilated because your microcatheter will grate along the inside of the stent if you're not careful. And what you end up doing is getting stuck. And if you're stuck through and you can't pull and you can't push, it's very, very bad. Once you've got a dedicated retrograde microcatheter in your collateral, whether it's a septal or an epicardial, it comes down to which microcatheter comes down to what type of collateral you have. Typically, I use caravels and epicardials or turnpike LPs, typically through the septum. Turnpike LP is my go-to. And then you have the same 4 crossing wires that Pratap spoke to you about a few moments ago. A Xion SHU-03, which is typically my epicardial wire. My Xion Black is usually my septal wire because I'm a surf guy as opposed to a a strictly wire guy. But what you can see is that even in the hands of expert operators, there's a variety of wires that are used. And the SHU-03s and the Xi'an family are typically the majority of those wires. Surfing involves gently probing the septal with a polymer jacketed wire. The perf rate's about 25%. The good thing is there's usually very low consequence. Versus the contrast guided or injection-based approach, where you use a very careful approach where you sort of give the wire permission to pass through the collateral during diastole. You don't really push. And that's why the SHU-03 is so important. It's got a 0.3 gram tip with a thread-like tip and an Act 1 core that gives you some torqueability. So this is what surfing looks like. This was a live case I did a little while ago. And as you can see, there's a clock on the bottom, right? This is not a particularly long process. I started it at 38 seconds. And surfing very gently, by 48 seconds, I'm across. It's a 10-second procedure. So when it goes, it goes. That's different than epicardials. This is an epicardial that I did into a very large OM. And now if you look at this Xi'an wire, this is a much more deliberate, much more careful, much more guided approach. Okay? And this then gets you up very carefully with in this case was a Caravel microcatheter to back it. And that's why when you're moving an epicardial, this is what your hands look like. It's very, very gentle. And then finally, once you're across, your microcatheter transit is a function of one operator, where you spin quickly, but you have to have momentum at your tip before you start to advance. If you advance as soon as you start spinning, you've defeated the purpose of a microcatheter. Okay? And if it's an epicardial, be careful spinning, because especially if they're intramyocardial epicardials, you can shear them. And so try pushing and don't spin until you have to, because you'll use up the ability of the microcatheter to spin. The braids and the coils will kink. If you fail to cross, you use a wire, you change your bend, or you use a different collateral. And these are various options when you can fail to cross, recognizing that some of them are not for epicardials. And so with that, I'll stop there. I'll apologize for going 2 minutes over and be happy to take questions.
So Joe, do you think the quantity and quality of collaterals predicts the quantity and quality, size, number, distribution, predicts the health of the culprit vessel and the area of myocardium it supplies, and it's got nothing to do with the culprit vessel, number one. Those who have rich collaterals, do you think the mark you have produced in the CTO segment by ROTA or laser or other things, they go into the donor vessel if you have rich collaterals? That is kind of blessings, or is a kind of...
Yeah, interesting, right? It makes it, rich collateral networks make it harder to see sometimes, because you have dominant epicardial collaterals that will overshadow lower risk collaterals like septals. But ultimately, when you get down to why neovascular revascularization occurs, it's either recruitable, right? So it's a pressure head phenomenon, typically your septals, or it's ischemia driven. That's VEGF. That happens when you walk through pain. Walk through pain collaterals are typically epicardial collaterals. And so I think and I don't have the data to back this up, I think actually the richer the collateral network and the more VEGF-derived collaterals, the more that patient actually was symptomatic. But the more of those collaterals, the less they remain symptomatic. And so if they, much like in the legs, right, if you do peripheral interventions, if you walk through, you create collaterals and you create lots of them. And so if you're no longer ischemic and you have large collateral networks, you can make the argument to leave the vessel alone. That's my opinion, right?
Thank you, Dr. Sanjay. Excellent talk. Yes, time is running short. We go for the next lecture. The reverse card tips and tricks by Dr. Dash.
Thank you for the kind invitation. So my talk is going to be on reverse cart, and it's complex. Many solutions came, but still it is evolving.
Okay, CTO remains one of the most challenging subsets of PCI. The success rate with the integrated approach is around 65 to 70%. The retrograde approach improves the success rate up to 95%. The era of retrograde CTO PCI began with direct two-element puncture, kissing wire cart, and reverse cart. Reverse cart is the most dominant retrograde strategy, and it has been iterated into several subtypes to improve procedure success and efficiency. This is the evolution of CTO PCI. It starts with basic antigrade wiring, follows by advanced antigrade IVAS guided wiring, wire-based ADR, rudimentary ADR, advanced retrograde with cart, IVAS guided cart and iteration, advanced ADR, and putting it all together. So this is 19 years ago in Toyohashi Art Center with Dr. Suzuki before starting up IJCTO. So we realized at least 30% would require retrograde. So the first procedure done was cart in Toyohashi. It is antigrade navigation of guide wire after retrograde balloon. So you can see this is proximal RCA CTO with ambiguous cap, and epicardial collateral was used, and the microcatheter was transit, and the wire was choice PT. This was the first cart and first dissection re-entry in the world. So this is retrograde bellowing and followed by antigrade wiring and stenting. So then some of the pitfalls of cart were realized. There was a difficulty in negotiating a retrograde balloon, and sometimes the subintimal space would extend to the proximal true lumen of the CTO. That may cause a fatal event. And estimation of retrograde balloon size is empirical. And procedure time was also unpredictable. So Kato thought of reversing this technique, and instead of retrograde ballooning, antigrade ballooning was used for retrograde navigation of the wire. Reverse cart as compared to cart is reproducible, safer, quicker, more effective, and gear handling is easier. So this is the schematic illustration. See, both antigrade and retrograde wire come and antigrade wire that is antigrade base separation, and retrograde wire with the support of microcatheter as retrograde base separation. And these, after the overlap, antigrade balloon is inflated to create the common subintimal space. And then through common subintimal space, retrograde wire penetrates into proximal true lumen. So in IVAS, there are four situations of the antigrade and retrograde wire, where antigrade and retrograde wire both are subintimal. Reverse cart is most suitable when both the wires are subintimal or extra plaque. However, there are still small number of cases where reverse cart fails or takes a long time. Failed reverse cart account for 30% failure in the retrograde approach according to APCTO Club. So there is a need to make the reverse cart quicker, more reliable, and more efficient. So this is the publication we made, and currently reverse cart is of various types. Conventional, that is a classical one, and assisted, that is by IVAS, stent facilitated, mother-child, and contemporary reverse cart, and extended or shifted reverse cart. So this is the conventional reverse cart. You can see there is a longitudinal overlap of antigrade and retrograde wire. Antigrade balloon is moved to the point of overlap, then antigrade balloon is inflated, and retrograde wire is navigated through common subintimal space into proximal true lumen. So this is the case, LED ostial CTO with a good collateral from RCA. Retrograde wire moves in with the help of microcatheter. Then antigrade and retrograde wire overlap. Ballooning and reverse cart was done. Then you can see the result. But, what are the highlights of this conventional? This is the commonest reverse cart used these days. It suits essentially any CTO except those without retrograde option. It may be for primary retrograde or bailout retrograde. Retro wire usually starts with intermediate load or knuckling compatible. There should be adequate wire overlapping and balloon size needed for passive wire migration and connection. It can accommodate techniques such as knuckling, IOS guidance for troubleshooting when failed to create common subintimal space. However, there are certain pitfalls. The larger balloon used in intimal or subintimal dilatation carries the risk of distal extension of the subintimal hematoma and vessel perforation. There is increased risk of coronary aneurysm and TVR because of longer length of the stent. If you manipulate the retrograde wire excessively or use knuckle wire, it may create a large space around the retrograde wire, hindering its directional control. Often it is time consuming. Then comes to avoid these limitations, contemporary reverse cart was done, and I did it in 2015. See, this is the end. It starts with the antegrade preparation. Small balloon was taken to the tip of the antegrade wire, then retrograde wire was moved towards the antegrade balloon, and then antegrade balloon was inflated, and then retrograde wire moves into the space, into the true lumen. So this is what we published in 2015. Now the question is, why antegrade preparation? Because wire control is easier and safer in antegrade compared to the retrograde. And you can find the suitable point for penetration of the retrograde wire, the point without dense fibrous tissue and calcification, that is virgin territory. It decides the antegrade balloon size for reverse cart. So this is a proximal RCA-CTO. You can see it starts with antegrade preparation, antegrade ballooning with 2 millimeter balloon, and the final result. However, contemporary reverse cart is not successful in some situations, like ambiguous course of CTO, tortuous CTO, and heavy calcification. Whenever you find CTO length less than 20 millimeter, you can consider direct wire crossing, and then if it fails, you can take the help of IBUS. Otherwise, we can look for contemporary reverse cart. When you think it cannot be done, then probably classical reverse cart has to be done. So this is the difference between conventional and contemporary. See, basic CTO wiring is antegrade or retrograde in conventional, antegrade in contemporary. Knuckling is suitable in conventional, but unsuitable in contemporary. Antegrade balloon size is large. Sometimes you may have to use IVUS to find out the size. But in contemporary, the balloon is small, and that creates limited injury. Retrograde guide wire is low to intermediate penetration wire in conventional, but Gaia types of wires are used in contemporary. So the indication of conventional reverse cart or CTO requiring bilateral wiring, calcific and tortuous anatomy. But when there is clear proximal cap, occlusion without heavy calcification or tortuosity, you prefer contemporary. So conventional, as I mentioned, there is no unsuitability. In most of the cases, it can be done. So how about shifting or extended reverse cart? When there is extension of the intimal or subintimal dissection beyond the CTO segment, it is useful in cases where antegrade preparation or retrograde cap penetration is not possible. So this is proximal RCA-CTO. As you can see, initially we tried to find out the connection. It did not happen. Then the area of common subintimal space was shifted, and final result. How about mother and child? It is involvement of the guide catheter extension into antegradely created subintimal space for retrograde navigation of the guide wire. So the importance, it may be preferred over the stent because it may be removed or repositioned if there is no connection. So this is again RCA-CTO. As we can see, antegrade preparation and retrograde wiring. However, we cannot make the connection. Then guideline comes in, and it works as a target for retrograde wiring. So this is the final result. So role of IVUS, Okamura already mentioned, IVUS can tell us about the antegrade and retrograde wire position. It can tell us about the size of the vessel and size of the balloon and further management. What are the difficulties in reverse cut? Sometimes there may be difficulty in connecting the spaces when the wires are too far apart and wires not in the same space and navigating the proximal CTO vessels. When wires are too far apart, you can think of contemporary reverse cut. That is, as I mentioned earlier, anti-gate preparation with maximized wire control by Gaia and wire towards the end of the balloon rather than side. And sometimes contemporary reverse cut is not possible. Then you can think of knuckle, that is long CTO, calcified CTO. Sometimes CTO may be very short. And in that case, there is no space to work in the occlusion. So IBUS may be used or ADR can be thought of. Wires they are not in the same space, then get both the wires in subintimal or extra plaque. Still you cannot connect IBUS bigger balloon or move somewhere else in the vessel, that is move the cap. So this is the latest publication. And with this, my conclusion is CTO PCI has been revolutionized with development of retrograde technique. Reverse cut, the dominant retrograde strategy employed currently as it is easier, predictable, quicker, and safer. The current iteration of the reverse cut, such as conventional, contemporary, extended, would further facilitate its adoption with more efficacy and safety. Guide extension and IVAS may assist the technique further. Thank you for your kind attention.
Thank you, Dr. Des. Very elaborative talk, very educative for the fellows, step by step.
Yeah,
so,
Prakash,
of time.
Just a short comment, Prakash.
Short comment.
Yeah. So, how many times you inflate a balloon? Is it a single inflation, multiple inflations for the multiple fenestration in reverse cut? And how often you use subintimal laser, subintimal IVL, and subintimal electrocautery if your balloon fails?
You are right, that electrocautery has been used in some cases. But if you don't get the result with first inflation, you can go for second, third. There is no limit like that. Our idea is to create the space with medial disruption.
The limitation is the size of the balloon, not the number of times. So we'll go for the interesting talk by Dr. Nagamatsu regarding the IVAS role in the reverse cut.
Okay, first of all, I would like to say that thank you very much for the invitation, and I appreciate. So my topic is IVAS role in the reverse cut. And maybe you know that after quarter channel guide wire crossing success, the technical success rate is very high, but still under 100%. So, but we have the data from Japan Institute Expert Registry. Once guide wire crossing via the quarter channel, we have the success ratio rate quite high, exceeds 90%. But still, we have some failure factors. And for example, the reverse coil failed, and the device uncrossing, and the complications. So in this time, I would like to focus on the reverse cut. And the reverse cut looks like a very easy way to make a connection, but occasionally it is very difficult to make the antegrade and the retrograde connection. So sometimes we need some of the balloon inflation, so many times, and we have to change the position so many times. But the IVAS, so nowadays we can use IVAS. So I would like to strongly recommend performing the IVAS guidance, the reverse cut. So what is the benefits? One is to recognize the wire positions of the retrograde and the antegrade. Number two is estimating the vessel size for optimal balloon size. And I would like to show and explain more detail using the actual cases. So this case is RCCTO. So actually, as you can see, this RCCTO performed by the retrograde pitch manner. And then actually in this case, a very easy way to make a connection. So, and I would like to confirm that why so very easy to make a connection by the reverse cut technique. So, and those like a region, so I try to insertion the IVAS. Okay, and this one is here, volcano, the flips IVAS. So that means that the center over there, IVAS, is the antegrade guide wire position. And as you can see, from the 3 to the 6 o'clock, we can see the plug matter. So here is the interplug. And we can see the other space is here extra plug, already vacant by the balloon inflation. Okay, and the antiquated guide wire be in the interplug, in the subintimate space. And as you can see, we can see the guide wire, retrograde guide wire from the 1 to 2 o'clock. So this one be in the subintimate space. So, and due to the confirming iris, we can confirm the guide wire positions. So in this time, the antiquated guide wire and the retrograde guide wire will be in the same space in subintimate space. And this is a summary for this case. So this case is easy to make a connection that due to same position. And please look at this one. And so upward, we can see the antiquated guide wire position. The left side is the retrograde guide wire position. So this case, the antiquated guide wire be in the subintimate space, and the retrograde guide wire be in the subintimate space. We can confirm by using the iris. In this time, so very easy way to make a connection. And for example, and for the be in the antiquated guide wire be in the interplug, and the retrograde guide wire be into an interplug. So both guide wire be in the same space. This like situation, maybe we can do the reverse cut, and then making it very easy, making the connection with ease. So easy to make a connection because both guide wire be in the same space. And I showed another case. So this case is a LED CTO. So this one is a try to the integrate, but failed. And I tried to the little piece of procedure and using a septal channel. And so actually, in this time, very difficult to make a connection. Why? So, and I would like to check the guide wire positions. The guide wire positions mean the antegrade guide wire and the retrograde guide wire. So as you can see, in this time that I use a Boston iris, so the we can see the antegrade position is here be in at intima like that. But unfortunately, retrograde guide wire be in the subintimate space, and both guide wire be in the different spaces. And additionally, we can see the very big plug matter there. So that's why it's very difficult to make a connection. But even if this like guide wire antegrade and the retrograde guide wire be in the different spaces, but we have the option. And for example, the optimal size of balloon. So, and if we can see that this basic diameter 3.5, okay, we can give the 3.5 the balloon for the reverse cut. And another the option is a changing cut position. So this part, this segment is different, but the more distal part or projection part, and sometimes going to the same spaces. So due to the recognizing the guide wire positions using the iris, make it we can do the optimal part. And we can give the another option is move the cap, the base, and original reverse cut. And for this case, so actually I performed the base technique. That's why. So retrograde guide wire, I'm going to the subintimate space. And then so this subintimate space already the bigger, very quite huge space is already created, maybe due to the anacro part. And and in this time we have to go into the antegrade guide wire, going to the subintimate space. So that's why I did in this time the base technique. So and I give the 3.0 millimeter balloon inflation, and intentionally I created the extra plug space, and then I try to get advanced guide wire from the antegrade to the CTO extra plug subintimate space. And so this one is the actual picture. And so as you can see, this UV3 guide wire going to the subintimate space with the necklace shape. And maybe both guide wire be in the same spaces, and the antegrade guide wire be in the extra plug subintimate space, and the little guide wire already and going to the subintimate space. So in this time, both guide wire be in the same space. Okay, and after that, very easy way to make a connection. So we give the additional reverse cut technique, and after that, and I success this case like that. And I showed another case. This one is a very impressive case for me, about 8 years ago case, very old case. So this one is the RCCTO. And as you can see, we can see very quite long the CTO. And the CTO exit part included a very important bifurcation like this. And unfortunately, we can see a little bit the calcified part like this. So, and this like, okay, and this one is here summary of this RCCTO. And the long RCCTO, and we can see the tapered entry, and then here is band and the calcification at the CT exit here, and the exit have the major bifurcation. Okay, in this time, I try to the primary lateral grade PCI procedure, and using the septal. And I give it the Corsair Pro and XS 150, and I use the septal channel. So this channel that scored the two easier guide wire crossing success, XS 50% from the Japanese IJCTO Express registry, and I use a Sion guide wire. And as you can see, this Sion guide wire going to the distal true lumen part. And additionally, I get advanced Corsair Pro, and then I check the tip injection like this. So very unfortunately, there is no microchannel from the lateral grade side. And so I set up the integrator, integrated system for the reverse cut technique. And the Miracle Neo 3, I get advanced, and I give it the semi-conveyor balloon 2.25 15. And I try to additionally give the guide extension. Okay, though this system already we created, so maybe and a very easy way to make a connection by the reverse cut. In this time, I believe. And anyway, so please remember this distal part included very severe hard calcified lesion. So and I need dual lumen microcity using a Sasuke. And finally, this guy next to guide wire going to the CTO lesion. Okay, very easy way to make a connection, but actually very difficult. So I try to change the reverse cut position and the wire escalation and the de-escalation. They're going to up the guy next to, and the de-escalation up to the Sion black, but failed. What is the next option? Yes, definitely giving the IVAS. IVAS guided reverse cut. So, and as you can see, this one is actually the IVAS study, and we can see the both guide wires. Here is the integrated guide wire from 2 to 3 o'clock. And we can see the white matter is a lateral grade guide wire. So we can see, so here, and be in the interplug, and the both guide wire be in the same space. Please remember this issue. So integrated guide wire be in the intimate space, and the lateral grade guide wire be in intimate space. So this time the both guide wire be in the same space. Maybe made easy way to make a connection. Okay, and I checked almost whole CTO route and by the IVAS. Here is different, and here is different. Why? Very difficult to make a connection. So only chance to make a connection here. So that's why, and I inflate the balloon here, and I change the guide wire Sion black, and finally success like this. So, and very important issue for the creating the strategy and technique, the review is a very important issue. So I will show the time allocation for this case. So total the procedure time is 208 minutes, and please look at this yellow matter, the reverse cut. So amazingly, I waste time for the reverse cut almost 1 hour. So early IVAS use would have shortened the procedure time. This is in the take-home message, and IVAS role in reverse cut. The recognizing of antegrade and retrograde wire positions is a key of successful reverse cut. And IVAS is useful for the confirming guide wire position, and this information will give technical options. Due to performing the IVAS guided reverse cut, there is a possibility to shorten the procedure time, like our last case. Thank you for attention.
Thank you, Nagamasan. Any queries, any questions?
Yeah, recently I like to do the tip direction area, so that's why the antegrade guide wire is subintimal and the lateral guide wire is a true lumen, and it is difficult to the reverse cut. I do the tip detection ADR, navigate the antegrade subintimal guide wire to the tool lumen. Just do that tip detection ADR assisted reverse cut, and also your case, antegrade guide wire is a tool lumen, and retrograde guide wire is a subintimal space. Do the tip detection method, navigate the guide wire tool lumen to the subintimal space, do the balloon dilatation. You can navigate the retrograde wire into tool lumen. So I like to do a base technique using the tip detection method, because tool lumen, then do the tip detection method and navigate the guide wire to the subintimal space, do the balloon opening or something. So yeah, any comments?
Okay, and thank you very much. Quite nice tips, Dr. Okamura Sensei. And maybe, so in this time, which guide wire you usually use, the Conquest 12?
Conquest 820 or SD, because the barrier is needed. Barrier penetration is needed.
Mm-hmm. Okay, so I think I wonder, because of the using IRAS, and we can use the very hard guide wire even if the retrograde. This is a very important issue for the safe. Safe is very important. The priority of the CTO-PCI. Thank you.
How often you have, do you have intraoperative CT scan in your country? CT scan in the integrated...
CT scan?
Yeah, in the integrated cath lab system, like Philips, you have now CT scan integrated in the system.
Okay.
Do you have?
Okay, unfortunately, I don't have, but checking the CT angiogram before starting a CTO-PCI in Japan, or maybe each case is.
Okay, so how often you use your IVUS like Eagle's Eye as a support catheter?
Okay, and how often? Okay, good question. But I tried to do one-time inflation with IVUS, but once failed, I tried to insertion the IVUS for the saving the shortened time.
Okay, thank you, Dr.
Thank you very much.
Thank you.
Thank you very much. We have come to the ending of the session 4. Thank you, Dr. V. Surprakash Rao, Dr. Okumura, Dr. Rath, and Dr. Ajay Swami, sir. We move forward. We have understood something about the retrograde. However, the externalization, the new technologies in between antegrade and retrograde in the body, and something crossable but crossed, not dilatable. We'll have the session 5. May I invite the chairpersons, Dr. N. Pratap Kumar, Dr. Nakamura sir, Sanjog Kalra sir, Dr. Sridhar Kasturi, and Dr. V.S. Ramchandra. The speakers will be Dr. Hayashi sir, Dr. Masahisa Yamane, Dr. V. Surprakash Rao, and Sansko Matsunoji. That's great, lovely photos. Why don't we join the chairpersons? I'm sorry, we are running almost 45 minutes late. Chairpersons, please kindly take over the scientific. Yeah.
Hayashi can come over and give the talk. Hayashi will be giving on the externalization, make it easy. He will make it easy for us.
Thank you, Chairman. It's a great honor to be here. I'd like to start with my presentation about externalization. This is my COI. This the first is introduction to this presentation. What is the externalization? In CTO case, we sometimes use a retrograde method. Using a technique such as reverse cut, we pass through the CTO region from the retrograde direction and then externalize wire out from the antegrade guiding cuts. So this is called externalization. So what is the advantage of the externalization? In the case of the CTO, it is difficult to deliver the balloon and other devices due to the severe qualification and or totality of the region. So an externalized guide wire will be able to provide the maximum support for delivered balloon and other devices. So how can we say such a thing? Let's think about the mechanism of the balloon passing through a region. There are several factors involved in the force required for devices to pass through the region. But the main issue is the wire slipping out. If the tip of the wire can be secured, the issue can be resolved. In other words, if the externalization is possible, maximum backup can be achieved. So now please let me speak on how can we make externalization easier. The key element of the externalization is inserting the retrograde wire into the antegrade guiding catheter in order to achieve a rendezvous. So I'd like to proceed with the discussion emphasizing these three keywords. The homemade snare and guide extension catheter, and the trapping balloon. The first keyword is homemade snare. The subtitle is easy catch. The type of the externalization can be divided into the two categories based on the rendezvous point. Inside the coronary artery or outside of the coronary artery. If the rendezvous point is outside of the coronary artery, a homemade snare plays an important role. I'll explain based on the case example. The patient underwent the PCI for RCA ostium 6 years ago. And the DS in the RCA had been occluded. So as you can see, there is a rich septal collateral from the LAD to the PDA. The circumflex is normal. So this is a summary of the RCA. The stent had been occluded at the proximal end of the RCA. And the occlusion length was about 30 millimeters. Unfortunately, the stent protruded approximately 3-4 millimeters from the origin of the RCA. And no guiding catheter, including the diagnostic catheter, could be engaged into the RCA. So we had no option to go through with the antegrade method. So fortunately, I already had a good septal channel, so it was easy to establish the retrograde method. So after some time, the retrograde wires shown black with Caravelle microcatheter was able to catch the aorta. The next step was to catch the retrograde wire from the antegrade guiding catheter to achieve externalization. So in Japan, these snare devices are available in snare and gooseneck snare. So sometimes we use in snare and gooseneck, but these are expensive. So I'd like to present homemade snare as useful snare. The cast of characters are the guiding extension and a normal wire and a 2 millimeter balloon. This is the animation. The first, I extended the wire approximately 30 millimeter from the tip of the balloon, and to make a bend with a wire bend, the insert it through the exit port of the guide extension together with the balloon. So advance to the tip of the guide extension and trap the tip of the wire by expanding the balloon inside. So push the wire makes the snare loop bigger. Putting on the wire makes the snare loop smaller. So we can adjust the size of the snare loop freely. Okay, the redwood wire easily went through the snare loop, and the homemade snare was able to catch the redwood wire. The size of a loop is crucial. A homemade snare can make the loop larger, making it easier to catch the redwood wire. In case where the anti-grid guiding cutter cannot engage, the snare becomes the key point. So next keyword is guide extension cutter eliminates excess space. So to explain this, it is appropriate to show you the case where the random point is inside of the coronary artery. So I'll present the case of RCA and the circumflex CTO. In both cases, the wire was successfully passed through the CTO from the redwood direction, and it now attempted to enter the anti-grid guiding cutter. But it keeps passing besides the guiding cutter, and it's struggling in getting inside. So I'd like to illustrate the simulation using the animation. This is the case of the LED CTO. The wire has successfully passed through the redwood region, but it's about to be inserted into the anti-grid guiding cutter, but it is difficult to get in. So here the guiding extension cutter makes it easier to insert the wire. This is because the extra space can be eliminated when the guiding extension is advanced to the coronary artery of the target. So without guide extension, there is extra space around the guiding cutter where the wire will be advanced, and it will be difficult to continue it within the guiding cutter. So this is the actual CTO case of RCA. It's difficult to accommodate within the anti-grid guiding cutter. So guide extension is used. The wire was able to advance into the anti-grid guiding cutter through the guide extension without swaying. So guide extension cuts are available from the various countries and play a very important role in facilitating externalization. The last keyword is trapping balloon. Trapping balloon minimizes blood loss. So as explained earlier, in externalization, the wire entering from the redwood guiding cutter must pass through the heart, and eventually there exists the body retrogradely through the Y connector of the anti-grid. So I will demonstrate the conventional methods. The wire cannot pass through the Y connector as it is. So an inserter is used to pass it through. When the Y connector and guiding cutter are separate, a significant amount of the backflow is observed. In this state of the backflow, the wire is inserted into the inserter and passes through the Y connector. So resulting in significant bleeding, as you can see. So I'll show you the a method to minimize bleeding using trapping balloon and advance the retrograde wire as far as possible, and use a balloon of 2 millimeter or larger as a trapping balloon, and insert it from the anti-grid wire connector and expand it inside of the guiding cutter. So in this state, even if you remove the wire connector, there will be no bleeding. So insert the inserter into the Y connector, and we can calmly insert the retrograde wire into the inserter. So insert the reconnect and the wire connector to the guiding cuts the deflate in the balloon and advance the wire outside of the body. So I was able to complete the procedure without almost no bleeding. So today's presentation was these 3 keywords: homemade snare, guided extension catheter, and trapping balloon. So I provide the success rate of my own CTO cases over the past 5 years, as well as the ratio of cases success with antegrade approach versus retrograde approach. The success rate of average is around 95%, with the retrograde approach being performed in roughly half of the cases. So in order to maximize your success rate, it is important to master the retrograde method, including externalization, reverse cut, and other techniques. So this is the last slide. Externalization is an important element of the retrograde method. So how smoothly the rendezvous can be achieved is crucial. So I hope today's lecture will be useful for your CTO PCI from tomorrow onwards. Thank you for attention.
Excellent talk, Hayashi. Actually, I will ask you. Then a snare bought from a company is more expensive than a guide extension catheter. So if you require a guide extension catheter for making a homemade snare, so the cost of the guide extension catheter versus snare, which is actually, what is the difference? If you make it, if it is cost effective, I don't know whether it is cost effective. Number 2, the last one, if you're using an old balloon is okay. If you are using a used balloon, then definitely that is that blood loss of 25 ml or 10 ml, whether it is worth or having a new balloon, is it worth? Can you just explain 2 things?
Okay.
Did you get? The first question is homemade snare versus industry-made snare.
Yeah.
The cost difference. If you take a guide extension catheter versus a industry-made snare.
So, because in the case of the CTO, already the 2 millimeter balloon or another floppy wire, something that is already open. So it's a low cost. So how can I say the commercially available snare is about $700 in Japan. It's very expensive. But guide extension and floppy wire.
So the homemade snare, the caution is you have to use polymer jacketed wire. Otherwise, you won't be able to see the loop.
Yeah.
You know, if you have polymer jacketed wire, you can see the loop nicely. But if you use the normal wire, you can't see the loop properly. You got my point. Only the tip is radio opaque.
Yeah.
Got my point? So if you have a polymer jacketed wire trapped inside the guiding catheter with the balloon, you can see the whole black thing. Right? So what wire you choose? You got my point?
That's so I prefer the cold wire for the homemade snare because trapping the tip of the wire is very important. So in the, of course, hydrophilic wire is radiophilic part is so long, so easy to see, but it's a
Yeah, just want to understand concept.
Just small question.
Yeah, very small. Just want to understand concept. If your guide liner is put side, you have already blocked the lumen of guide liner. Then how you are going to put this guide liner into guiding? So if your guide liner lumen is blocked already with the balloon, you are going to put into the guiding catheter. How are you going to put into the guiding catheter when there's no lumen in the guide liner?
Sorry, I can catch up, sorry.
Sorry? Yeah, but it means wire has to be kept outside the guide liner. It means guiding wire.
Actually, when you in the guideline, there is a portion of nearly 18 or 20 centimeters where you can keep the balloon inside and then take that. Usually, we take the like that and take a wire just distal to that. If possible.
Once your balloon is inflated into the guide liner before putting inside, then how can you put the guide liner inside?
Yes, set up outside of the body.
Yeah, you already inflated balloon outside the body.
Yes, yes.
Your guide liner lumen is occluded now.
So, but you can use a fluoro.
Yeah, how can you?
Basically, you are not going into the guide catheter. You are keeping outside. The 6 French, what is the size? 6 French or 5 French?
Yeah, 6 French.
6 French. It's possible.
Anyway, this is a very important point, fundamental. Less bleeding, smaller, actually the shortened procedure time is very important. This is actually the nice lecture. Thank you very much.
Thank you.
So next speaker will be our leader, Yamane Sensei. The topic is very, important, very interesting. New techniques and technology of the CTO-PCI 2024. So please.
Thank you very much, Dr. Nakamura. And I congratulate you for the successful meeting here, because over the 10 years, I'm fortunate to be invited, but never thought that you are growing success year by year. And now you are the most, one of the important CTO-PCI meeting in the world. So probably my topic today is just one of those future predictions regarding a technique as well as a technology. When you look back upon our technological as well as some technical development, probably over those 20 years, our most exciting history in the medicine and our interventional cardiology. This is back to 2004, the initial report of the how to combine the IVUS into the CTO-PCI. But now that those things are modified in the future development for the puncturing the distal lumen by Dr. Okamura here. And I'm very much happy to announce that this method is kind of the very much revolutionized to the re-entering in the distal lumen by just applying the IVUS as well as using the careful navigation of the guide wire. And this is one of the examples how the tip method will be utilized for puncturing the distal lumen, which will be explained detail by tomorrow by Dr. Okamura himself. So probably when it comes to the new technology, just in your recent development, the Gaia Next series is most closer to our application. Today's live as well as tomorrow's live. And compared with the old Gaia series, probably outer sleeve of the Gaia tip is very much more improved for the rope coil of the structure, which is more resistance in the very hard calcified portion. And even in the very much trapping state, probably you can improve. This is one of the examples of the very bending and calcified proximal RCA CTO, including the ISR here. So when we started with the XDR guide wire, a little bit softer, so we can change in the Gaia Next 1, which is rather basic 2 gram stiff guide wire, but which is very much good transmission of the torque force. But you can see that the multiple projection is encouraged for the Gaia Next series, because some people say that it's more perforative because that they are spinning the guide wire. This is definitely not spinning the guide wire, just a directed guide wire to puncture. So even in this case, multiple projections and upgraded the Gaia Next 2, which penetrate through the direction of the side branch first, and then pulling back to the distal lumen. And at the end, probably we can confirm, sorry for a little bit time, and go into the distal lumen here.
So in this case, we can finish with the integrate, and usually it's very nice to have those kind of procedure, as Dr. Okamura indicated, that the integrate is almost always faster and simpler to putting the stent. But at the end, probably we need more application of the shock wave because of the undilatable lesion in the proximal portion. But at the end, probably still we have some disease segment in the middle, but this is the end of the procedure. Now we have a GYN-X4, which is a little bit more new, and which is a 10-gram tip load and very much rotatable, so-called Confianza Pro. So this has a very strong power to penetrate, even with the use of the, sorry for that, the model here, compared with those conventional guide wire. It's more directed, and sorry for the animation not work. And this is one of the example for the stent is left main to the LAD proximal portion, and the ostium of the circumflex is blocked. And even if we explore the retrograde channels, we did not see anything. So when we use the GYN-X4, which has a very strong dielectric penetration force, actually we can get into the CTO segment, and after step down into the UV 3-gram wire, you can see the progression of the guide wire, which was confirmed by the IBIS. It's all through the subintimal space here. So in this case, using the first guide wire there, and the second system is used GYN-X4 with a 90-degree tip under the IBIS guidance. When you can see that this is a calcified portion, and this is a penetrative wire here, and that way you can leave the first guide wire and the application of not a parallel wire, but a 2-guide wire technique. You can advance a second guide wire, step down into the UV3, and at the end, you can get distal to lumen, and we can achieve the very nice outcome after stent placement here. So probably GYN-X4 expands our possibility even in the heavy calcified portion. This is this proctor shape here, and you can see that even the advancement of the cyan blue wire just jump out of the ostium. So this is a little bit anomalous origin of the RCA. So in this case, probably a reasonable option would be the retrograde, although you can see the very much so-called dangerous epicardial collaterals, but in this case, so the 3 managed very nicely and exchange to the UB3 to penetrate the CTO back to the proximal portion. The idea would be probably this is a very nice to have a snare at the end, externalization done, and probably we can place stent. But the problem realized here is the retrograde microcatheter could not grow. During the entire effort, the retrograde system actually disassembled. So in this case, probably back to the square one, what do we do? So in this case, no lot of option, but since we have a GYN-X4 not only the penetrative wire, but it's very much drilling and penetrative inside of the vascular structure. So this is a little bit anomalous use of this wire, but once we advance it, you can see that the GYN-X4 is inside of the vascular structure using a dual lumen catheter, the second guide wire CP12 with a little bit longer tip, so like CP12ST, and then you can navigate the second guide wire into the distal calcified segment here. At the end, you can get the second guide wire into the distal lumen. After ballooning and stenting, probably good enough support to advance the guide catheter extension deeper and deploy the stent, although we can recognize the diffuse disease distally, which will be growing larger in the future. So probably this is some algorithmic approach in the most updated one, Japanese expert registry. And guide wire manipulations about 20 minutes if you choose a primary integrate, but primary retrograde approach also exists. And the novel thing is once you are getting up some difficulty, either you can explore the integrate like a parallel wiring or the IVUS navigated, Or you can switch to the retrograde, of course, reminding that those kind of a limitation exist, a one-time CTO procedure here. This is already mentioned, the global CTO algorithmic, so we are reaching some kind of agreement that the 7 principles of the CTO PCIs are pretty much important now and future. And this is new things for the a little bit plasma wire system for the development of the software. Probably a penetration plane view is a pretty much important concept to include the plane of the proximal lumen to the distal to lumen here. And objective perpendicular view is a OPV that is a 90-degree, exact 90-degree plane. The reason is that we try to figure out the exact mathematical orthogonal projection. Why do we need? Because for the future plasma wire system now developing is used in the future. Just in brief, short notice that this is a burst of the energy here, and this is a microcatheter, and the spark is actually generated between the tip of the microcatheter and the tip of the guide wire. But to use it, we need to have a precise guide wire location. At the same time that we need to calculate the place to burn, because we have some kind of a generation as a feed as well as a bubble as a byproduct in the procedure. When we have axis vector analysis software, that means probably we need to have exact orthogonal projections. Why we need it? Because we exert repetitive, very high burning pressure on the 1/4 of the CTO segment. And then the ACD synchronized fluoroscopy is a pretty much new things, and this is a gated image. So like a CT scanning, actually the picture is gated on the fluoroscopy. So the heart is stopped moving. So you can see that the very much still frame to puncture and pinpoint the guide wire direction, which will be explained tomorrow by Dr. Matsuno. And this OPB and PPV method is explained by the Dr. Nasu tomorrow. So even with the mechanical guide wire, probably you can apply some futuristic application of the software here. So when you see those kind of the CTO segment using this biventricular software method, and probably you can get the integrated wire into the distal true lumen. So guiding principle of the plasma wire system so far, the first human study already finished, pre-approval clinical study is successfully finished. So the future will be coming, and whether you take it or not is probably your own skill set as well as your background, as well as availability of the software system. So this is a contemporary summary of the CTO PCI. So new techniques and technology for CTO PCI. Contemporary CTO PCI have heavily relied on the technological development. Wires, guide wires, stent and balloon, and imaging devices are the backbone of the current CTO PCI. But feedback from each user, that is each one of you, the physicians in front of the patient, has greatly promoted on the technological innovation as well as competition. Hands-on experience has improved the PCI technical skill set as well as an algorithmic approach with more success and fewer complications. And last, lesson from the failure, acceptance of the new ideas as well as accommodative for the new technology are the keys for our better clinical outcome in the future. Thank you very much for your attention.
Thank you very much for nice lecture. I have one technical and one technological question to you.
Yep.
The first one is this plasma wire can penetrate the distal cap precisely?
Yeah, that's how we combine some hardware as well as the software together, because it's a very much high safety level always required for this
anyway,
system.
Possible and anyway possible. This is possible.
Yes, possible. And to be honest, some research suggests that some risk of the perforation always exists.
Maybe
So,
yeah, this will be the very big advance.
Sure.
So next question is about Gaia Next Wire. Actually, I also use the Gaia Next Wire 6 or 7 years maybe, and when the wire going to the very deeply, and if we feel some tight the situation, and sometimes we like kind of the spinning. Like a kind of the spinning. Of course advanced, but a kind of the spinning. So in that kind of case, did you feel like, so company said the anti-clockwise rotation make it some like a tight, the wiring. Did you feel that?
To be honest, I don't feel the difference because that the inside of the some structure in the core system, actually the double core structure,
like
actually it's like loose when the outer coil is tightened. So those kind of interaction will reinforce the guide wire structure.
When I look at some like a good operator, always in a kind of the spin, always they made anti-clockwise rotation. So just so I ask.
Yeah, that's recommended by the company. Yes, yeah, I know that. Yeah.
Dr. Yamani, excellent talk. Plasma wire can even penetrate the calcium?
Yes and no. It's situational because not always, to be honest. So it's like substantially like more CP12 wire, something like very close.
It will not behave like a laser and all. It will be...
It's different, yeah.
Different. I think we have to use and then understand these things, right?
Yeah.
I think if no more questions, give a excellent big hand to him. Excellent talk.
Thank you very much.
Thank you. We will call upon Dr. Surya Prakash Rao, the course director and organizing secretary, make this event such a wonderful program now. Actually, you can see the fellows course making such a big crowd I have never seen in one of the meetings recently.
Thank you.
Surya, can you talk about that? Thank you.
I will try to compensate some time. We are running short of 45 minutes. So, when I am doing this procedure, I thought I am first time doing. Later I realized many cases have been done, long back, 10 years back. So, the Rendover technique is that actually it is in the guiding catheter, antegrade microcatheter and retrograde microcatheter together, very close, then wired from one end to other. But what more useful is the intracoronary Rendover technique. In this, the technique was crossing particularly with the Gaia series, where one-to-one torque is there. You can pass the guideway to contralateral microcatheter inside the block in the CTO lesions. So I have done around 14 cases so far, this in last 10 years. This is a female with the antival MI, already stented the lady. It is anomalous RCA. You know, a simultaneous injection involves the anomalous RCA needs a good support also. Basically, there is a tight CTO with a mid-tight stenosis and the good retrograde collaterals from the LAD. So the septal collaterals are good in this case. So fair chance of any operator trying for the collateral in this case. So the initial antegrade preparation as a standard protocol done with the fine cost with the field XTR, but there is a difficult penetration antegrade subintimal position of the wire. Even the Gaia series escalation of the wire also found to be in the false lumen. So there is selective injection, then I tried for the S2 collateral, then Corsair 150 with a CO wire crossing the collateral. It's not that good because the collateral is good, no difficulty in crossing this. If you see the retrograde injection is a side branch, but the up to mid segment is the CTO. So the antegrade Cyan and the retrograde Gaia rotational angio. This is very important. When you don't have IVAS, this I have done some other place where there is no provision of the intravascular ultrasound. So they are in the false blind, not in the rotational angio, very useful in this type of cases. So I tried for a Godzilla supported reverse cut also. that is also not successful. Then there is a failed retrograde wire into the Godzilla. So finally, I tried the antigrade Cyan into the retrograde Corsair. I think this is the first case that time I have done this. And after that, I found this technique is very useful. The rest of the thing is the ballooning and the stenting. And final result is this. So this technique is very useful. Initially, we used to think that when you fail many things, you can try that. Later, I find some of the cases you can try this case. So learning from this case is that the anomalous RCA with short stump occlusion, difficult subset, and Godzilla guide extension assisted procedure provides extra support. Rendo technique is alternative for composite core wires like CN or field XTR. A rotational angio, if there is no IOC, is very useful. This is another case of old inferior MI and LV dysfunction, and a PC attempted back by somebody. The simultaneous injection showed mid RCA long CTO with good collectors from LAD to PDA. This is already tried case, so CTO score JCTO of 3. So a retrograde approach adapted because of this score and already tried case. So at that time the Corsair 150 I used to use more cases, and the injection of this S2, the cyan blue can cross the retrograde collateral easily, and antigrade preparation has been done. There is another CTO at the mid segment also in the RCA. Here the wire-based re-entry clearly has shown that how to enter a Gaia 2 re-entry. Gaia the 1-to-1 torque, we can cross easily the mid RCA. But the problem came at the distal end. The retrograde Corsair injection, selective injection has shown there is another CTO, and the crusade guided entry into PDA also very difficult at this. So here the Gaia 2 with the bifurcation we tried, that also went into the false lumen. So the reverse cut also I tried at CTO site, no communication made. So I given a retrograde Corsair selective injection, very carefully aspirating 0.5 ml. So here I tried the Gaia 2 with a Rendu technique to the retrograde Corsair into the PDA. So then the antigrade Corsair threaded to the PDA, and the rest of the procedure. Always remember that you check the retrograde without no septal injury in any case. A long DS deployed in the distal RCA. So this is the case with final result. So there are many cases, but I just want to conclude here in the interest of the time that this technique can be a routine, but unfortunately it's not there in any of the CTO crossing algorithms. I think next time when you do a consensus, global consensus, I recommend this to be included. I even recommend to Dr. Bilakis when he published the article with all our names. Thank you.
Actually, intracoronary rendezvous technique is actually not known by many people. Actually, one case I have done, basically when you have a severe calcium there, can we cross like this? Or in only severe fibrotic lesion, a calcified CTO in the mid part, whether we'll be able to take a rendezvous. If it is that rendezvous done, can we push the micro? It will be difficult to take the microcatheter down. What will be
in a calcific lesion rendezvous? Because the type of the wire also very important. You have to have a 1-to-1 torque. I find the Gaia is a very useful wire in this technique. But the problem in Gaia is the calcific lesions. It gets stuck sometimes.
But actually Gaia next will take away the major problems of Gaia wires. Gaia wires, when it is stuck in the calcium, it will be broken. But Gaia next is a little bit better than the Gaia wires.
I agree.
I think any more questions from the...
I think they should be very close. You should give a gap naturally. Okay.
I think that is because of the intra-plaque. If it is in the catheter, it should be very close. But in the plaque, you have a chance of getting into the, there will be minute channel only. So through that channel, from
maybe
one
some micro channel. Because if you have done a intravascular ultrasound before, we could have known.
That is why I asked if it is in a severe calcium, it may not be. And moreover, actually, he is telling a torqueable wire is, guide wire is important in this case, not normal wire, right? I think
Yes, so very nice presentation, Dr. Surya. So I think you said that it's not mentioned in the algorithm. So the rendezvous inside the CTO segment is a type of kissing wire technique.
Kissing wire
technique. So it's a type means you're using a microcatheter, retrograde or antegrade, and the other wire is just kissing that wire. So kissing wire technique is quite underrepresented, or maybe people don't mention it, but it is a recognized type of retrograde. It is considered as a retrograde procedure, as like in our Euro CTO club, we enter as a retrograde procedure. If you take the wire or do retrograde, and you can't do cart or reverse cart, and if you then take a wire, not soft wire, but some kind of a wire which you can control like Gaia 2, invariably you can get parallel to it in like kind of a rotational angiogram, antegrade wire close to the retrograde wire. And then obviously the step up is like you can get into the rendezvous technique. So kissing wire is a very important technique if nothing works and you are good at handling wires, stiffer wires, Gaia 2 or Gaia 3 type of wires, and you can align it to the retrograde equipment in multiple views, and you can successfully do the procedure, integrate true to true lumen if there's a big subintimal space.
But it is not specifically a kissing wire. Kissing wire is actually a marker wire technique. You have a retrograde wire, and antegrade wire is actually crossed by looking at the similar position of the retrograde wire. The wire is crossing.
To see the architecture of the vessel exactly.
Yeah, but this is actually a different thing because intraplaque, intracoronary rendezvous technique.
Tip in.
Tip in, but it is actually like there is as Anil told, it can be spaces actually. It cannot be as close as in the catheter. I think thank you, Surya, for giving. One question you have. I think he has no question. Thank you, Surya Prakash.
Okay, next speaker will be Dr. Matsuno. And Dr. Nagamatsu, Dr. Matsuno is a new leader in the Japan field of the CTO PCI and actually established. So anyway, let's enjoy his talk.
Yeah. Actually, he was a non-person here. Last year also he was with us, and he's one of the very nice. But no, thank you.
Sorry. Thank you. It's a great honor to be part of this wonderful session. So today I'd like to talk about my favorite bailout tools for balloon uncrossable and balloon undilatable CTOs. This is my disclosure. As you know, CTOs, balloon uncrossable CTO lesions are defined as CTOs that cannot be crossed with a balloon catheter after successful wire crossing. Oh, sorry.
You have to proceed for the next slide.
Okay. I don't know why. This one. Okay, sorry. Let's start. Balloon uncrossable CTO lesions are defined as CTOs that cannot be crossed with a balloon catheter after successful wire crossing. Balloon uncrossable CTO lesions are often also uncrossable with a microcatheter, and these lesions account for 6 to 9% of CTOs treated with PCI, and one of the biggest challenges of CTO PCI. So we need to familiar with the bailout strategy for this kind of difficult lesions. Sorry. Okay. This slide shows an algorithm for crossing balloon uncrossable CTOs. This is an algorithm proposed by Dr. Manos Bourakis. In this algorithm, the various techniques and equipment should be attempted sequentially or in combination with others. It includes small balloon crossing, granuloplasty, increasing support using guide catheter extension, anchor balloon, and special microcatheter such as Turnpike Gold, Spiral, or Tornus Pro, and wire cutting or wire puncture, excimer laser, atherectomy, and extraplaque techniques. But there can be some differences in the preference of technique or availability of the equipment in our daily practice, so we need to make modifications so that this algorithm fits our own procedures. As for me, increasing guiding support is the first thing to do. side branch balloon anchoring, guide catheter extension, and power guide extension are considered. As you know, power guide extension is a technique to increase support for device delivery by inflating a balloon beside guiding catheter extension placed proximal vessel, within the proximal vessel. And the next thing to do is try small balloon crossing. My preferred small balloon is in Rise 0.75, Sapphire 0.85, or Relay 1 millimeter. If small balloons can't cross the regions, I tried a smaller microcatheter such as Jizai or Mogul SP thinner, or special microcatheter such as Tonus Pro. And wire cracking with higher penetration force wires such as Confianza Pro 12 or Miracle 12 is sometimes helpful to overcome this difficult situation. If the microcatheter crosses the lesion, it is easy to exchange wire for the rotor wire, and doing rotational atherectomy, it would be the most promising solution. But as I told before, balloon uncrossable lesions are often difficult to cross with a microcatheter, so exchange for rotor wire is sometimes very difficult. As the rotor wire drive has become more torqueable than previous one, but so the lesion can be crossed with the rotor wire drive after the microcatheter is advanced to wedge the lesion, but there remains some risks for losing wire. So I prefer the parallel wiring. I mean, I try to advance another high penetration force wire through the occlusion to the distal vessel with the first wire as a landmark, and then remove the second wire, and then the rotor wire drive is advanced through the channel that a high penetration force wire has created. So it is a reasonable way, because we never lose the first wire and try to cross the lesion with the rotor wire. Please let me show you the two cases. Okay. Not moving. Why? Yeah, moving on my screen. Why? Okay. Not moving.
Can you check it is working or not?
Please check.
In the meantime, I'll ask you.
Okay. Okay. I'm sorry for taking time. But okay. Not moving on my screen, but okay. This is the case of the LED short occlusion. The occlusion length is very short, but the lesion is severely calcified.
Again, not working. Can you just operate from there? Can you control from there?
I'm sorry, but I'm not prepared for the bailout of this difficult situation. Yes. More difficult. Yes.
No. In the meantime, I will ask you that when you have rotor wire down and you have Mogul SP like very minute microcatheter, keep the microcatheter there and take a rotor wire. And now we have a rotor drive wire available.
Yes.
When you have a rotor drive, why do you have a parallel wire?
Agree. Yeah, rotor wire drive is more torqueable than before, so it is one option. But if the lesion is long, there remains some risks of the unsuccessful wire crossing with rotor wire. So I prefer the more promising way.
I will ask questions later.
Yes, okay. So this is very calcified short occlusion. And the lesion itself was easily crossed with XTR, but fine cross GT couldn't cross the lesion. So I tried relay 1 millimeter and Zinrai 0.75 millimeter small balloon crossing, but they couldn't cross the lesion. So again, next Tornus Pro was attempted. It showed some progress, but it couldn't cross the lesion. And Tornus Pro couldn't cross the lesion even with the support of the guide catheter extension. And small balloons and lower profile microcatheter Zizai were attempted with the support of guiding catheter extension, but they couldn't cross the lesion. So I decided to do the parallel wiring. So another Confianza Pro was advanced through the lesion to the distal vessel, and after successful wire crossing, Confianza Pro second wire was removed, and rotor wire drive extra floppy was advanced to go through the channel that Confianza Pro has created, like this. So by applying this method, we never lose the first wire and try rotor wire drive crossing. And after 2-wire crossing, the first wire was removed, and then rotational atherectomy was performed using 1.25 millimeter burr. And after that, microcatheter was smoothly advanced to the distal true lumen. And after exchanged for workhorse wire, predilatation was performed using 2 millimeter and 2.75 millimeter NC balloons, and 2.25 millimeter and 2.75 millimeter drug-eluting stents were deployed, followed by 3 millimeter NC balloon dilatation. Final angiography showed an excellent result with perfect stent expansion. The second case is a mid-RCA short occlusion, and you can see severely calcified tight stenosis at the proximal vessel. In this case, there was a promising retrograde option from the LAD to the PDA, and this patient had a severe CKD, so we had to reduce the contrast dose. So after the septal channel was crossed with SO3 and Caravel MC, this is a dual injection angiography through antegrade and retrograde microcatheters. It revealed short occlusion with severely calcified diffuse disease. Anyway, the workhorse wire was advanced to the small RV branch next to the proximal cap, and then 2 millimeter balloon dilatation was applied for the proximal lesion. After that, Corsair Pro was successfully advanced to the mid-RCA with the side branch anchor technique, and antegrade wire escalation was performed with the Gynex 3, but it was unsuccessful, and the Gynex 3 had migrated into a fourth lumen. So I moved on to the retrograde wiring, and the Gynex 2 was advanced to the occlusion and succeeded in making wire overlap within the occlusion. So I tried to advance an antegrade balloon catheter to the occlusion to do reverse cut, but even with side branch anchoring, small balloons couldn't cross the proximal occlusion, proximal stenosis. So I tried power guide extension technique to facilitate balloon delivery, but Zinrai 0.75 couldn't cross the proximal stenosis. So I changed my mind, and after the retrograde wire was advanced to the extraplaque space of the proximal RCA after bypassing the balloon uncrossable lesions, then Gynex 4 was intentionally advanced to the extraplaque space from the proximal RCA, so-called scratch and go technique. This is a bilateral fluoroscopy after Gynex 4 advancement, and you can clearly see that both antegrade and retrograde wires were overlapped within the same extraplaque space. So 2 millimeter balloon was advanced over the Gynex 4 to the extraplaque space and inflated. Then extended reverse cut was finally successful, and the retrograde wire was advanced through the connection to the proximal vessel. So the retrograde wire was successfully advanced to the antegrade guide. After guide wire externalization, predilatation was performed, And IVAS after that revealed the wire had nicely advanced beside calcification. After 2 drug-eluting stents implantation, final angiography showed a good result. Let's move on to the next topic. Balloon undilatable lesions are often severely calcific and are also often balloon uncrossable. Previous papers report 12% of CTOs are balloon undilatable. The algorithmic approach has been proposed also for balloon undilatable lesions. This is an algorithm proposed by Dr. Manos Bourakis' groups. Briefly, the high-pressure balloon inflation, plaque modification balloon, intravascular lithotripsy, ultra-high-pressure balloon OPN, and atherectomy, and laser and extraplaque tracking are recommended to be attempted with the aid of the intravascular imaging. But again, there can be some differences in the preference of technique and availability of equipment, so we need to modify this proposed algorithm. This slide shows my personal algorithm for balloon undilatable lesions. For me, the first thing to do is do IVAS examination. But if IVAS catheter cannot cross the lesion, I consider rotational atherectomy, mostly with a 1.5 millimeter burr, and unless the patient lesions are high risk for rota. But if the IVAS catheter can't be crossed through the lesion, I estimate a probability of balloon expansion based on the IVAS findings. Specifically, if the IVAS calcium score is low, I consider modified balloon or NC balloon. But if IVAS calcium score is high, my first choice is rotational atherectomy with a 1.5 millimeter burr. But IVL can be a selection for short circumferential calcium with large MLD or for high-risk patient or lesion for rota. Orbital atherectomy is not commonly selected, but is reserved for high-risk patient or lesion for rota. In conclusion, balloon uncrossable and balloon undilatable CTOs are challenging lesion subsets that require various techniques and equipment to overcome. We should have a personal algorithm for these lesions after considering equipment availability, the probability of success, risk, complexity, and cost of each strategy, and preference for each strategy. Thank you for your kind attention.
Matsuda, thank you. Matsuda, actually, the second case, you already crossed the wire retrograde. Did you cross the wire retrograde before? Then why did you do a balloon dilatation and I did not understand.
Yes, in the second case, the retrograde wire was advanced within the extra plaque space.
Okay.
Yes, and the retrograde wire bypassed the calcified part.
Okay.
And then, but at the proximal vessel, the retrograde wire was in the extra plaque space, but antegrade wire was proximal to lumen. So to overcome this situation, I intentionally advanced the antegrade wire to the extra plaque space, the same space, and do reverse cut.
Then you do reverse cut and then
yes.
Then you again cross the retrograde wire inside.
Inside the so-called extended reverse cut. Yes, to make the connection between the antegrade retrograde wires after bypassing the balloon uncrossable lesions.
So the initial wire when retrograde was totally subintimal. It was
yes.
actually you wanted to make minimum proximal part intimal, right?
Yes, exactly.
Correct. So the first, the last algorithm you told, balloon undilatable lesion. You don't have an IVL balloon, OPN balloon there?
Yes, unfortunately, OPN balloon is unavailable in
Japan. That is why you are not including that. No?
Yes. In my personal opinion, in my institute, laser is
undilatable
not
balloon. If you can deliver an IVL balloon, you can deliver an OPN balloon. He actually delivered an IVL balloon. You did not see the algorithm. His algorithm, he was showing IVL. Yeah. His algorithm shows rotablation. His algorithm shows orbital atherectomy. If you can do IVL, I thought in Japan, OPN balloon is not there. The OPN balloon is there in Japan?
Yes, not OPN is not available.
Not
IVL,
available.
IVL is available, but there is a problem of cost and crossability.
So I just wanted to tell Anil Dal, he has taken a photograph. In that photograph, you add OPN also. That's why. Thank you, Matsudo. Excellent talk. And we will be concluding the session. And we will call upon this Priyan sir to talk about the next session. Thank you.
Thank you, Dr. Pratap Kumar sir, Dr. Sunao Nakamura sir, and Dr. V.S. Ramchandra sir for making the session very lucid. Presentations were very excellent. Balloon is crossed, wire is crossed, tenting is done, but something different is also waiting for us. We start the session 6. May I invite Dr. Sudhir Rathore, Dr. Sevket Gurgulu, Dr. B. Srinivas, and Dr. N. Ramakumari. We have got some different ball games to be played when we are doing a CTO PCI, right from the idle patient to the idle CTO with difference. Dear chairpersons, we start the sessions. Please take over the scientific agenda.
Okay, thank you. Thank you for all your patience. And we are rapidly moving towards the end of the fellowship session. It's the second last session, session 6. So in the interest of time, if we can keep to the time, so next talk is given by Dr. Hamanaska about post-cap PCI. It's a different ball game.
Okay, thank you very much. It's very nice, and it's my very great honor to speak in this IJCTO 2024. And I'm so, I have a very surprise to all the audiences, so much enthusiasm for the conference. I'm so happy to be here. Thank you. And my topic is that the post-CABG CTO PCI. Actually, in my facility, I do the PCI 100%, not for the CABG. So I had a great, still some difficulty in selecting my cases. Anyway, so I will talk I'll show that this case, 70s male, and this patient had the previous bypass surgery, Liter to LAD, and SVZ to circumflex. So initially, it was 2008, and this patient was referred to our hospital after the bypass surgery. And he had a severe stenosis at the right coronary, which was unprotected, and we had to fix the right coronary. But anyway, so this is the native coronary of the left coronary artery. So here's, can you see? Okay, the left main trunk was have kind of moderate stenosis. And also there's a severe stenosis at the ostium of the circumflex, and also the medium stenosis at the LAD. And the bypass has a good patency, and the SVZ to the circumflex, and also the Liter to LAD was very nicely flowed. And after 1 year later, we followed the RCA lesion. And of course, at that time, we checked the left coronary. And the progression of the atherosclerosis is not so much. And also, there's a severe stenosis was found. However, the progression was not so severe. And however, this patient came back after the 12 years later. And at that time, we checked the angio, and it shows the progression of the native left coronary has impressed. And because of this one is the proximal part of the SVG, this patient had the kind of the chest symptom. So, okay, so which lesion we should treat? This is the native coronary, and this is the vein graft. It has already more than 10 years. But anyway, so because of the severe calcification we can see from the angiogram, and also there's some complicated bifurcation, trifurcation of the coronary artery. And on the other hand, this is quite simple lesions that we can treat easily, I guess. So maybe many of the audience will treat this one. And of course, I did the same thing, and I put the resolute stent on the proximal part of the vein graft, and it was opened nicely. But after 2 years, then this patient came back with the chest symptom. And of course, you can see the restenosis of the proximal stent. And also, this has a very have a calcification here. Maybe I will mention later. And the bypass graft is of the Lita artery. It was very nice. And at that time, can you see this one at the proximal of left main coronary artery was the very severe calcification and very tight stenosis, and the progression has very much great progression was observed. So I had no chance to treat the proximal part of the native coronary artery, so we had to go to treat the vein graft. Anyway, so this is the serial change of native coronary post CABG, and this is the control. And 1 year, there's no quite difference. However, the 12 years, it has much great progression, and also after that, still the much more progression was observed. Here I will show the outcome of CDO-PCI with prior CABG. This is the prior CABG patient, has older and more males, more complex lesions, and more calcified lesions, more lesion longer than 20 millimeters. And also the procedure has more complicated and anything. And this is the success rate of CTO-PCI, which show that even any of the studies shows that lower success rate with the prior CABG group compared to the without prior CABG group. So why post CABG CTO-PCI has lower success rate? So the patient with a prior CABG is older, exhibited more comorbidity, including hypertension, diabetes, primary MI, previous stroke, chronic kidney insufficiency, and left ventricular dysfunction. Also, the patient has exhibited higher complexity of the CDO lesion and vessel anatomy because CABG can accelerate development of native coronary artery and atherosclerosis due to the competitive flow generated by the grafted process, which I showed earlier. So how about the outcome? This is the freedom from MACE, which shows that after the patient post-CABG has lower freedom from death and also the MI, TBR, or reocclusion. Okay, this is Dr. Sakakura is one of our colleague, the Japanese colleague. He showed a pathophysiological examination of the coronary artery after the CTO lesion in patient with prior CABG. So as you can see in the radiogram, there is a severe calcification at the proximal and mid part of the CTO lesion. And also there's severe calcification and the bypass graft. And the specimen sections was showed that also the calcium was occupied, especially in the proximal part, the 70% was a calcified lesion. And even at the distal part of the CTO, the 48% was occupied by the calcium. So this is the comparison of the CTO with CABG and CTO without CABG. And even the long duration, compared with the long duration CTO, the plaque area of the proximal segment, CTO segment, and distal segment has much higher percentage of the plaque area. Also, this slide showed that the calcifications area is the proximal CTO segment, distal segment, even all these, during all these CTO segment, the calcium is much higher in with CABZ group. So I will show one case that we had to fight very much because of the calcification. The patient with diabetes, hypertension, dyslipidemia had undergone CABZ Lita LAD outer to OM in September 2006, and but the next year, 2007, the Lita was occluded, unfortunately. And CTO in LAD was tried to treat 2 times after the occlusion at other hospital. However, all of the trials was failed because of maybe the calcium. And the patient has still complained the chest comfort, so we decided to treat the third trial of LAD CTO. And this patient had a lower ejection fraction. The deterioration of the LV wall motion was found anterior septal wall and inferior and posterior wall too. Here the angiogram, it shows that the right coronary was very nicely flowed, and there's also the good collateral from the distal PD to through the septal branch to the mid LAD. And the occlusion was started with the ostium of the LAD, and so this a little bit ambiguous, but there's a severe calcification was seen on this one. And there's some small channel we could see to the maybe this is a small channel, but it goes to the diagonal branch direction. Okay, this time the flow of the graft, RA graft to the circumflex was very nice, and the collateral to the diagonal branch was found here. So this is a contrast, the coronary CT, because of this, the regeneration of the renal function. So we just did without contrast. But however, still we can see the severe calcification along with, this is a proximal of the ostium of LAD, and all through the CTO lesion, there's a severe calcification we can find. And so this is a procedure, so we can see that the small channel here and maybe goes to the diagonal direction. And so firstly, we used, okay, this is the septal channel, and the CTO length is more than 70 millimeter. So we checked the IBUS from the circumflex, and there's some maybe dimple can be seen here. It could be the entrance of CTO, but there's severe calcification. The plaque is observed at the top of the LAD. So we used the serum black to pass through this small channel, and it goes, but at distal, the wire was knuckled. Anyway, so we checked the IBUS from this part, this channel, and it shows that the distal part is the outside the subintimal space. This is the subintimal space, and the true lumen must be beyond the calcium plaque. And in the proximal part, this is the true lumen maybe, but maybe this one should be the true lumen. And because of the antegrade wiring was not successfully done, so we switched back to the retrograde approach, and it was quite easy to going up, and using the ultimate brochure and Gaia second, Gaia third, but still, because there might be a very hard plaque, the calcium is occupying this part, and also the angulation is very steep, so it couldn't pass the retrograde wire also. So we switch back to the antegrade wiring again, And using this wire as and the second wire, Gaia second was treated to go this way angiographically. However, it goes the different, the distance has a very much. And so we decided to check the IBUS again. So this is the second wire. The second wire, and we checked from the first wire. So the second wire goes into the subintimal space because of the maybe this the calcium, and so we needed to re-penetrate the more proximal site like this. So at this time, the two wires were already inside the subintimal space, so that it was quite easier to treat the penetrate with the miracle 12 ground with the third wire to proximal patch. And it goes like this. And antegrade wire was proceeded. It goes the subintimal space and it goes like this. So the antegrade knuckle was used to go pass through this calcified lesions. So anyway, so this was okay, and the reverse cut was completely done, and the final was like this. So okay, so this case has a third time procedure using bilateral approach, and the first wire went into subintimal because of the severe calcified nodule existed between the LAD main vessel and the ostium of the diagonal branch. So IVAS guided re-entry procedure for re-penetrating at more proximal site. And also in the middle of the long calcified LAD CTO lesion, knuckle wiring with Sion black made it possible to perform the reverse cut. And this is my conclusion slide. The CTO lesion post-CABZ has many difficulties with mostly from severe calcification, both entrance and middle of the lesion. And IVAS had a powered device to overcome this situation. Thank you very much for your attention.
Thank you, Dr. Hamanaka. You have very elegantly demonstrated the complexities with the post-bypass CTO lesion. I was just wondering what happened to the first patient you showed.
Okay. So
just
because
what
of
treatment did you receive?
We tried the ostium of the vein graft.
Again.
But it was very hard calcium. And so we needed to use the rotablator.
I think, So that was the point. So I think we have got accumulating evidence now that the saphenous vein graft PCI, the outcomes are not very good. And in the first time when he presented, I think it was a straightforward procedure. It could be done either antegrade or retrograde PCI. Even in the second time, antegrade and retrograde could be done. You can use the graft as a retrograde conduit and do the procedure. I think there is enough evidence now that possibly you should have a native vessel left main stem and start PCI. I think in the interest of time, we will move on to the next presentation, and then if there's any time left, we will do a presentation for the questions. Thank you very much.
Thank you very much.
Okay, we are moving to the next presenter here. We have an ICR CTO, different ball game, and our presenter is Reja Sekar Varma. Please.
Good evening. Thank you, Dr. Surya Prakash Rao and IJCTO for having me here. ISR CTO, as you know, clinical angiographic definitions are there, 50% or more of diameter stenosis in the stented segment. If you use intravascular imaging, it's 75% or more reduction of the reference vessel cross-sectional area. ISR CTO is when you have a presence of a CTO segment, 100% occlusion of more than 3 months duration in the stented segment. There is some difference between the incidental stenosis of a DES versus that of a BMS. Waxman's classification of ISR is type 1 mechanical, type 2 biologic. Here you can see that the neointimal proliferation is because of a hypersensitivity to the polymer that is used in the DAS as opposed to the BMS, local inflammation and delayed healing. And neoatherosclerosis is of course much more common in DAS ISR. Mixed versions are the type 3 where you have both biologic as well as mechanical causes. Type 4 is the CTO DAS ISR. And type 5 is when you have previously treated with 2 or more stents. You have different angiographic OCT and etiological diagnostic patterns. Type 1, type 2, type 3, and type 4 is the occlusive in the angiographic, the same as the type 4 in the etiological this thing. Looking at some of the OCT patterns, the homogeneous pattern is commonly seen with the BMS instant restenosis, whereas a more heterogeneous pattern is seen when you have a DES ISR. That's because of the increase in the amount of proteoglycans that are present. Later on, the ISR of a DES turns to that of a layered pattern where there's probably the initiation of the new atherosclerosis happening. And then once you have calcification or you have a lipidic collection, then there is new atherosclerosis. You can also see at 6 o'clock to 7 o'clock, you can have macrophages which are highly refractile and send shadows. There are different patterns of the ISR CTO. Pattern A is when the CTO is confined to the stent segment. Pattern B is when the CTO extends beyond the distal edge. Pattern C when the CTO is beyond the proximal edge, more than 5 millimeters in each case. And pattern D when the CTO extends both proximally as well as distally beyond 5 millimeters. The importance of these patterns are that the pattern A is probably the easiest to tackle. The highest success rates are with pattern A, and pattern C comes next with the next higher rate of revascularization or crossing again and further treatment with lesser MACE rates, pattern C. Pattern B is worse than pattern C, and pattern D is the worst of all with the least possible success rates and higher chances of MACE, higher long-term MACE results. In our experience, 76 patients with clinically relevant ISR over the last 2 years, 17% were ISR CTOs. One ISR CTO had a non-viable target territory, and so therefore we did not intervene in that patient. A failed antegrade wire crossing was seen in 3 patients, and one patient among these, one was amenable to a retrograde PCI. The other 2 were failed PCIs because there were no good interventional collaterals. Of the 10 successful ISR CTO PCI, reverse cut was performed in the one. NC balloon use was in all patients. Scoring and cutting balloon were used in 7 patients. Intravascular lithotripsy because of the presence of calcium was used in 3, and rotablation had to be used in 1 because there was both stent underexpansion plus calcification. Just balloon dilatation was performed in only 1 because of the patient had only pure stent underexpansion. As a reason, drug-coated balloon was used in 4, and DES had to be implanted in 5 because of patterns B, C, and D. What are the problems of ISR CTO PCI? The most common one is the unpredictable wire crossing. This happens because of the hypocellular proteoglycan-rich ISR of the DES, lack of microchannels, and when there is increased duration of ISR CTO, there is progressive calcification. The wire can pass substrate. If there are multiple layers of previous stents, again it makes matters difficult, and the wire may go through different layers of stents and make further device passage very difficult. Previous stent underexpansion adds to the problem. And if there are no previous records or no previous relevant information about the type of stent that was used, the diameters of the stents, etc., that can also add to the difficulty of doing the procedure. Reduced procedural success, increased MACE, increased long-term MACE have been seen in the earlier studies, but then there are other studies which have come later which showed these may not be true. So let us see. What are some of the mitigating factors when we do an ISR CTO PCI? Is the availability of previous records, a previous angiogram that delineates the anatomy very clearly, which shows the course of the vessel properly. You have the details of the previous angioplasty, the stent details, etc. And when you do the angioplasty, you have a roadmap made by the previous stent and on fluoroscopy, which helps you to do the procedure. Sometimes, of course, this roadmap can be faulty. Technical considerations, the wires, probably because of the lack of micro channels, you might need more penetration wires. Image guidance is optimal and probably a must in these days, OCT versus IVUS. You need to assess the reason for the stent failure. The use of crossbars has been given a class 1 indication in ISR CTO PCI. Preparation, you have different choices. You have the plain non-compliant balloons. You have cutting or scoring balloons. You have intravascular lithotripsy, ultra-high pressure balloons. And sometimes when you need to debulk, you can use rotablation or laser. It is inevitable. It has to be, it is a must that you should always correct mechanical causes, because this has to be corrected before you do completion of the angioplasty with either POBA, a drug-coated balloon, or a DES. So this is one example where a crossbus was used in a distal RCA ISR CTO. The crossbus was taken over the wire, and then with rapid spinning motion, the crossbus catheter just runs through the CTO segment without any difficulty, even in the absence of the wire. And then subsequently wiring and antegrade balloon dilatation and stenting gives you a very good result. This is another patient where debulking was performed with the help of laser. This is an LAD CTO in stent restenosis. Again, the passage of the wire was a little difficult beyond the CTO segment. Lacing was done with 40, 60, and 80 joules energy, fluents. And then subsequently, the wire crossed, was changed to a workhorse wire, and further lacing was done because the stenosis extended beyond the stented segment, and then subsequently to stenting, this was the final result that was got. Coming to the next case, this was a patient with an ISR of the RCA. Here, the previous operator had stented into an RV branch. And probably because at that time the cell was bigger or whatever reason, I don't know. But then when we wired the wire, the antegrade wiring was a little difficult because the wire, we did not know the actual anatomy distally. So somewhere along the mid RCA, the wire went out of the stent struts and was taking a course of its own. Then we went retrograde, and again the retrograde wire you can see is coming into the stent from an angle. A reverse cut was done, and then subsequently we had this good result. So substrate wire passage is always a big problem. So this is an example of an RCA CTO where the wire went very easily, but actually went past through some of the struts, and after balloon dilatation we found that towards the mid RCA you can see that this part of the stent has been crushed because of the balloon. There have been many trials in the management of ISR, but very few or practically none in case of an ISR CTO. So this is a meta-analysis of different studies using DES versus a DCB. In case of BMS ISR, the efficacy parameters were probably a little better with the DCB as compared to the DES, whereas the safety parameters were unchanged. In case of a DES versus DCB in a DES ISR, the efficacy was much better with the DES as compared to the DCB, but the safety parameters were partly better, not really significant, but trending to significance with a DCB. Again, so how do we decide? Patterns B, C, and D, probably you need a DES. In larger vessels, diffuse neoatherosclerosis in patients with stent fracture, probably a DES is better. Smaller reference diameters, multiple layers of stents, BMS ISR, you probably need a DCP. And comparing sirolimus DCBs versus paclitaxel DCBs. Again, each system is a different system, so probably there are no class effects, and but similar results have been found with respect to in-segment late lumen loss at 6 months and clinical outcomes at 12 months. Routine follow-up CAG does not have any role. Prolonged DAPT for 24 months is probably better than in case of DES in the sub-analysis of the Prodigy trial. Shorter DAPT with the DCB is a logical extension. 1 month probably should be enough, but there's no specific evidence in ISR, CTO, PCI. The composition of the DAPT and duration should be guided by the clinical presentation. So these are some of the registry data. This is a Spanish registry of 16 centers, 233 patients, 80% successful acute results. Lower success rates were found in circumflex artery lesions, osteal lesions, JCTO score more than 3, and in patients who did not have a femoral access. At median 20 months follow-up, TLR rate was 15%, reocclusion 6%, and stent thrombosis probably less than 2%. This was a Chinese study by Wang et al. 200 odd patients with ISR CTO in Fuwai Hospital, Chennai, compared with de novo CTO. Significantly lower failure rate with respect to ISR CTO, but significantly higher suboptimal recanalization rate as opposed to the de novo CTO group. The 30-day cardiac deaths were higher, but the 5 MI incidence was also probably higher, but p-value was only trending to significance and not completely significant. This probably the cardiac death and the MI incidence were related to the higher suboptimal recanalization rate that was found with the ISR CTO. This is a large pooled analysis of 4 multicenter registries, including the Progress, the LATAM, and 2 other large registries, with more than 12,000 CTOs, nearly 12,000 CTOs from studies. De novo versus in-stent restenosis were compared. 15% of the total CTOs were ISR CTOs. Diabetes mellitus, CKD, past CBG were higher among ISR CTO patients. They found similar technical success, similar procedure success between the 2 groups. In-hospital MACE was also not significant. But at 12 months, there was a higher incidence of MACE, marginally higher in patients who had ISR CTO. So this shows the successful crossing strategy. Most of the crossing was antegrade. Very rarely they had to do antegrade dissection and re-entry, and sometimes retrograde. This shows the cumulative probability of MACE in these patients, which the incident ISR patients had higher. Finally, I'll talk to you about this study that was published in Eurointervention 2020. It's a Korean study from Asan Medical Center. CTO PCI compared between instant CTO versus de novo CTO. The remarkable thing about this study was that there was more than 90% utilization of IVUS for stent optimization. And with this IVUS use, it was found that the technical success was similar, in-hospital adverse events were similar, and the similar 5-year target vessel failure rate was also seen, as also the target vessel revascularization rate at 5 years was also the same. So probably if imaging is used, they concluded that if imaging is used, probably it is likely that you may not have a difference with ISR CTO versus the de novo CTOs. So in summary, some do's and don'ts with respect to ISR CTO. You need to define the ISR lesion. Do use intravascular imaging. Do not rely on angiography alone. Identify the contributive factors. Do not stop after identifying one factor. Look for multiple factors. Address mechanical issues. Do not treat without first modifying the mechanical issues, and do attempt to address all identified mechanical issues. Treat as per the underlying stent type. Do consider DCB in preference to DES for BMS DSR. Do use DES for DCB for DES ISR. There is a mention about hetero-DES versus homo-DES treatment. If you have used a DES with a particular type of drug, you can always try a DES with a different particular type. But again, not much evidence other than anecdotal reference. Thank you very much for your patience.
Okay, just one short question. What is the rate of intracranial imaging if you are dealing with an instant CTO?
Yeah, it's around 80% or so.
Okay, so the question here is, I think, not opening the CTO, but treating it afterwards, opening the artery. So I think we have to understand the underlying cause of this instant CTO. Otherwise, it will be occluded in a near future, so it will cause more trouble than if you put another stent there without knowing the cause and treating accordingly.
Yeah, I think in the interest of time, we'll move on. Thank you very much, Dr. Rajshekhar. Let's now invite a good friend and a very experienced CTO operator. He's going to talk about ideal patient and ideal CTO to start program.
Thank you very much, my friend, and thank you for having me here after COVID. I think last time was 5 years. I'm very proud to be in IJCTO club again. It's fantastic to see all the audience still until 8 o'clock in the evening. So nice to be here. So I think it's my talk. It will be a very small, and because you all see all the patient selections, difficult patient until now, and tomorrow you will see easy and difficult case in doing CTO by experienced operators. So, but let's, because it's fellow course, so let's start to see the CTO program, how to select the patient from the start. Because whatever you see in the audience and previous experiences, operators has been done hundreds of cases, and they have been through a lot of complications and to deliver this very fantastic job at the end. So beyond this or behind this, they have a lot, huge, large experience to perform this kind of case. And we don't recommend you to start as we start before and to go through all the complication we have before, and you go through the all troubles we have faced before, because simply the technology changed. So simply we know that the CTO proximal cap is very hard and distal cap is very soft, so we know that retrograde sometimes better than antegrade. So how to choose these patients? Here, if you see this kind of simple PCI, it's very simple, but here CTO, this is also simple because it's short segment. And here we know the morphology of the patient. So we know that if we do a CTO, the most common 80% of the patient, 18% of the patient, they will have a CTO. Post-cabbage, 54% they will have a CTO. 10% during the STEMI will accidentally find they have a CTO. So, and patient, they will be, of course, diabetic, hypertensive, peripheral vascular disease, low ejection fraction, they have a heart failure, and all this together, when we see it as a patient, it's coming to our mind which patient to select to start the program. So we know, of course, the benefit to open the CTO and the challenge that we face. Of course, until now, we improve the quality of life, improving the ejection fraction, avoid the cabbage, and challenging still a long lesion and difficulty to cross, and all we have mentioned in before. So we are intervention cardiology like a pilot. I think it's a lot in the United States, a lot of intervention cardiologists has been tried to fly. So what's different between the intervention cardiology and the pilot? Yes, we have the same. Intervention cardiology always take a high risk, and at the end, all of our intervention colleagues, they are burning out. Long radiation dose, long journey, a lot of patients, back pain, so same tiredness like pilot. So is the difference between us and pilot? No. When the airplane crash, the pilot die with his all crew, all passenger. But during CTO, PCI, when the patient die alone, not with you. So he will die alone. So please take care for selection of the patient, because he will die alone, not you will die. Maybe you will go to jail, but he will not die. So Andrea Grozny has been die because he was very aggressive and going in the very bad weather against the recommendations. So always we have to take care why the pilot or aircraft crash. First, pilot not fully trained. That's very important. Airplane too powerful or double-engined, so there is no engine enough. Environment, bad weather. So that's why Andrea Grozny has died, because of bad weather. So when we are see the experience of the pilot, exactly our life. So here the intervention cardiology should have a good experience, so building up, so respect your learning curve to choosing the patients. Year of experience, you should respecting that. You have your friend or your colleague or your mentor or proctoring. Procedure volume, not comparing people doing 1 CTO per month, like people doing 5 CTO per days. So you have to have a good volume place. Cath lab, available device. Please, when you do case, before selecting the case, you have to have all equipment in your cath labs. You never know what's going to happen. So not let your patient die because lack of device. Experienced team, so you will build up your team. And again, supportive of your colleagues. Never work alone and never just here to your ego. Experience CCU as a backup for you. And of course, experienced surgeon with you. So when we go flying with Boeing 787, the thanks for Dr. Khaldoun gave me these slides, Al-Aswad. To perform a complex CTO, we have to have a very good angiographic picture. And I will go ahead in the next slide to see you how to select the angiographic picture. I think the previous slides was the same, previous presentations. So GCTA score is very good, not just to predict the success rate, but to predict the complication rate. So GCTO score, when we start the program, don't choose CCTO score 4 or 5 to be just open, I will open this CTO. No, start to use 1 or 2 or 0 maybe for when you start. When you recommend the procedure performance and experience operator. If it's yes, you just perform, and if it's no, you can easy to refer to other experienced operators. So here again, always intervention cardiology and CTO operators always like before the surgeon in UK say, when you say it's difficult procedure, he say no, in my hand is different. So always when we say to the intervention cardiology you're doing performance CTO, he say no, in my hand is different. No, respect the failure before. Study the case very good. Even you have, see it is simple, there is no simple case. So repeat the angio, see if you don't have a CT, do the CT before. If you don't have IVAS, do IVAS in this time. If they failed antegrade with longer procedure, you may go retrograde. And you have to have a case selections and your selections. So you don't operate when you are sick, when you have a cold, when you have to take a medications, when you are stressed, when you have a last night have a full alcoholic and you are just drowsy, when you are fatigued, emotion is not good, so you are good, so not overestimating your ability to understand his fatigue. So again, very important to see in your patient selections when something happened to your patient. So be careful when the patient starts to suffering about chest pain, short-term breath, hypotensive, bradycardia, wide QRS complex, ST elevations. You have to check what's happened. Again, we go by, again, all people here, I think Minus Polak is with us, so progress has been addressed a lot of things, of failure rate and selection of the patients. Age is very important when selection of the patient. Please, at the starting of your patient selection, don't start a very elderly lady with a peripheral vascular disease, very small vessel, long lesion, circumflex CTO. The failure rate would be very high. Calcifications, very long calcification, post-dialysis patients, post-cabbage patients. This is a very high risk of failure. Proximal cap. So you have to be selective patients which has not ambiguous proximal cap in the beginning, because ambiguous proximal cap, it means the high risk, the high chance to go retrograde. ADR, when you are not familiar with ADR, don't start without proctoring. You have to have a proctoring start with you the ADR, and retrograde, of course, step by step. Again here, with a registry of progress, have shown that the MACE is increasing with this point of the age, female sex, and the all I said for you before. So patient selection quickly to summarize. Patient age and sex is very important to choose the patient when you start. GCTO scores between 2 and 0. This is the ideal patient to start. Antegrade with good success rate. That's the ideal to start. Retrograde with good septal, not epicardium, is very good to start. And of course, that's wrong, I wrote. Of course, the retrograde with CBG with a good retrograde feeling, and ADR if you have a good training or proctoring. Avoid at the start the post-cabbage antegrade, very long segment, and you don't have a retrograde options. So it will be a very long journey, and the failure rate is high. Avoid a very long CTO circumflex. Avoid a very obese patients. You will get 100 doses of radiation. So don't start to have a very obese patient having a CTO with bilateral radial, and you cannot have these patients. Avoid the multiple attempt trial before without a good experience, a small vessels with a peripheral vascular disease. And here, very important to know the GCTO scores. And of course, this whole journey you have to go through to choose your access, antegrade or retrograde, guiding selections, or your gear. You have to be ready with all your gear. And challenge situations, of course, the radiation dose, post-cabbage, and all these strips. And the crucials to study very well the anatomy and the calcification, the collaterals. Yeah, and this here to know the collaterals. I will show you this, of course, when you start, you have to do a very good scheme in your mind. You will go antegrade, retrograde, ADR, so you have to put it in your mind. So here's the retrograde, very quick. So because antegrade, all of us already trained to do, so this is retrograde for septals. And here, very important to choose which septal you go. So you directly, if you have a straight, not angulating septal, or if in angulating but easy, the success rate to go, you go by septal surfing or tip injection for septals. It's two school, but two is working. But be careful when you do a septal injection. Never go with a surfing again, because you may cause a dissection, and you may go again with losing of these septals. Yeah, I would do one case quickly. 53 years old male patient, hypertensive, dyslipidemic, angina, hypokinesia in the inferior, CTO, ambiguous cap. It looks like short segment, but as usual, you never know. Antegrade wire escalation not working. Gaia next, Gaia third. Gaia third pass, but outside. When we see different direction, We are almost outside. So it's very important when you say, when you do your patients, don't believe one direction. So you have to take several directions. This is an old case. Yeah, and here is wire surfing. Very easy because it's very connected, very easy case. And this is an ideal case to choose when you start. Very nice, anyone can. And I remember Dr. Kato when we started retrograde before, he say, retrograde Khalid does not need experienced operators, so any operator can go retrograde. It's not true, but yeah, for him, it's, passing the wire through retrograde is not a big deal. Dealing after that with a complication is a big deal. You needing experience, but passing the wire through the retrograde is not so good. So microcatheter cross, distally, and kissing wire techniques was easy to direct the patients, and the final result. So, and this is the ideal patient to start with. If you go retrograde, this is the ideal patient to start retrograde. So important rule to select the patients for CTO, to visualize the occluded vessels, segments, the route, the CTO entry, the calcium distribution. If you know the key point before you start the PCI, CTO PCI, the CTO procedure successful rate will be developed. Thank you very much.
There is an excellent talk, sir, very appropriate to the present session for fellows, and is full of what you call wisdom and appropriate advice. So my question is, do you advise the young cardiologist who is about to start a career in CTO intervention, any formal training in CTO intervention before taking up, or can they start on their own with a simple kind of anti-grade technique, and they'll be escalating their skill level?
You know, if you don't have a mentor in CTO, you will go through all we do. And now with a very strong gears we have, the complication rate is very high. So it's not ideal to do a CTO case and kill 20 cases to start the CTO. You know, it's because sometimes the complication is fatal, especially when you go starting retrograde or going antegrade with some aggressive manipulations, and the patient start to complicate. So, and patient is asymptomatic sometimes. So we don't have indications, clearly indication to open the CTO. You know, the patient is we do the CTO to improve the patient quality of life. And he's asymptomatic, and he get difficult complications. So the answer to these questions, anyone will do a program of CTO, it's better to have mentor. Proctoring, we have a lot of CTO operator now, very well trained in all countries. Just call him, be with you in the first 20 cases. Then it will be easy. He will teach you all the tips and tricks of this long operation, long experience.
Yeah, Khalid, I liked your presentation very much. The analogy with the pilot one I'm using always. It's up to the flying hours. There will be not the same the pilot flying 10 hours with the pilot with 10,000 hours. So, and the complications are not acceptable anymore because, as you said, we have gone through all these complications, and doing it again and again with so many experts around and willing to help, and doing a complication is not acceptable. You are very right in that. And yeah, thank you very much.
Okay, thank you, Khalid. Now we'll close the session.
Thank you.
And move on to the next session. Thank you.
Thank you very much, chairpersons, Dr. Sudhir Rathod, Dr. Saket, and Dr. Srinivas. All said good. We have 92 to 95% success, but some percentage to reach 100 is left over. What is it? Let's know it in this session. So may I invite the chairpersons, Dr. Wataru Nagamatsu, Dr. Pramod Kumar, Ravi Kumar Alluri, and Dr. Gautam Swarup to join the chairpersons. And we have got three speakers, Dr. Vijay Trayahan, Dr. Gerald S. Werner, and Dr. Anil Dal. Thank you. Chairpersons.
First speaker, CTO PCI complication, Dr. Vijay Trehan. Sir, you do robotic CTO PCI, sir? You do robotic PCI CTO?
Is there a question to me or? Okay. So, I think this gentleman, history of angina, couple of months, more so for last couple of weeks, rest pains. And the story started after reviewing this retrofill. Guide is not very good. Supported with a balloon, his whisper is walking into the lesion, walks for a while. But distal to the tip, you can see the calcium. So there the whisper is trying to find way, and suddenly the operator loses control. Control over the wire in the sense, trying to talk, doesn't get the transmission, pull push, gone. If you see carefully the guide, you find the wire moving up, but the tip is not moving. Oh, what's this? Watch. This is a wire there, and there the wire goes up out of the guiding, but the wire in the right corner is there only, fractured. Now, the guide catheter is hanging just outside the os. Guide wire obviously is fractured, in fact transected, not elongated and fractured. The proximal end of the fractured wire is at the RC os, very precariously placed, just inside the guiding catheter tip, and there is a balloon extending into the RCA for a couple of millimeters. Distal end of the wire, I'm not very sure whether it is impacted or not. Sometimes the wire is impacted and then gets fractured. At times the wire may not be impacted, still may get fractured. New wire it was, whisper. Now, if the wire is fully impacted inside the right coronary artery, then if you pull out the balloon, everything will be fine. You just pull out the balloon, and all what will be left is a wire there, and we see the wire is fractured almost close to the RC os. Should be nothing, it should be just trivial thing. You leave a fractured wire in the right coronary artery. But if the wire is not fully impacted and is rather fully free, then if you pull out the balloon catheter, the fractured wire might start getting out of the RCA for a while. It may get out totally, or it may get out only for a while, and then the balloon gets out, and then the wire may be free, and it may fly out across to the left coronary or into the brain. That may not be forgiving. So what to do?
Trap it. Trap with the balloon, everything, trap it.
Put another wire, put another balloon.
Monby.
So,
he said trap it. Any other thoughts? Quick thoughts, because time is running out.
Maybe balloon trapping have the good power for the throughout these guide wires, I think.
So generally what we think is
twisting the wires. Twisting the wires. Take one more wire, twist it out.
The general thought is that you cut the hub end of the balloon catheter and advance a snare over it to catch the wire just beyond the tip of the balloon, which we normally do. But if you look at the kind of seat of the guiding catheter and the wire fracturing just close to the os, I think it is a very, very precariously placed situation, and the moment you try to advance anything over it, my experience says that it's possible you may catch it, but there is good chance that you will just lose it out of the tip of the balloon. Or as suggested, just pass a balloon alongside and trap it just near the tip. But even this may push the guide wire out of the guiding catheter. That's what I said, that you can take a snare.
Could take a snare or another ping pong catheter. You release the resistance point of the wire.
We don't know what is the resistance.
Oh,
what
we do not know. This is another thought.
The operator is trying to torque the wire, the torque is lost. Trying to pull the wire comes out. leave some wire in the right corner.
Yeah, so we can measure the length of the wire outside the
No,
body.
we have seen it.
Quite.
It is just a transection. There is no elongation of the wire. And
Okay.
what is left is about 3 centimeter piece.
So examination said it is a snap.
Yeah, snap loop.
It is very unlikely wire tip is entrapped, because wire tip is entrapped, it should be elongated rather than broken. Very unlikely. It's not possible to say it's actually not entrapped. But the way it has broken down, it seems unlikely to entrap the tip.
Whisper wire is relatively notorious to snap.
He has mentioned that he has examined the wire, it was a snap.
Yeah.
It was not
that's
unraveling the wire.
So that's why I'm saying it's not trapped. That is why I'm saying it's not trapped.
So, what we thought was, we can trap the wire inside the balloon itself into the wire lumen. And how do you trap it? You must have seen sometime, if the balloon is inflated, it grips the wire. If balloon is inflated and now you try to move the wire will not move. So I thought this might work. Just inflate the balloon, and also to make it more effective, make a mechanical couple. And how do you make a mechanical couple? Is a reverse Nanto, that you put a suction 50 cc syringe at the proximal end of the balloon, which is supposed to be the wire lumen, and then make a strong suction. So now what is happening is, it is trying to suck the wire, and inflated balloon is trying to trap the wire within the balloon lumen. And with a strong suction, then I thought, let's just try to pull, see everything is coming out. And Dr. Chawla was absolutely correct. Dr. Chawla was absolutely correct. He was correct from the angle that the wires, when they do it like this, especially if they snap, they are generally because of an over-rotation. And in fact, this is a preventable complication. And if a wire is trapped, they usually try to lengthen. Anyhow. Yeah, same routine balloon.
This is a rapid exchange balloon, right?
Yeah.
How do you do the negative this thing syringe pay? Negative suction.
You apply a negative suction, which is, I don't know whether it worked or not, but we applied it. Sometime, if you apply a negative suction in the system itself, then as you are trying to pull, there is a tendency for things to get in. There is no harm in applying it.
There's no harm, but how it works, that's all.
You can use the penumbra system.
So,
if you have penumbra,
now this was
a lot of negative pressure, but the manual is also. Right.
It could be swallowed out into the guiding catheter. A bigger balloon will it happen with a bigger balloon? Well, a bigger balloon will also do the same. It will catch it, of course, will not come into the guiding catheter. It will come down into get out of the coronary. You can have it at the groin. Now, if the above trick fails, and that will fail if the wire is impacted, then the problem can be there. And but we thought that in case the wire is like this, no issue. In case the wire is like this, again no issue. But if the wire is out, or if the wire is dangling like this and moving with the stream of the aortic blood flow, then of course we'll have to have a snare going up, catching it and pulling out everything. Just leave it. So we were talking about bailout. Donor artery thrombosis, I think wrongly called, because arteries don't thrombose. More often it is a thromboembolism into the donor artery from the guiding catheter. And this is a usual story. Start CPR and suck the thrombus. I think the best thing to suck the thrombus is a guide. Something which injected in, you just push the guide in and apply a very strong suction. You may use a thrombosuction catheter, and as Hazra was saying, somebody has an advantage of having penumbra on the board. That might be a little more efficient. And no doubt, the only way to support the circulation and oxygenation will be ECMO. But I don't think there is any trick or any bailout which can be consistently repeated. This kind of a scenario, I think most of us who are into the business will know that the moment you get into a trouble like this, you don't know whether you will be able to really get out or not. And even if you are able to salvage, how good or complete salvage is going to take place, I'm not very sure. So I think message here is not how to bail out. Of course, we try to give too many drugs, intracoronary, ADR, 2p3, and sometimes thrombolytics also. But what message I want to give is that if the donor artery guiding catheter is like that for some time and the ACT is not very high, then you can have things like this. It is seen because you shot it with the dye around, but if you don't shoot it with the dye around, you just flush it, you will not see it. What you will see is hemodynamic collapse. So the operator got the opportunity to suck it out, and that's what it was. So I think most important thing is, rather than trying to learn a trick to bail out, prevent. Very, very simple thing. What is somebody in the cath lab who you think is the most useless person, cannot do anything, just put him to the job, keep measuring ACT and keep telling us, like a cricket umpire, ball 1, ball 2, ball 3, and ask him to keep pushing us if the ACT is down. Then pressure waveform. Lot of clinicians see pressure waveform. I see the dicrotic notch, fine. Stupid. Many a time we take big guiding catheters, 7, 8. If you take a 8 French guiding catheter, you put a 6 French sheath into it, nothing will happen. You will get a good dicrotic notch. Many a time the thrombi are there into the guiding catheter for a long distance, and yet you have a very good pressure waveform. So don't get fooled by pressure waveform and say that, oh, nothing, no wrong, nothing wrong. You can have a big thrombus in the guiding catheter, yet the pressure waveform may be good. So if you have any suspicion, either from the pressure waveform or sometimes just on the table, you put your hand, you find the blood is kind of sticky, and you ask for the ACT, and ACT guy tells you it's 270. I think it is good to be paranoid. If you are in a position, change everything, change the guiding catheter. But if you are not in a position, you have walked through with a microcatheter in, then I think pull your guiding catheter into the descending thoracic aorta, suck, flush, do whatever. And if you want to put it back into the coronary, put your ears, hand here like this. I will not inject through this. Let the gears go out, because gears walking out probably don't take the thrombus with it so much as is injection, especially a powerful injection. Now, this kind of problem, or here, if you see, it has been already stented from the os with star-like result, TIMI 2. I think it is stupid to think that you can have some interventional cardiologist who can bail you out of these situations, because you might have down AR and up carotids. Surely these patients will be bailed out surgically only. So, to think that I will give you some trick for these ghastly complications, I think the trick is avoid aggressive guiding catheter, use guide extensions. Here, this vein graft, which was intended to be used as a conduit for a retro, power injection led to evulsion. Some of the vein grafts are weak. If you do a power injection, it led to evulsion of the vessel. Bailed out by putting a coil, but that power injection again caused same thing opening up. So, something which you get bailed out, but the cause was power injection, the power injection overcome that coil and again open that evulse part. So, message is hesitate or stay away from power injections. I think this has been shown in many conferences, that sometimes this is IJCTO which was done retro, and after completing the procedure we found that there is a dissection at the dissection by the guiding catheter catching the circ near the LM, and the real reason, if you see on the right side, is the guide getting sucked into this donor guide getting sucked in. And typically how it gets sucked in is, after you exteriorize the wire, then either you trap it or you catch it with a snare and you pull it. Now the moment you are pulling, what is happening is your guide will dive in. Not only the guide dives in, you will get a wire into the branches, into the septal, especially if it is not covered with a microcatheter, will slice through the collaterals. So here, one must remember that never do this thing. The donor vessel should donate. Let the donor donate. Keep pushing through the donor, and do not let the recipient snatch away. Don't pull the recipient, and that means the recipient vessel, no gear should be pulled from that side. Now here, a mid-RCA perforated at the site of CTO after stenting. It was bailed out by a covered stent, but watch carefully. Well, not oversized. This tent is not oversized. So what was perforation? Remember, bailing out can be done by a cord stand, but avoid. And how do you avoid it? You must know that many of these CTO segments are negatively remodeled. And so it is better to undersize. And in fact, don't even try to rely on IVUS. Many times an IVUS, especially in the subintimal space which has been enlarged, will you give a wrong or a false oversize. And if you are sizing according to the IVUS, even then I think it will be an oversize and lead to perforations. And especially in elderly, frail ladies, one must avoid this thing. I think before I finish, I was in the aircraft and I was thinking, what fantasy can you have as far as CTO complications? So I pulled out of my laptop, this case, and all of us know that if there is an hostile CTO, we must be very, very sure as you are coming retro, so that you re-enter not in the LM. If you have re-entered in the LM, you should counter-check by an intravascular ultrasound. And if you have not counter-checked, then this intima might get pushed to this side, and by ballooning or by anything, this will get further in front of the circumflex. So I was just worrying and thinking that a lot of us are doing CTOs and not many of us have intravascular ultrasound with us to confirm it. So what in case you are getting back? See, anybody will say that re-enter into the LED. If you put a stent here, this will be the story. So anybody will say that you re-enter into the LED like this. But this re-entry is not always possible. Many times, and all of us know that your wire control may not be so much that you re-enter there, especially once you have made flaps. It is possible that your wire is just walking to the subintimal plane and breaks out into the LM. So what if you are not able to control? Anybody?
You must take a guide extension to protect the lapman if you have a lapman CTO proximality, if you go with it. Huh?
That, of course, everybody will do, surely.
So guide extension.
So if you put a wire and you have a flap across, then it will be like putting a stent graph from LM to LED.
Just a minute, sir. Just housekeeping. If you talk like this, the other end wouldn't be able to hear you. Please talk to the mic.
Master is here.
Thoda mehnat karo, yaar.
No, you put guide extension. Best is to receive the retrograde wire into the guide extension into the LED. So that will not make a flap over the LCX. Yeah, and put another protection wire.
Your retrograde wire has entered the guide extension, and the guide extension surely will start from the guiding, which is outside the LM or into the LM, and then it will walk through the LM into the subintimal space into the LED.
While you are doing anti-grade preparation, must be sure that guide is in, the guide extension into the LED lumen, 2 lumen.
That you cannot be very sure. In fact, once you are coming retro, that means you are subintimal almost.
Dr. Trehan, my friend wants to make a comment. Yeah.
Okay, thank you very much. And these like retrograde guide wire crossing that may have the risks of creating a dissection after left track. This is like situation we have to prepare the reverse cut from the antegrade. Yeah, this is the key point, I think.
See, actually, I was saying that most of us are two-eyed. We don't have a third eye in the form of an IVUS. And what I'm saying is, in case you are suspecting.
So the best way is to prepare antegradely and decide where you want to do the reverse cut with the guide liner extension. It will basically avoid to this kind of the complication. Guide extension reverse.
Okay, let me complete my fantasy.
And the IVUS guided is one option. Yeah.
Let me complete my fantasy.
You still have more.
I was doing one case.
The time is up.
And
time is
just okay. 1 minute. We are already late by some 40 minutes. We've been waiting. So I thought if the flap is there, so I should put a cutting balloon size to the left main. If I have a cutting balloon size to the left main, not getting into the LED, I'm sure I'm going to create fenestration in the flap. Flap is not going to stay the same. And then that will make a way. If you put a stent, then what will happen is you will still have flow. This will not be like a covered stent. This is something like lampoon or basilica, which a lot of our structural people are doing nowadays. So you create a rent in that flap, which is supposed to come in front of the circumflex. And of course, sure, as was pointed out by Yadav. We'll have a wire already in the circumflex, just in case we have an error. And I think after creating a fenestration, if you go across from LM to LED, there should not be any problem. So thank you very much for your time.
Thank you. Great. I think time is running out and time is precious. We cannot buy it in the open market. Anyway, thank you, sir. So now we are moving to the next talk. Dr. Gerald, Dr. Warner, you know, radiation is very important. You have robotic PCI, you have RAMPad, RADPad. The best way to protect from radiation not to do PCI. Over to you, sir.
Thank you. And your introduction is right to the point. We develop protection devices from radiation, but the problem is the source of the radiation. And I'm happy that at least a few people, a good crowd is still there. Not only fellows, it's also a topic for the senior operator. I have no conflicts here. This patient is the only one I personally encountered. It's not my patient. I just had to operate on him after someone did 25 grays on his skin. Skin injuries start above 2 gray and are cumulative injuries. So if you bring back patients for repeated procedures, they don't recover. They have a memory. They appear several days or weeks after the procedure and go unrecognized if you don't monitor for them. To protect the operator, we heard new devices, reduce scatter radiation. I come to that at the end of the talk. But also you need to protect the staff. Like Manos Brilakis, if you see him work, he is behind his wonderful clock, which is suspended. But all the other people around don't have the luxury. So better work to reduce the source of the radiation. This is a paper, an old paper in Japan, where they looked at different institutions. It tells you different institutions, different operators had different levels of radiation, and 2 out of 72 patients had skin injury. Technical factors were frame rate, projection plane, and so on. But on the other hand, we find a very well-cited paper, 2013, where radiation injury is 0, because you cannot do a multivariate analysis when data are not reported. That is simply not true, that there is 0 radiation risk. And we, as the operators and your staff, are under stress. Unexposed staff in a cardiology unit, staff in the interventional cardiology unit. 4 times more skin lesions. Orthopedic, okay, you can say it's the lead apron. Cataract, 5 times, no, I cannot calculate later. Higher thyroid, so it's a big risk to your occupational hazard over years. And we know all these anecdotal reports about left-sided brain tumors in interventional radiologists and cardiologists. The determinants of skin dose and also of the radiation to the operators are complex lesions, multiple lesions, but the highest is occluded lesions treated, and also if you use the lateral X-ray plane, which is hardly ever used because we have the radial access and you cannot do lateral, which is quite nice. But it also tells you, this old paper from the US, that with experience you reduce the radiation. But as a fellow, you should start with the experience of your elders and don't start with high radiation. And rightly so, radiation has become one of the 3 reasons to stop a procedure in the algorithms for CTO treatment. Air camera above 5 gray, unless procedure well advanced. And if you look at the mid-2020s and 10, the radiation at that time was quite high. Record, Sudhir Rator wrote this paper from Toyohashi, 10.5 gray on average in the tiny Japanese population. There must be 20 or 30% of skin lesions in these patients. And later, it was reduced, but it is still high. Here, this is unpublished data from the EuroCTO registry. We looked at 14 operators over 10 years, And you see the operators per fluoroscopy time, per air camera. So there were some operators who managed radiation better, some worse. But after 10 years, most of the operators, but one, were really lower in radiation. Some upgraded their machines, some learned better techniques. And the excess of 5 gray, which was practically in every operator, was reduced considerably. Most of the operators never exceeded the 5 gray. So how can you achieve that? You should know what to watch. The radiation speed here, that is what you do on the German Autobahn, 330 with an Alpina. If you look at your radiation, you look at the dose rate. This is displayed whenever you press the pedal. Look at the dose rate, milligray per minute. And unlike on the German Autobahn, low speed is the goal, not high speed. So, simple things. It's old papers, 20 years old, that show the obvious. AP and REO30 have the lowest fluoro rate, or LEO40. Cranialization, caudalization less so, increase radiation. So you don't need to work always in AP cranial, just for decisive parts of the procedure, then go back to shallow angles. Simple, 45 degree LEO, 58 milligray per minute, 30 degree LEO, you can work the same, 20 milligray less. Simple procedures. Of course, everybody knows about the 7.5 frame rate is half of 15. In 90% of the cath labs I walk in, it's set to 15. Especially in the old Siemens machines, it's so difficult to change. But these operators, this is a study, a randomized study, they had still rather high radiation because they did cine at 15. So you need to avoid filming as often as possible. You should never film a stent or a balloon inflation, except for you need to see the expansion of the calcified, but that is an exception. Here, fluoro dose is 2% of the cine dose. These are comparisons, studies that compared different evolutions of the Philips system. The Clarity system was developed, but it was based on the old Philips. And you see here, this is Columbia. This is a study from Germany, that is a Milano study. All of them reduced the radiation by implementing the Clarity system, but to different levels. So how can you compare? This, for example, this is actually Professor Reifert's lab. He had incredible low 459 milligray, but his fluoroscopy time was only 16. So he was not so persistent at that time. So to compare this, you need to calculate the dose rate index. That's also what is written or shown on your machine. So the dose rate index, for example, in Columbia was 113 milligray per minute. It gone down to 33, so almost 1/4. Our own study in the RTC, the same machine, we reduced by modifying our protocol to 20 milligray per minute. That is published the lowest ever radiation dose, and that you see different steps in improving our system. And this is the main step, by reducing the cineangiographic part of radiation. And if you look at these two images, you can still see the collaterals, but this radiation is 6.2 milligray as compared to 45.8. And we never got beyond 5 gray, and only occasional, one patient actually got across the 2 gray skin dose. So all this achieved on an old RTC machine. New machines make it easier, and I got around a little bit here in India and I see a lot of nice new machines. But the as low as reasonably achievable principle is not always implemented. The machine is not the the first step. But the problem is also the companies selling these machines and setting them up. Look at website pages here from Siemens. All wrong. 15 frames for the Cine, 15 frames for the fluoro, and medium fluoro. And that is one simple step that you can do. Reduce to low fluoro. Low fluoro, 88 milligray per minute in one patient, as compared to regular fluoro, which is the normal setting in most of your labs, 70. Yeah? As compared to high fluoro, 37. Philips isn't better. Philips presents on the website 15 frames per second, and this is their dose. The dose rate index is 63.1 with an Azurion that has been achieved 20 years ago. Yeah? That is how they advertise the machines. In the Azurion, 3 steps you have to do. Press low, go to 7.5, and here, press low. And I show you an example from yesterday. And I think I shouldn't be feeling too bad if even I spend another 2 or 3 minutes. So, I did a case yesterday, an RCA CTO. And we did something particular, or the idea of my host was that the patient had a high creatinine. So the machine had the previous angio still there. So they just opened the old angio, and we started at the end of the diagnostic. So we had all the Cine runs there. So that is what we started with. The diagnostic used 5 minutes, almost 6 minutes of fluoro time, 436 milligram. The dose rate index, 70.8 milligram. I had to confess that the procedure took a little bit longer. You see, 15:11 until 18:09. It was a 3-hour complex reverse card with a lot of difficulties and a 8-year angiographically confirmed, probably older. But what air camera do you expect after additional 90 minutes of fluoro time? 941 milligrays on top. So we just had 600 milligrays for 90 minutes additional fluoro time. Dose rate index 5.7 milligray per minute. By going to 7.5, by going to low fluoro, and by not doing a lot of Cine. That's possible. And then we come to protect yourself from scatter radiation, but if the source is reduced, this is still valid, but not the main thing. For us, it's cheaper to put lead on the patient. And of course, this is zero gravity. You see Manos Prilakis working in this machine. Maybe he transferred it from US. We'll see tomorrow. Or people build up the Rampart system, and they even take off the lead apron and work just without lead. I'm not sure whether that is a wise decision. This is a recent study published last year with another system. I think there can never be too little radiation. What you should have learned in physics, X-ray cannot be eliminated, but only attenuated. So, let me finish. There is not, oh, you switched off the gong. The initial bilateral imaging to visualize a collateral in a CTO, that is the only time when I use 15 frames per second. Then I go down to 7.5. Pulse rate in my machine is 6. If you don't have 6, go to 7.5. Work with low dose fluoro protocol. The machine goes up if the patient is heavy, automatically. In case of bad images, change angulation slightly. Get the diaphragm out of the image. Never film a balloon or stent, just store the fluoro. Use low radiation angulations after passing the occlusion for routine steps of device advancement and so on. Thank you very much.
Thank you very much. Any comments from the course directors? No? Then I have few comments to make. Do you have in your mind the CT scan? Pre-PCI CT scan for CTO, you have some information. And second is a DCR, dynamic coronary road maps. And third comment, maybe in the future, you should have longer length of guide, longer length of balloon, longer length of PTC wire, so that you can stay away from the patients longer. So what's your thought on this robotics? You know, robotics cannot be done in CTO. So what's your take on DCR in your country, dynamic coronary roadmap?
If you use your machine to the optimum, you should still wear lead apron. We protect ourselves from scatter radiation. What you don't have here is a simple lower shield on the table. That is available with all the vendors. The lower shields extend with the lead, yeah? And the shield that you have in front of you, the glass shield, you put it on the patient so the lead is on the patient. This is mistakes I see every day in labs. These things are more valid and easily accessible, and CT scan. We recently did pulmonary embolism and atherectomy. The CT scan radiation to a pregnant woman was higher than the whole fluoro procedure of 35, 45 minutes because we use the same radiation for everything. The simple coronary is done with this. My EP guy works with this. There's no reason for excess radiation. Longer guides, good idea, because our patients in Europe get bigger. Not because I need to get distance. I hardly get a retrograde, 190. It's very difficult to do a retrograde procedure from the radial. But that's the point.
Okay. And I would like to point out this point and the accumulation, the accumulation, the exposure problem. So, and you are the based and the very nice expert CTO PCI physician. Maybe you receive the reattempt and the reattempt, and we have to estimate the accumulation.
Yes. Yeah, that's an important point that I mentioned, that radiation accumulates. For example, this patient I showed you with a severe skin injury, I did the procedure, it took a long time. What we did was we put gaze with a radiographic marker, and we looked at a projection that we never see the gaze. There was someone who said, put a red pad on this. That is the foolish thing you can do.
Right. So yeah. In future, thank you very much. I think you should have a lubricant which can radiate your radiation from your body to the patient and to the doctor. Now going to the safety protocols for complex CTO PCI, safety for the doctor, safety for the patient, safety for the hospital, safety for the society, safety for everyone. Safety is very important. Dr. Anil, that elegant speaker. Over to you, sir.
I guess this is the interest in CTO PCI, that despite the fact that everybody's got to go for dinner, etc., everybody's still here. I compliment Surya and his entire team, and also the IJCTO for a great show and a great fellows program. I don't have any spectacular things to say. We have to balance risks versus benefits, and we must be clear before we take on a case for foolhardy intervention that we are going to benefit the patient. Risk is limited to two domains, the substrate and the lesion. We should be sure that we are dealing with we understand the lesion, the ambiguity, the calcium, retrograde. Post-CABG has many, many issues, some of which were taken away by the intense discussion on calcific disease. You can have dry tamponade in a post-CABG patient. The substrate, which includes the age, the heart function, your collaterals get spread out and become straighter if there is LV dysfunction and LV dilatation. The axis, the comorbidities, these are the two major domains that are going to make our choices. We need to educate ourselves. We need to be convinced that we, despite all the fancy procedures, are going to benefit a patient. And we also need to be mindful, as Professor Bernard taught us just a little while ago, that we have to be mindful of our own teams, our institutional strategies. What are our weaknesses, our strengths, our protocols and training? Manus's slides, which I have taken, which are very, very clearly available, that for all complications, we must understand that things can go wrong. Murphy's law applies, but we must try to mitigate that, what can go wrong. We should not do cowboy-like things, and we detect problems before they actually manifest in a great measure and reflect on ourselves. And there are simple things. We must know ourselves, know our equipment, know when to quit, know when to press on and take risk, know when we are in danger, live to fight another day, and have a plan. We must adapt, fail fast, make progress. There are some aspects of CTO PCI which are like advanced access, optimizing support, guide wire strategy, plaque modifications. We all have to be adept in intravascular imaging, microcatheter skills, but more than everything, complication management. In performing PCI, CTO PCI, we understand we might have to do subintimal anchoring, some reverse wire technique, side branch manifestation. You need to have some amount of retrograde control, and you need to then apply your algorithms. And really, this has been discussed threadbare, but look at number 10. Consider stopping if more than 3 hours, more than 3 times estimated GFR, ml of contrast, and air karma of more than 5 gray unless procedure well advanced. We must examine CTO complexity well in advance, know whether it's a blunt ambiguous proximal cap, what is the occlusion length, tortuosity, are we going to finish at a distal cap bifurcation, what are the collaterals like, are there interventional collaterals, what is the calcification, whether it's a post-CABG patient, any previous attempt, circumflex, we can calculate different scores, the progress complication score, the open CTO registry, but we need to individualize risk assessment. Multitude scores are available which point out virtually the same thing. We can examine in retrospective data whether one was more important than the others. There are newer scores which are CTO-specific difficulty scores, and this was probably reported last year between LAD, circumflex, and RCA. We can give different points, but by now we have a sense that this CTO is going to be not really a cakewalk, but this is going to be very difficult. And we understand lesion length, calcification, tortuosity, landing zone, we need to respect it. We leave many things to our nurses. Our labs, proper IV access, blood availability, hydration, even bladder catheterization, and examination of the skin and talking to the family. Do we have all the setup in the checklist in the room? Emergency drugs, working defibrillation, suction, oxygen. Where is the IBP? Where is the echo machine if required? Where is the specialized CTO equipment, microcatheters, wires, re-entry devices, covered stents, coils, snares? How do we manage? How do we manage groin complications? Do we have a surgeon available somewhere? They never come to our rescue, but all the same, it's a consolation that they're there. And do we have a working ACT machine? Just last week, I did not have protamine. So you need to also discuss pre-procedure team discussion. We are as weak as our weakest link. We must involve all the attending, the fellows. Everybody should be involved in trying to see, because by failing to prepare, you're preparing to fail. And we must update, benefit in real time. It's like the Indian elections. Everybody was monitoring, who's got more seats, who's got less seats, or an IPL match. We need to know, what is the likelihood of success? Is the patient getting agitated? Are we looking at the hemodynamics, the oxygenation, radiation, contrast? Professor Werner just pointed out. Have I done anything to the vessel which I'm concerned about? Have I exited the architecture? Look at the VPCs. What about the donor vessel? What is my exit strategy? Am I going to leave an investment procedure? Or am I going to come back with either a surgical option or reattempt with more experienced operators? Maybe we get Dr. Nagamatsu here. Even experienced labs need help in complications. Remember, it's not your index complication which kills the patient. It is what you do after the index complication which can kill the patient. We have to practice, teach, assemble a kit run a drill and run from algorithms and other complications. A lot of checklists, ischemia, rhythm, how does, we all have seen Vijay Trehan showing us that guide catheters. We in India use Oxford guides. And Oxford guides without monitoring ACT over a period of time with stagnant flow, and suddenly somebody does a power injection, lo and behold, you have thrombus everywhere. And disaster follows. Air embolism, atheromatous embolism, rhythm, we must be mindful of Brady and Tachy. You're using long-length guides and powerful guides, and you're creating an acute AR, or you're causing a circumflex ischemia and creating an acute MR. Your patient is going into pulmonary edema. There is if not a perforation in the coronary which you're looking at, look at the access site. Your groin may have just become a football or a basketball. Their universal algorithms need to be practiced. You need to practice it in mind, body, and soul. You need to first inflate the balloon, look for supporting blood pressure, pericardiocentesis, and look for the cause, whether it's a large vessel perforation or a distal vessel perforation, and have a perforation kit which is actually ready, not look for it at that period of time. There are various algorithms which have been described in literature for both main and distal vessel or collateral perforation, and we need to understand how we can apply them. All perforations are not created equal. 8.9% CTOs half required treatment, and if you look at it, retrograde procedures, especially using epicardial collaterals, are notorious. We all have an equipment wish list, but we must look at this list and see what is the missing component, and also our technique and expertise, because we must not, as somebody said, that we must not start with the most complex epicardial collateral as our first retrograde procedure. We must study the angiogram. We must detect complications. Make haste, but avoid the second or third mistake. If everything goes well, all is well. Something goes wrong, you need to bail out, because bad things do happen. Bleed, tamponade, MI, emergent CABG, loss of limb, stroke, death. And you must know when to call for help. Manage yourself. Follow these steps, and if something bad happens, there are phases of how we accept it: denial, anger, bargaining, depression, and acceptance. And we very clearly move very quickly from denial to acceptance. But we must reflect. We must understand what happened. What is our response? What should our response have been? And we must be kind to ourselves. We are as weak as the weakest link. Let's build teams. Let's protocolize response to uncommon complications. Learn from every complication. We must know when to stop. And this has to be our judgment. We must, as has already been said, reduce exposure to injury, radiation injury. We must look at, and definitely at 5 gray, we must sensitize the patient. If you are staging a procedure, 4 to 6 weeks for a different vessel, 8 to 12 weeks for the same vessel, we must mark skin lesions, as Professor Werner has suggested to us. We must give radiation discharge instructions. Yes, cancers happen, but there is a long latent period. We must look at contrast volumes and contrast nephropathy. Everybody is not a Pratap who can do a reverse cut with zero contrast. Most of us tend to go a lot heavy on contrast, right? So we must be careful about it. There is no virtue in being a cowboy, or in this case, even a cowgirl. It is the highest risk elective coronary procedure. Having a broader skill set helps us identify and mitigate risk, but also emboldens us to take high-risk procedures, continuously update the likelihood not only of success, but of things going wrong. Stopping is not failing. Harming a patient is. Let's be focused and be present. I think I've finished in time.
Yeah.
Thank you very much.
Thank you very much. I think, end of the day, if you really want to listen to we really want to know how the philosophy of CTO or any complex PCI is progressing, you must listen to the song of Kenny Rogers. Kenny Rogers, a gambler. You must know when to pack them up, when to go out, when to walk out, something like that. Now, there is a new concept of protecting your back from the egg nest. And in the future, I think that in last 30 years of my practice in cardiology, one thing has never deceived me, cheated me, and saved many lives is the hemodynamics. So respect the hemodynamics. That is the one most important thing for your safety. Hemodynamics, that is the best thing. Any comment?
Okay. Thank you very much. A very excellent lecture. So the one kind of the principle that for the manage the complication is one, is anticipate. Number two is the prevention. And number three, the prepare the better technique.
Okay,
Yeah.
hemodynamics, anticipation, preparations, and treatment of complications. What's your take? Don't do PCI.
Definitely, it is for the younger fellows program, and you have to start the CTO program. Definitely, you have to careful angioanalysis. You have to have the bailout strategy in your mind, because everything in the coronary is most of the time it is predictable. So if you are going slow, predict the easier lesion to start with, and predict definitely the bailout strategy and the armamentarium. It should be in your cath lab. Then only you can start the.
And be humble, respect your mentor,
Yeah,
the teachers.
be humble and staying calm.
Yeah. And at two sides, MLCTO and TCTMD, you will get a lot of archives of CTO. Thank you very much, course directors,
Also
for
do
giving me a
remember
chance to
today's
chair.
companion
Thank you.
lectures of CTO PCI, and that will take all the measures to a higher percentage. We have one more session. Ladies and gentlemen, esteemed faculty, please be seated and join for the one more session, that is connecting the dots with Incileran, LDLC, variability and adherence in ACVD. May I request the chairpersons, Dr. T.N.C. Padmanabhan, Nitin Kavra sir, Dr. V. Dayasagar Rao, and Dr. B.K. Shastri to please come over on the dais. One more session is there. Kind of. Yeah. And Dr. M. Srinivas Rao sir can come over. Yeah, Dr. M. Srinivas Rao sir, he is here only. Dr. Shastri sir can please join on the, Dr. Srinivas sir, please.
Good evening to all of you. Can I start, sir? I think it's past the dinner time as well. Most difficult time to speak and most difficult time to listen also. So my today job is to tell something about prevention. We had a host of those beautiful lectures as how to deal a established cardiovascular disease. It's also important that as a cardiologist we prevent the disease as well. And one of the most important thing that we see one of the most important thing for the development of cardiovascular disease and its progression is LDL-C cholesterol. And while we are trying to address the problem of LDL cholesterol leads to progression of cardiovascular disease, it's also important that a lifetime reduction of LDL cholesterol is achieved so that we can get best prevention in the patients. But unfortunately, most of the times when lipid-lowering therapy is adapted to patients as a prevention in the primary status or a secondary status, there is what is called as variability of LDL cholesterol, which is also an important fact that we need to learn and try to prevent that. And one of the most important thing what happens when the LDL cholesterol is variable in its content is the poor adherence to the lipid-lowering therapy. And when we look at what we call the data that we see in ACS patients, when they are admitted to the hospital or undergoing a intervention, about 1 in 10 patients actually have a recurrence of events of MI or stroke or CV death when they are actually getting discharged in the next 100 days. And about 10% of them in 1 year, they also have recurrence of ACS and readmission, death or MI. So that is why they said LDL cholesterol has to be brought down to a drastic level of less than 55% in patients with high-risk patients, and extremely high-risk patients who are having cardiovascular disease risk factors, they must have less than 40. And unfortunately, what happens is when we are trying to reduce the cholesterol to optimal level in this group of patients of extremely high risk and high risk population, The data shows from real world data that 80% of the Indian population do not achieve this LDL cholesterol reduction, and the reason for that is multifactorial. And if you look at even those 70 milligrams percent also, it is less than 50% of the patients who achieve such a goal. And this is not true that it's only India has this problem, but even the Western European data like the Da Vinci data as well as Sentinel data also shows a poor adherence to the lipid lowering therapy and poor response to lipid lowering therapy when they are given a lipid lowering therapy in these patients who have ACS or patients who have got high risk features of risk factors in them. So, what is the LDL availability? The lifelong reduction LDL cholesterol to optimal level imparts a beautiful reduction in the cardiovascular events. That's very important. That is backed by a number of studies, whether it is a genetic studies, whether it is a epidemiological studies, or whether Mendelian randomized trials, or maybe a randomized clinical trials. All of them show a lifelong reduction of LDL cholesterol without much variability imparts a very good protection against progression of atherosclerotic heart disease or vascular disease. Now, when you have a patient who has got a variability in the LDL cholesterol content as the time passes on, but every one standard deviation of increase in LDL cholesterol variability will have a additional risk of any coronary event about 16%, cardiovascular death by 23%, and a stroke by about 17%. And on contrary, if you have a non-variability of LDL cholesterol in a patient with a robust reduction in the cholesterol, that leads a reduced risk of CV events and all-cause mortality. This is the important point that we need to know. And why is it that there is a variability? That's most of the time it comes because of the complexity of the dosing that we are giving, the number of pills that he is taking, or too frequent dosing that happens. Even in those monoclonal antibodies what we are giving the patients who attain a LDL cholesterol to a robust lower level, even there a biweekly dosing also becomes a burden in patients who are taking for a near lifelong therapy. So, new molecules which require a infrequent dosing like inclisiran may probably an answer to this kind of LDL variability when because not only inclisiran decreases the cholesterol to robust level but also decreases the LDL cholesterol variability in them because it is infrequent dosing that we are taking once in 6 months. Now, when lipid lowering therapy is not adopted properly and leads to ethical variability and infrequent, and then when the patient is not continuous lowering of LDL cholesterol to optimal level, what happens is that there is a loss of this good effect that we see with the statins or other lipid lowering therapy, and he is likely to have a much worse progresses in them. So this is where we need to adapt ourselves, and the data is not just imaginary, but if you look at the real world data among the patients with almost 5.4 lakh patients who have been have patients with high risk for CV events because of multiple risk factors which are in their background, only 15% of these patients were actually given a lipid therapy in an aggressive manner, and about a quarter of them actually have been downsized to their dosage from the aggressive lipid lowering to moderate or average or low level regimen. And worst of all, about 50% of them actually have discontinued the therapy in 15 months. That this kind of what you call a lipid variability or improper dosing of the statins or lipid lowering therapy may lead to a worsening of the events and progression of atherosclerotic vascular disease. Now, look at these 3 examples what we have. This is, of course, imaginary patients, but with our common patients what we see. One scenario is a young man who is actually had a PCI for non-STMI. He had received rosuvastatin and ezetimibe, it was 40 milligrams, ezetimibe 10 milligrams, but still continues to have 154 milligrams of LDL cholesterol, which is there at the time of discharge, at the time of follow-up. And Mr. Ramesh, who is an elderly male who underwent multiple PCIs in the past 3 years, he has on rosuvastatin 20 milligrams and has also begun avalocamab, which is every 2 weeks. Although he has been taking avelumab with robust dosing of rovastatin, but still he has 88 milligrams per deciliter. And then we have another lady who is actually middle-aged, but he underwent multiple PCS. But here she has got a problem of tolerance to high doses of rovastatin, and she is only getting 20 milligrams. She could be upgraded to 40 milligrams. It's remestemcel added, but still she has a high levels of LDL cholesterol of 120 milligrams. So this is in contrary to what we actually preach with regards to lowering of LDL cholesterol optimal level. In those patients who are very high risk, we recommend about 55 milligrams deciliter by both LPA or Lipid Association of India as well as CSI. But in those patients who are very high risk, in Indians, we want to go them down to 40. But what's happening in this kind of high risk patients we discussed is none of them have actually achieved a proper lowering. In fact, this young man who is very busy would like to have a simplified dosage regimen, and then the middle-aged man Ramesh would like to have a dosing which is not very complex and not very frequent, because he is taking every 15 days one dosing of avelumab. And here we have this lady who is middle-aged, who is not able to tolerate a high dose of rovastatin because of side effects, but still she has a lot to have a reduction in the LDL cholesterol. Now, inclisiran is a new molecule that has come into the existence, which actually unique action. In fact, it is a small interface RNA which actually, when it injected subcutaneously, rapidly cleared from the blood. It's after 48 hours, nothing remains in the blood. It is undetected. It's all taken by the liver hepatocytes. It goes in the circulation and sticks to glycoprotein receptors on the hepatocytes, and then it rapidly gets in cytoplasm. It goes and interfaces with the messenger RNA, which is coded for the synthesis of PCSK9. And here where it is interfaced with the mRNA, which is coded for the synthesis of PCSK9, it is destroyed, and that's how the PCSK not synthesized, and it is not available for destruction of LDL receptors, and LDL receptors are in exuberance in the hepatocytes. This is how these receptors clear the LDL cholesterol very, very efficiently. This is how the mechanism of action is there. Whether we have any kind of clinical data, any clinical experimental data, or any kind of clinical trial data, yes, there's a robust program. That's what is the Orient program that's going on. In fact, many of these Orient trials have already been out. The one which is we are eagerly waiting is the Orient 4, which is a cardiovascular outcome trial. But nevertheless, Orient 9 and 10 and 11 are the ones which are actually specially designed in patients with high-risk nature, especially those people who have got a genetic problem of heterozygous female hypercholesteremia, and also patients with having established ACVD and Orient 10. And Orient 11 are those people who got not only established ACVD, but also the high-risk nature of risk factors associated. Now, with this data, it have found that when we have from 9, 10, and 11 of Orient data, there is a robust reduction of LDL cholesterol by almost like 50% or more when it is given subcutaneously. It is given in the day 0, and then 3 months, and later on once in 6 months, which in such a kind of infrequent dose, usually the patients are very well happy because of infrequent dosing. And this leads to a robust reduction of LDL cholesterol to the very optimal level. And then, although Orient 9, 10 and 11 are not the ones which are actually outcome trials with hard endpoints, but what we see with exploratory outcomes in this study is that 26% reduction in the MACE. These studies are not powered for any kind of cardiovascular outcomes. But if you look at exploratory outcomes, here we see there is a 26% reduction in the MACE, and then that shows even early in the early part of this Orient program, we still have a data to show that not only the LDL cholesterol reduced by them, but it's going hand in glove in terms of reduction in the hard endpoints as well. Now, from the Orient 8 demonstrated a long-term safety of this trial also, because the extension of Orient 8 trial, the maximum exposure of 6.8 years, with total inclisiran exposure of more than 8,000 patient years. There is a very good safety profile of this particular molecule. with no dose adjustments for that in advanced renal disease. You can do it in the almost like stage renal disease as well. And in the case of what you call a moderate or mild liver dysfunction also this can be used. There is no clinically significant drug interaction with this particular drug and no clinically significant difference in the efficacy and safety profile of patients who are tested positive for anti-inclisiran antibodies. It could probably produce in some patients in anti-inclisiran antibodies, but they are not of any clinical significance. And of course, it doesn't have any off-target effects other than reducing the LDL cholesterol. Now, 2 doses in a year to start with 0, and then the second dose at the end of 90 days, and then of course once in 6 months thereupon. And what's important is this is a simple injection subcutaneously. It doesn't require any kind of refrigeration when it's being transported. And this leads to a robust reduction, not only LDL cholesterol, but also because of infrequent dosing, the adherence to the molecule is much better, and LDL variability is much eliminated with this kind of a dosing which is infrequent. So, ladies and gentlemen, my colleagues, just want to highlight that the key takeaways of my particular presentation is that increased LDL cholesterol, as all of us know, is the cornerstone for the production of CVD and also vascular disease. And a lifelong reduction of LDL cholesterol is very much warranted. The quicker the reduction of LDL cholesterol, the longer the duration of LDL cholesterol, the lower the lowering of LDL cholesterol in any patient as a primary prevention or secondary prevention is very important. And this kind of LDL cholesterol level variability is dangerous. That should be avoided. And molecules like inclisiran, they exhibit very good clinical profile with a robust reduction of LDL cholesterol with the least amount of LDL cholesterol level variability. So, I end my presentation at this point and over to chairpersons.
I think we have a drug, or for that matter, a parenteral drug, that is very effective, although it's slightly costly, at least for the present. But for those people who are in dire need of reducing the cholesterol level, especially LDL-C, nothing to beat inclisiran as on today. It's much more powerful than the so-called antibodies to PCSK9. That is evolocumab and other monoclonal antibodies. It is important to realize that inclisiran works only if there are LDL-C receptors. In the absence of LDL-C receptors, like in homozygous familial hypercholesterolemia, it doesn't work. But it does work in heterozygous because there are still some receptors left in the heterozygous. Very effective but costly, but it is available in our country. So for those people who can afford it, and you have only 2 shots in a year, and then you can be happy, you can forget about taking the tablets every day. Thank you, Dr. Srinivas, for a lucid lecture.
I think, my take will be every doctor should protect themselves first. And this protection is going to come from this kind of vaccinations every 6 months. Most of the time, forget our meal, forget our breakfast, and forget our pills. But once you are taken this molecule for primary prevention or secondary prevention, you are protected all the time, all the days, all the months, all the weeks for next 6 months. So that's my take. So please think wisely, very deeply, seriously, whether you really want to take this medicine. I have taken this. I'm expressing my conflict of interest. I have taken it because I don't have any coronary disease. I don't have diabetes, no risk factor. But I believe the lowest is the best.
Actually, just word of this cost, what we are speaking about. Cost, of course, we are very much concerned about. But looking at the cost of monoclonal antibodies, what we have, evolocumab, compared to that, this is half as expensive. So if somebody requires a robust reduction of LDL cholesterol and not responding to conventional doses of highest rosuvastatin or atorvastatin along with ezetimibe, I think in order to protect the patient from increased cost of therapy, this will be half as expensive as monoclonal antibodies.
So what is your experience using this? How many patients you
I have about 7 patients as of now. Many of these patients are actually those who did not achieve the LDL cholesterol reduction. And because we have been trying to give bempedoic acid and as well as ezetimibe and as well as 40 milligrams of rosuvastatin, but still did not achieving their LDL cholesterol reduction. And these are the patients who had recurrent events. So we had to put them on this molecule. And previously they were on monoclonal antibodies, that is evolocumab, but because the cost and complexity of dosing, I had to change them into this molecule. And then there's a couple of patients who are intolerant to statins, and for them, of course, we have given this.
You used for secondary prevention?
Sorry?
It is like you used for secondary prevention after?
Yeah, all of them are secondary prevention. No, we don't. I mean, there are no side effects that we have so far seen, because my experience with the molecule is very small, because it's only since 3 months I've been using it. So my experience is very, very minuscule. And then from the data that we have seen from Western world, then there's not much, there's no serious adverse reaction to this, except that sting like side effect at the site of injection, but that's also very, very minimal. In fact, it is less traumatic than the monoclonal antibodies when we're giving. This is something like what you see with collection injection subcutaneously. And absolutely no side effects so far have been observed. So far.
Okay, fine. I think it is important to know that we still do not have any clinical outcome data with inclisiran. This is unlike the statins, where there is a lot of evidence, there is a long track, good efficacy record. The so-called statin-related myocyte symptoms is extremely rare. So discontinuation, as on today, statins are the first drugs. And if somebody is rich enough and then casual enough, he can take 2 injections and then forget about the drug. With the full understanding that both, inclisiran does not have outcome data. We really don't know what it is going to be. Hopefully that it will be effective, because all drugs that have reduced the LDL-C have reduced the CV events. That is comforting, but purely from the academic point of view, there is still a lacuna.
Yeah. But Mother Nature does not know how we achieve LDL cholesterol reduction, whether it is ezetimibe or statin or monoclonal antibodies. But as Dr. Asaur was saying, that we still are waiting for Orient 4 trial, which is an outcome trial.
Srinivas, Srinivas, you are my doctor. Yes, sir, no, you are my doctor. I take atorvastatin 80 mg and ezetimibe 10 mg. And I don't think I ever forgot. Maybe 1 or 2 days, my LDL cholesterol is 37. 37. I have checked 3-4 times, multiple times. Do you think I should take inclisiran?
I think yes, you should take. You should. You should. I mean, I sincerely feel you should be taking, because I know the kind of background you have. I think definitely you should be taking, because over a period of time, statins, of course, we know that incidence of side effects is very rare, but you have to wait. I mean, since you already got 37 milligrams %, you may not have to hurry to this, but the only thing is, as soon as the outcome data comes after the Orient, I think you can shift that time.
No, actually, I made it personal to make it more appealing, but in clinical practice, a good number of patients, if you give high-dose statins, ezetimibe, and nowadays bempedoic acid, a good number of them, it comes down to less than 50.
If you combine a high-dose rosuvastatin with bempedoic acid 140, that is 180 milligrams, your LDL cholesterol will come down by 60%. It is as good as taking a inclisiran injection. The only thing is that you'll have to take it every day. Whereas inclisiran, you take once and forget for the next 6 months.
Actually, sir, the typical patient with CID requiring hypercholesteremia, very often they are on other medications which have to be taken directly. So when I take medicines, it doesn't matter whether I take 3 or 4. Though many people complain, actually a person taking 3 or 4 pills, just gulp them, and I'm not sure.
You look at the real world data. The real world data which has been published, I mean, from the Western
No,
world
no,
as well.
I just want to
So
ask
that-
the audience here.
The data, sir, that shows about 5.4 lakh patients who are actually being treated by top class hospitals. How many of them will be given a high dose statin? Number one. How many of them are actually continuing with the high dose version? The doctors themselves actually, there is a kind of inertia to actually continue the high dose. They themselves are coming down to the dose, and those few doctors who are continuing the high dose with the patients, how many of these patients at the end of let's say 6 months, they are continuing high dose? Majority of them are actually not.
Da Vinci data, only 30%.
Yeah. So the data show that people are actually vexed of taking the number of tablets, because I know we are treating patients, we know how important it is, but I think 80% of the patients who come to OP, they always bargain, sir, kuch kam kariye. So this is what happens. So, and when you don't reduce, they themselves reduce spontaneously. And then if you don't reduce, they'll change the doctor also.
No, I just wanted to ask the audience, how many of the audience are taking statins for whatever reason? Can you lift the hands? I know. How many for primary prevention, how many for secondary prevention? Primary, yeah, I think everybody is taking it.
Madam Devi is taking. She wants to make a point, yeah.
Sir, when I was doing a webinar with Dr. What is his name? Arabino, who has done the primary research for the inclisiran, and I categorically asked him, when should I use inclisiran for myself or for my patients? He very categorically told me, madam, if you are taking high intensity statins and your LDL cholesterol is less than 70, then you should not take inclisiran. It is not indicated. That means when you are taking high dose statin, bempedoic acid, ezetimibe, for most of my patients, as you said, Dr. Shastri, clearly they are less than 50, most of them. And we have to insist them that it will be effective. It will cause definite improvement in their clinical outcome. Since they know it, they are academically quite good, they are all very educated. So they don't stop it. And we can reduce this dose also, these 3 drugs, gradually as they go with the good lifestyle modification. In spite of that also, if you are not able to achieve the LDL cholesterol less than 70 in long run for primary prevention and less than 50 or 30 in secondary prevention, then you are supposed to add on to this. It's not that you stop the drug and take this. That was very clear message given by the primary investigator.
There's a good article written by Eugene Braunwald who says how to live for 100 years without having an atherosclerotic vascular disease. It's an article worth reading because the concept is very good, because the concept of what we call LDL threshold value of 8 grams over a period of lifetime. If you can postpone that 8,000 milligrams over your lifetime, then you are going to postpone the atherosclerotic vascular disease. And that is obtained by multiplying your age in years with the LDL cholesterol level in the blood. If your score is less than that, probably you can still go slow. But if you are almost reaching the threshold, probably you should do it at a high intensity level.
Right.
I think it's an article worth reading.
So you know how much of what is the level of LDL in Dr. Braunwald? Anybody knows? 21. And Jagat Narula is 23. So there was a debate who will live longer. And obviously Dr. Braunwald was living longer. And the chairperson was Patrick Serious, one of the debate. Anyway, Jagat Narula is taking inclisiran. I'm saying
No.
Braunwald is taking statin, simvastatin after forestral, now he's on atorvastatin. That is, I'm on the Jagat Narula's talk, if you listen to Jagat Narula. So we still do not know what is the best LDL cholesterol at which all human beings will be spared from atherosclerotic cardiovascular event. That's it. Is lower is the better. So it's up to you whether you want to lower it by statin, by ezetimibe, by meditation, by yoga, by not eating, fasting, or inclisiran. It's up to you.
But to answer the query, see, we have we have open label extension of the studies with molecular antibodies. That is now it is about 8 years. Despite the fact those people who had less than 20 LDL cholesterol, nothing happened to them. Neither they had any kind of hemorrhagic strokes, not they had cognitive problems, not they had any muscle problems, not their liver problems. So the concept that if we go below 40, there's going to be a kind of red zone. It doesn't really not really true, because when you
have to conclude. Only side effect they had COVID. COVID is the only side effect of inclisiran because it happened during COVID time, this OLE. So thank you very much for your attention and attending the last portion of the meeting. Excellent, Dr. Rao. Thank you very much.
Thank you, sir.
Thank you very much, Dr. Srinivas sir, Dr. Dayasagar sir, and all the chairs. Tomorrow morning, 8 a.m., we are starting the session in Hall B1. And the main hall, the session starts at 8:30 a.m. Thank you.